Yes, Kishore, welcome.
Hi.
Yeah. Your volume is a problem again. The microphone. Change your settings. Microphone settings.
Is that better now?
Yeah, better.
Okay, can you hear me clearly?
4, 3, 2, 1. We are live, sir.
Okay. So we are live now. They have opened the link to the other delegates also. So please check in your Kishore. Just check your microphone settings once.
Yeah. Hello. Can you hear me?
Yes, I can hear you clearly.
Okay.
I think Dr. Palande has joined. Dinesh, is Dr. Palande muted by default or he's muted himself?
He's muted himself.
Okay.
Yeah. Hi, Dr. Pablo.
Yes,
Can you hear
unmute.
us? Yeah. Just can you hear us? Just unmute Dr. Pablo.
Dr. Palande.
I can hear you.
Dinesh.
Fine, thank you. Dr. Palande, sir. Deepak, sir. Yeah. Can you hear me, sir? Sir, Deepak, sir. Dr. Deepak, sir. Just unmute yourself.
Yeah, okay. Yeah. Hello, Dinesh?
Fine, sir.
Yeah. We can't hear you properly. You use a microphone.
Hello, Arnan?
Yeah.
Can you hear
You're better now with the microphone. Yeah, but okay, I think Dr. Basan Misra has also joined us. Just switch on your video, please. Dr. Mishra.
Video, Vernon, video will join in 1 minute.
Okay, fine. Yeah, your audio is good. Audio is fine.
Hello, how's my audio now, Vernon?
Yeah, better. You use the microphone only because the audio on your laptop is not good.
Yeah, now?
Good, sir. Good. Dr. Deepak, sir. Your audio
Yeah,
is
better. Good.
very good, sir.
Good, no? Okay.
Excellent. Thanks, sir.
Yeah.
Vernon. Vernon.
Yes, yes.
Yes, Pablo.
Do I have 2 minutes to refill my coffee?
Yes, of course, of course. No issues. Yeah.
It's supposed to be in 25 minutes when we are officially
2:30.
starting.
2:30. Yeah, 2:30 Indian time. Yeah.
Perfect. So I will be
Yeah.
here in 5 minutes.
Please do. Yeah, please do. Yeah.
I will leave this one.
Yes. Yes. Please do. Dr. Mishra, welcome. Sir, welcome. Mishra, sir, welcome. Can you hear us?
Vernon, I can't hear you anything. Your
Mishra,
voice is very
You
low.
can't hear.
Mishra sir, can you hear us?
Vernon, your voice is very
Can
low.
you hear the? Yeah.
No,
Can
sir,
you
your
hear
voice
the
is good,
others?
sir.
Good afternoon, Dr. Mishra.
Can you hear the others?
Sir,
Hello.
sir, we can hear that your voice is quite good. I think the Mishra sirs need to have increased their speaker level.
Yeah.
Yeah.
So just tell him to increase the speaker level.
Yeah, fine.
Send a
Mishra sir,
message.
can you hear me? Yeah, Dr. Mishra sir, can you hear me?
Send him a message to increase the speaker level.
Volume.
Okay, I will reply.
Hi, Varun. Good
Batuk,
afternoon. Yeah.
welcome, welcome. Good to see you.
Hello, sir. Good afternoon. Mishra, sir.
We
Dr.
cannot hear you.
Palande. Yeah.
Hear us. Yeah.
Palande, sir. Good afternoon.
Good afternoon. How's my voice?
Yeah. We have our dean who's also logged in,
Hi, Sukhdeep.
Professor Ranjit Mankeshwar.
Hi,
Dinesh.
Vanan, can you hear me?
Yeah. Good. Good. Good
Is it
afternoon.
clear? Good afternoon and all the best.
Hello.
Thank you. Thank you.
Mishra sir, can you hear us? Mishra
Dr.
sir.
Palande is there.
Dr. Mankeshwar.
Ranjit, Dr. Palande is saying hello.
Hi, sir. How are you,
Hello, fine. Congrats. I didn't
Hey.
know.
sir? Sir, it's a
Yeah.
acting dean's charge, sir.
Yeah, acting or anything. It's a dean is dean.
Thank you very. It's so nice to see you, sir.
Yes, very nice. Good.
Good.
Your volume is good. You're good to go. Indeed.
Okay,
Yeah.
I'll mute it then. Thanks.
Yeah.
Varun, you had a
Dinesh?
word with Kishore Shetty, no?
Yeah. I've told him also to log in. He's not yet logged in.
Yes, sir. Tell me, sir.
Just sort out Dr. Mishra's volume because we cannot. He cannot hear us.
Fine, sir. I will sort it. If possible, can I get a number of Mishra sir? If you can put in a chat, I will call him.
He's on the WhatsApp group. He's on
Okay,
the
fine,
group.
sir. Fine.
10th October group. अरे काय झालं रे तुमचं? हा? झालं? लाईव्ह आयपी वरती गेलो. उत्तर बरोबर. डिपार्टमेंट किती नेट पाहिजे? नाही डिपार्टमेंट नाही आया नाही. चार्जिंग बॉक्स किधर है? बराबर. My presentation there. What's the exact time? Rishikesh?
Yes, sir.
Rishikesh, where is Harish, yaar? He's supposed to be starting the show.
Okay. He just said he's joining. I just called him.
He has to check his volume, check the.
Yeah, I'll just call him back.
Yeah, you log out.
Hello. Huh. Huh. Huh? आता मी बिझी आहे, काही इमर्जन्सी नाही आहे ना? हां.
Hello, Dinesh.
Yes, sir.
I've changed my laptop. I've gone on to the Mac. I just want to check my share screen.
Yeah.
Can I go ahead?
कसं आहे ना, ते तिथे ऍडमिट आहे, त्यांना रक्त पातळ करण्याचे औषधं चालू आहेत. हां हां, तर कसं असतं माहिती का, रक्त पातळ करण्याचे औषधं चालू असताना जर ऑपरेशन केलं ना, तर मेंदूमध्ये मोठा रक्त मरून जातील.
Rishikesh, mute yourself. Can you see?
Yes, you can see. Your skin can be seen.
थोड़ा लैग है 5-6 सेकंड ऑडियंस के लिए ठीक है दिस इज ऑडियंस यू कैन ड्रैग इट फ्रॉम
Okay. Is the video clear? Dinesh?
Sir, very clear, sir. Sir, now your video quality is good, sir.
Yeah, because I'm using the Mac.
Yeah, it's very clear. Even though now your video and audio also has become quite clear, sir.
I've changed the net connection also.
Yeah, fine, sir.
Okay, I think it's fair enough. Yeah. So we'll just.
you keep this on first so whenever you will back
Sir, fine, sir. Everything's fine, sir.
Okay, fine. I'll stop sharing. Thank you.
Yes, stop.
Yeah. Has Dr. Mishra joined us?
Yeah.
Sir, on your camera, Dr. Mishra, sir.
So can you hear us?
Yeah, very well.
Okay, good. Good. Yeah. Is on the screen.
What has started here?
The video. Okay.
Is there arrow?
Rishikesh, Harish?
Yes.
Is Harish logged in? We got another, how many minutes? 10 minutes? 15 minutes?
10 minutes. Yeah.
Yeah, 10
He's
minutes.
not picking up the phone. I just called him.
Find out where is Harish.
Has Sukhdeep joined?
He has checked his presentation also.
Yes, sir.
We'll start with him only, no?
Yes. He's the opening batsman.
Okay.
For the day. This is a direct line. No?
बाद में कर लो ना.
सार्वजनिक ठिकाणी कमीत कमी 2 मीटरचे अंतर.
Vernon, sir, just unmute yourself.
Vernon. Hello, Vernon. Hello.
Sir.
My dear Vernon.
Yeah, hi, sir. He's muted.
Yeah. Hi, sir.
Hi, Vanan. How are you, my dear friend?
Great to see you.
You
Hi,
need a
Atul.
haircut? I can come.
Yeah.
Oh, Kishore. Kishore.
Hi, Atul. Dr.
Great to
Palande here.
yeah, Deepak. Oh
Yeah.
my goodness, Deepak तो
Yeah.
तो यार क्या घर पे?
तुम्हारा तो हेयर कट का सवाल आता ही नहीं है.
ये बात का सुरेश कैसा
Hi,
है?
bus fine, yeah. Good.
I can see Kishore on the screen.
Where is
Yes.
Kishore? Huh? Kishore is
Yes.
connected to us.
Yes.
Anyway, the one seminar of NSI just got over.
काय पे था? Intracerebral hematoma.
Intracerebral hematoma.
I think COVID is making everybody study more.
I know. Saturday, Sunday, तो like goes like crazy, you know.
बराबर. What about the Spanish young boys have not arrived? Batuk.
He, Batuk is there. Yeah.
Hello, sir.
Hi, Batuk.
Yeah, hello.
Hi, Batuk.
Hello, sir. Good afternoon.
Good afternoon.
Rishikesh.
Yes.
I think Paolo is trying to contact, you know.
Okay.
Sorry to disturb you, sir. You all are live, sir.
Sukhbir.
Yes, sir.
Hi.
Good afternoon.
Good afternoon.
Hi.
How's everything?
Hello.
Dr. Harish, has he joined?
I
don't. Harish, unmute yourself, Harish. Welcome, Abida. Welcome, Harish.
Varnan.
Dr. Suresh.
Abida, you are mute.
Yes, sir.
Varnan, you have to give how the program has to run.
Yes.
Okay.
Yeah.
You give the format.
Yeah, the format is first we would be having welcome. Dr. Harish is the compare. I will just introduce, then I will introduce the chief guest, our Dean, Dr. Ranjit Mahakeshwar. He's already here with us. He's already in. Then there would be opening remarks by our chief guest, the Dean, and a briefing of the scientific program. Okay, so the first session would be the anatomy session, where the moderators would be introduced by Dr. Rishikesh, and each moderator will have to introduce the speaker. And after the speaker finishes, question after the talk, only from the faculty would be okayed. Like the moderator can take some questions from the faculty, and the rest of the questions will be at the end of the session, sir, where each moderator would be given 5 minutes to address the questions in the question box in the same sequence. So then we will go ahead with the dissection section. That would be by Dr. Pablo. And after the dissection section, same thing, same protocol. Then it would be session 2. And there would be a dissection session by Dr. Abida, because we are still trying to get the net connections and all those things ready. So if that is ready, then we will have Abida dissecting. So that would be the layout. Can you hear me, sir? Go ahead.
Yes. Very well.
Dr. Ranjit, you wanted to say something?
No, everything is fine.
Yeah. Okay. Yeah. Professor Goel, this is Dr. Ranjit. He's the acting head of the PSM department and also our dean. So he does statistics for us, all our publication statistics.
Welcome to our show.
Good afternoon, sir.
And welcome to Neurosurgical. Good afternoon, Ranjit. Nice to see you.
Sir.
Where are you from, Ranjit? Which from Bombay or from?
Yeah, from Bombay, sir.
Okay.
The Bandra boy. Just like Dr. Palande, Bandra boy. Yeah. I think Dr. Mishra is also Bandra boy, if I'm not mistaken. Welcome, Dr. Nadkarni. Cannot hear you.
Mishra is an old man of Bandra, not boy.
No. By the way, Dr. Mishra,
bolo.
In Bandra, nobody gets old.
Okay. My dad was also a Bandra boy. So even at 75, he used to say, I'm a Bandra boy.
Yeah.
There are two. In this, it would be Mahim boy or Bandra boy, one of the two.
No, Bandra still is a lot of green, so I love it. That's a beautiful place, yeah. It's very lot of traffic, but it's a beautiful green still.
Welcome, Dr. Dev Pujari.
Welcome. How is it going? You starting on time?
Yeah, we are starting on time. Dinesh, you have to tell us when to start. 2:30 sharp, we start.
The NSI webinar ended just 10 minutes ago.
I know.
Much longer.
I was following that up also.
कोई फायदा नहीं है किसी को टाइम का बता के.
So I think we got 3 minutes to start. We start on time.
Yeah.
Dinesh?
Yes, sir.
Yeah. Can you tell us how many delegates have logged in?
Yeah, 1 second, sir. I will tell you.
Because I cannot see it here. I can see only participants, our participants. No?
Varnan, they will log in after 2:30, not at this time.
Okay. So should we wait for some few minutes?
Yeah. No, we should not start before 2:30 in any case.
Okay, sir.
Correct. Yeah. Correct. 2:30. Hardly 2 minutes remaining.
Welcome, Dr. Muthukumar.
Good afternoon, everybody.
Good afternoon. Good afternoon. Good to see you after the NSI webinar.
Yeah, just 15 minutes ago we finished that, so we have to.
So probably we'll have to give them some time to switch to the next webinar.
Have some lunch.
Yeah.
So grab some lunch.
That's good.
How are you, Dr. Palande? All well?
Yes, fine.
Varnan, they are the same people who are doing this webinar organizing thing?
Who?
The people the digital people.
Digital is Sun Farm. We are doing it, yeah.
And that was different actually. That NSI was
that was Baxter. Yeah, they were doing it on the WebEx. Here I think we are doing it on the Zoom because the number of that's what you were saying.
We tried with WebEx for 3 meetings. It turned out to be a very big problem. So we went back to Zoom again.
Yeah, because the more the people, then it becomes an issue on WebEx.
What happens is that the slides and the speakers lecture, they don't sync. They don't sync. It happened not once but 3 times. Then eventually we had to make the decision of going back to Zoom.
I think Zoom is the simplest one, and
I think Zoom is the simplest
so far. Yeah, absolutely.
This is on the cable.
Yeah.
Dr. Hemant Bhatia, welcome. Unmute yourself, please. Unmute.
Yeah, can you hear me now?
Yeah, good. Yeah, go ahead.
Yes. Good afternoon. How are you all?
We are good.
So about to start.
Yes.
I think most of the people have already joined, seems. Almost everyone.
Yeah, because I cannot see it from here. That's
right.
Yes.
Dinesh?
Yes, sir.
Yeah.
You can start, sir.
Are we ready to start on time?
Yes, sir.
2:30.
It's 2:30, no? Harish, you can take over.
Yes, sir.
Yeah.
Varnan, mute everybody. Mute everybody.
Please mute everybody. Harish only remains.
Okay.
Please start, sir.
Yeah, shall we start, sir?
Harish, go ahead. Be a bit louder.
Yeah, shall we start?
Yes, start, please.
Yes, sir.
Okay. Good afternoon to you all. So today we'll be having a live webinar.
What happened?
Harish has gone off the screen. Hello?
Sir, God might be disconnected, sir. You can take on, sir. Sir got disconnected.
Okay, Harish.
Yes, yes. Sorry for the interruption. There's some net issues. Okay, so good afternoon to all. Good afternoon to the faculty members and the speakers and all the delegates. So we'll be starting with the webinar. So this is a webinar on neuroanatomy, wherein different speakers all over like India and Europe will be showing us live cadaver dissection and also the brain fiber dissection. And then we'll be having in the second session the clinical neurosurgical talks by various speakers. So without wasting much of the time, hope we will be running on the time. And I request Dr. Vernon Vello, Professor and Head of Department of JJ Hospital, to formally inaugurate the webinar and introduce our Dean.
Yeah, dear friends, good morning, good afternoon, good evening to all from India and all over the world. I welcome you to this live webinar session organized by our department in association with the Neurological Society of India, the Bombay Neurosciences Association, and the Goa Association of Neurosurgeons. In this year, 2020, our institution celebrates 175 years of service to mankind. And so this program is being organized as a mark of remembrance of this special year of foundation. I welcome you all to this one-of-a-kind teaching and learning program, which has been amalgamated for the first time with a live cadaveric dissection course to make it more lively and exciting. And I feel this will be the future of educational programs in the coming times. Today, we have with us our Dean, Professor Ranjit Mankeshwar, who has consented to be part of this program in spite of his prior commitments and busy schedule due to the ongoing COVID pandemic. I welcome him. I now welcome our distinguished faculty of speakers from Europe and India who have a vast experience in their field, and I thank them for taking part in this live webinar. I also welcome our distinguished team of moderators who are well-experienced professors of neurosurgery and would be engaging the delegates in fruitful discussions and helping to clear their doubt. This program has been accredited by the MMC with 2 credit hours, and the certificates will be distributed after the program is completed. I also welcome our MMC observer for today, Dr. Kishore Shetty, who is also a GM site. Thank you, Dr. Kishore, for being with us. And we shall now, without wasting any time, have Professor Ranjit Mankeshwar, our Dean, to make the opening remarks. Thank you.
Good afternoon, everyone. On behalf of Grant Medical College and Sir JJ Group of Hospitals, on our 175th year, so this is a very special year for us, I welcome you to an international virtual symposium organized by Professor Dr. Vernon Vello, who is also the chief coordinator and speaker. It is extra special because this year marks 175 years for Sir JJ Hospital. And as you know, Dr. Vernon, everyone knows him. He's been very active in the field of neurosurgery and also regularly organizes seminars, virtual seminars and dissections and other workshops in Grant Medical College and JJ Group of Hospitals. I think thanks to COVID, this is the first time a live cadaveric dissection has been organized by them. So I would really like to thank, on behalf of the entire faculty of Grant Medical College, I'd like to thank Dr. Vernon. I'm also delighted to see that among our speakers, moderators, Dr. Palande, a former professor and head, and a Grant Medical College stalwart here. So without any further ado, I'd like to welcome all our international and national speakers, moderators and delegates, and I wish this international virtual symposium all the best. Thank you. Dr. Vernon.
Yeah, thank you, Professor Ranjit, and thanks for being with us. And I'd request
Dr. Harish to continue with the beginning of the scientific session. So before we start the scientific session, there would be a small opening prayer. If Dinesh is there, he could play it, and then we will get on with the scientific session, please. Okay, Dr. Harish, you can take over.
Yeah. So with the Goddess Saraswati's blessing, we'll continue the webinar. So I would request Varnat sir to briefly introduce the scientific program. So how the program goes ahead.
Yes, the scientific program will start with the neuroanatomy session first, and it would be conducted by Dr. Rishikesh. So, and followed by the question and answer session. Then we would be having the dissection course, and followed by session 2 and question and answer sessions. So my request is to all the participants, you can type your question and answers into the question and answer box, and the moderators would be given a time of 5 minutes for each topic to address all your questions. At the same time, if the faculty wants to ask questions, they would be allowed to ask questions after the speaker finishes. So Dr. Rishikesh, please take over the first session and introduce the moderators as well as this.
Thank you, sir. So good afternoon, all the faculty members, all the moderators, delegates who are logged in, and our chief guest, sir. So we begin with the first session of the scientific program. So the first session is about neuroanatomy and white fiber course. So for the first lecture speech, we'll have on cranial nerves and its applied anatomy by Dr. Sukhdeep Zawar. So the moderator for this session is going to be our esteemed Professor Dr. Palande sir, who completed his MBBS and Masters in Neurosurgery from our own Grand Medical College in 1985. Then he worked here as a lecturer and associate professor for the 9 years and 11 years respectively, and then head of the department. He was there for more than 15 years, and he has more than 50 publications to his name with multiple chapters in textbooks, national and international. He's a life member of Neurological Society of India. He's a life member of Indian Medical Association. He's life member of Indian Society of Stereotactic and Functional Neurosurgery, as well as Indian Society of Pediatric Neurosurgery. He's a life member of Asian Congress of Neurological Surgeons. He's a life member of Indian Federation of Neuro Rehabilitation, very actively participating in the neuro rehabilitation part. He's a life member of Bombay Neuroscience Association, and he's the man behind our meetings in BNA. So he is the recipient of many national and international awards. So I request Palande sir to introduce the speaker for the first lecture, Dr. Sukhdeep Jawad. Sir.
Thank you, Dr. Rushikesh, for that introduction. I take this opportunity in the 175th year of our alma mater, Grand Medical College and JJ Hospital, to welcome you all for this seminar. And this institute is a historical institute with many firsts to its credit, and many eminent workers, researchers have passed through this institute. Prominent being it was the place where Hapkin did his research and produced the vaccine. We have a lab in his name. Even Dr. Cox has worked here, and I'll not go with the list of all the first. That's a big list. I will introduce you to Dr. Sukhdeep Singh Jawar, a senior consultant from Apollo Hospital, Ludhiana. He has done his MCH from KEM Hospital and GS Medical College, Mumbai. He was an ex-professor of, associate professor of CMC, Ludhiana. He has done his endoscopy skull-based fellowship from Pittsburgh and microvascular fellowship at Fujita, Japan. He has got around 30 plus international publications to his credit, and he has got special interest in neuroanatomy, in cadaveric dissections and fiber dissections. He will enlighten us on cranial nerves and its applied anatomy. Over to Dr. Sukhdeep Singh.
Thank you, sir. Thank you for the introduction. And I'd like to thank at the outset Dr. Varnan Ballo for giving this opportunity to present my work here. So today the topic is a very interesting topic. I will be talking on the cranial nerves and overview. So as such, cranial nerves is a very vast topic. You know, every cranial nerve is special in itself, and they are very important. And if you can talk for a long time on each of the cranial nerves. So instead of covering one or two nerves, what I have done is I have made a crash course, or you can say summary of all the cranial nerves, because when you are dealing with the brain, mostly with the lesions of the brainstem, or you can say skull-based surgeries, you have to encounter all these cranial nerves. And the anatomical knowledge of cranial nerves is very important when you're dealing with these lesions. And of course, you know, when you know your anatomy, when you know how they are displaced, how they are related to vital structures, you can save them. And saving cranial nerve is also a part of a neurosurgeon. And they are not, of course, you can say these are not very essential for the life, but they are very essential for the function. So after the function, then comes the cosmetic part. So for a functioning human being, these are very critical. So I'll start. You can see this is the sagittal section of the whole of the skull here. You can see how these cranial nerves are related to various parts of the skull base. We have the first cranial nerve in the anterior cranial fossa, second cranial nerve, partially in the, you can say, junction of anterior and the middle, maybe in the interior, you can say. Then we have cranial nerves which are related to cavernous sinus, which are related to the motion of the eyeball. Then we have our cranial, fifth nerve, of course, is concerned with sensation and the mastigation part. Then we have the facial nerve. Then we have our lower cranials, which are very critical for our speech and our eating and all those things. So you can see these are related all our cranial fossas. So this is the overview of the cranial nerve. This is how you, from the inferior view of the brain, this is first cranial nerve. Of course, we all know this anatomy. This is part of our job and also part of our training. But how beautifully, you know, these are related to each other and how they can be dissected and learned. You have to see how they are. And some interesting fact about some other cranial nerves. So first nerve, second nerve here. You can see third nerve coming out from the interpeduncular fossa. Of course, fourth is the only nerve which comes from behind. and sometimes it's not visible, and it is also thinnest of the nerve. Then a very big nerve here on the lateral aspect of the pons is the fifth nerve. A large bundle of nerve which divides into actually 3 nerves are bundled together in this big nerve. And then we have the sixth nerve here, which is again the motor nerve here, and the 7th, 8th complex here. Then we have 9th, 10th, 11th, and the 12th. So this is again the close-up of the midbrain here. You can see the optic nerves here. You can see some pituitary stalk, and you can see mammillary bodies, and the third nerve coming from the interpeduncular fossas. So then this is the pons here with a large view. You can see fifth nerve, how lateral it is. Yeah, sometimes we know in the textbook description or textbook vision is that it is little medial, but if you can see, it is quite laterally located here. And right in the center of the pons, you can say. Of course, the lower cranials, we have the 12th and 6th. These are motor nerves. They are all in one line. You can see 3, 6, 12. These are pure motor nerve. They are more medially located. More the sensory part of the nerves, they are more laterally. As you go laterally, like 7th nerve, 8th nerve are more here. And then we have in the same line, very close to 7th, 8th nerve, there is very less distance between these. These are our 9th nerves and the 10th nerve. And of course, 11th have a cranial and a spinal part. And you pre-olivary sulcus, we have our 12th nerves here. So I'll go each nerve one by one. First, let's see the, of course, this is the olfactory nerves. You can see how they are related to the anterior skull base. This is the vision which you mostly get once you go to the, your transsylvian approaches. You just lift your frontal lobe. You can see their olfactory system. You can see your interoptic systems here. Even you can see ICA bifurcation. You can see the ACOM going like this. And if you see in the depth, you can also see the third nerve going here. So olfactory nerve, of course, we have to deal with this only tumors related to olfactory groove meningioma, some aneurysms, or some tumors in this area. And mostly it is not given that importance, like it's not very, you can say, for the essential for life. But if you ask me, I think it's one of the very important nerve. Of course, it's concerned with olfaction, but apart from that, it is also concerned with your taste sensation. Olfaction goes, your smell goes, your life is miserable. You can't smell things. You can't know, your body can't warn you of dangers. You can't know what is the taste. And even you can see it's also, you're concerned with other senses also. So, of course, our endovascular friends, they are very fond of, going through the nose, and then they will say that, you can take the olfaction. But I think olfaction is a very important part of our sensory this thing, and it needs to be preserved. So when we go from the subfrontal, from the anterior approach, you can see how these olfactory nerves are arranged here. If this one is involved, try to save one of them and try not to damage them. So very critical for these approaches, subfrontal approaches, transsylvian approaches, and the lesions around the anterior skull base. Of course, many sinonasal malignancies, they can destroy these nerves. And when I'll just show some endoscopic views also how these nerves are important. So this is an endoscopic view here. You can see this is the olfactory nerve here. So olfactory nerve, technically it's just an extension of the brain. And of course, it's not a proper nerve like other cranial nerves. So it is just, you can see the extension of the brain. So now you can see this is the optic nerve here. These are the rectus arteries here. And even you can see some part of the orbit here. So when you are dealing with orbital lesions or the lesions of the skull base through nose, this is the part where you can encounter these olfactory nerves. So this is again the fiber dissection with some cut sections of the brain showing some part of the olfactory nerves here. So then we come to our cranial nerves, 2nd, 3rd, 4th, and of course 6th, which are concerned mainly with the eyeball, how the eyeball has to move, and how its rotation, and of course the vision is there. So now we're coming to these nerves. So coming to the optic nerve is again very critical for vision. With they say if the vision is gone, the world is gone. So you can see from the top how this is related to the anterior clinoid here. This is the tuberculum sella, optic chiasma. And if you see the oblique view here, the structure which I am trying to show is this part of which is between the optic canal here and the superior orbital fissure, optic strut. So optic strut, many times juniors get confused. What is this optic strut? So optic strut is this piece of the bone which is connecting your anterior clinoid to the sella here. So when you are coming from the nose side, from the your endoscopic approach is to sella. Many times people say opticocarotid recess, very common terminology. So opticocarotid recess is nothing but the ventral representation of your optic strut. So just try to remember this. And then with the relationship of the dura with the optic canal, you can see here optic canal is lifted on one side. And just below, we have the ophthalmic artery going along with the optic canal here. So, of course, during these approaches, you should know how to ophthalmic artery aneurysm, how they project inside, how they project into the cavernous sinus, or they're projecting intracranially. So here we have removed some part of the dura from lateral wall. You can see third nerve. Third nerve also very interesting now. So many times we see the third nerve is in the lateral wall of the cavernous sinus. So it is in the lateral wall, but it enters through the roof. Just you can see it enters here through the roof, close to the lateral wall. Once it's inside here, then it just goes along the lateral wall into the superior orbital fissure. So third nerve, very important. So third nerve, again, very interesting nerve for anatomy people. And of course for neurosurgeon also. Once you see the relation with the tentorial edge here, so tentorium, as you can see, it is attached to the anterior clinoid, then it goes like this to the posterior clinoid. So here we have the third nerve going. Then we of course have the trigeminal large with its large Gasserian ganglion here. Here we have removed all the dura and the other intervening venous injection. Interesting thing here is these two structures here. One is the proximal dural ring, one is the distal dural ring. Many times people get confused about this anatomy. So you can see it is a very clear anatomy. You can see it very clearly. How to see it? This is the anterior clinoid. You just remove this anterior clinoid. On top of anterior clinoid is our distal ring. And below the anterior clinoid is your proximal dural ring. And between the two dural ring is the clinoidal segment of the internal carotid artery. I think this will help people and young people to understand, because in the books sometimes it is confusing. What is carotid collar? What is this distal ring? Which is proximal ring? So this is the anatomy of that. So when you see from below, of course, from the endoscopic view, the view changes. The anatomy remains same, but the view changes. And with the endoscope, there is some distortion also of the optics. So many times structures which are like, when we see in the microscope, it is mostly flat, but in the endoscope, it is a cylindrical kind of view. So you see more than what is required. Of course, that is sometimes helpful. So you can see optic nerve, optic chiasma. On top of that, you can see acom artery complex. You can see pituitary stalk. And here you can see beautifully these arteries going to the stalk. These are superior hypophyseal arteries. So different steps for endoscopic approach, of course, to reach this area. We know middle turbinate, then we have their ostium here. Once you open the ostium, you have the vision of the sella. In sella, we have ICA here. This is the OCR, which I was talking, opticocarotid recess. So on top is optic nerve, below is carotid, between is the recess, which is the ventral representation of optic strut. So these struts are between two foramen, optic foramen and superior orbital fissure. So we call it optic strut. So once you remove the bone, we have all the dural covering with the venous injection here. So these are all part of the cavernous sinus, intercavernous sinus. So once you remove this intercavernous sinus, of course, we have this carotid here. Then we have some part of the median nerve here, which is going to the pterygopalatine ganglion. Pterygopalatine ganglion is part of the trigeminal nerve, V2 nerve. So of course, once you remove all this, you can see arteries here, coming back to the nerves. So once you have removed this, then you can see some part of the cavernous sinus nerves. So you can see here is the third nerve entering the roof of the cavernous sinus. And here you can see in the lateral wall of the cavernous sinus, of course, it is lateral to the carotid artery, and most of the cranial nerves are here. We have the V2 here. V2 is not totally, I'll say, in the cavernous sinus. It is just below the cavernous sinus, and V1, and along the parallel to V1, we have 6 nerve here, and third and fourth are on top of this. So this is again, the view from top, this is the endoscopic view, but this is what we see in the microscope. This is the second nerve. This is the ICA bifurcation. Of course, the idea is to show the oculomotor triangle, how the third nerve. Now from second, we are shifting to the third nerve. So how third nerve is entering the cavernous sinus. This view, sometimes difficult to imagine. You can see anterior clinoid, posterior clinoid, and the petrous apex. Just remember three bony structure: anterior clinoid, posterior clinoid, petrous apex. Between two clinoid is your interclinoid ligament. And from anterior is anterior clinoid, from posterior is posterior clinoid. So three clinoid ligaments form a triangle, and in the center of that triangle enters our third nerve, which is the oculomotor triangle, and the oculomotor nerves enters the oculomotor triangle. Easy to remember. So just once you know the things, then it is easy to understand also. So this is again the same nerve. You can see how it is entering in the center of the our oculomotor triangle. Anterior clinoid, this is posterior clinoid, and this is the petrous apex. And fourth nerve just following a very small flimsy nerve, but of course it is also important. It is easy to get damaged. So very careful about fourth nerve also, but it travels along the edge of tentorium and goes with the third nerve here. You can see here, fourth nerve going. Once you remove the venous injection, you can see much more clearly how the fourth nerve is going. And our very favorite sixth nerve, you can see how it is going below this tie-shaped, you can say bow tie-shaped this ligament, which is petrosphenoid ligaments. So once you know these ligaments, once you know these bony landmarks, you know these nerves. When you encounter these nerves during your surgery, whether it is endoscope, whether it is your microscope. And if you see on the other side, we have this petrosphenoid ligament. Of course, this is the petrosphenoid. But before entering petrosphenoid, some part of this cranial nerve, it travels between this venous kind of area, which we call Dorello's canal. So this is the entry to the canal. So there is a, you can say, posterior intercavernous sinus. There is a confluence of the superior petrosal sinus. So there is a venous lake area, which between the two layers of dura, this lake, there is a tunnel kind of area, which is our, you can see much more clearly here. So this is a tunnel kind of area, which is our Dorello's canal. And just at the end of the Dorello's canal, we have our petrosphenoid ligament, and then this sixth nerve enters into the cavernous sinus. Of course, then we have our fifth nerve. This is the lateral wall of the cavernous sinus. Different stepwise approach. You can see how we have this dura here. Once we remove the dura, we have venous injection. When we remove then the venous injection, you can lift the V1. As I told you, V1 is parallel to your sixth nerve. So this is the cavernous sinus. V2 just stays out. It tries to enter, but stays out of the cavernous sinus. So once you retract the cavernous sinus here, sorry, fifth nerve. Just coming back. So fifth nerve here, we can see here, this is the ligament here, which is the landmark for this is the petrosphenoid. This is okay, I'll come back to that later. So coming back now, you can see how all of the lateral aspect of all the cranial nerves from till now. Fifth nerve, this is the tentorial edge here, of course. Third nerve, fourth nerve, just going below the third nerve. Second nerve here, first nerve here. And now slowly we are shifting from fifth nerve to the seventh and other nerves which are concerned with this hearing here. Of course, once you lift the dura from the lateral aspect, this anatomy is very important to remember. So this, as we know, we have a extradural approach to the cavernous sinus. Here we have, if you keep on peeling the dura, you can save these nerves. You can see this thin covering of, so this lateral nerve actually has two covers. So you can take out the outer cover, still you can save all these nerves. You can see third nerve, fourth nerve, V1, V2, V3. So this is for the extradural approach to the cavernous sinus. Now this is again the beautiful view showing all the structures with after removing the venous injection, proximal ring, second nerve, distal ring. Then we have here, this our third nerve here, fourth nerve, sixth nerve going in the background, and this is your fifth nerve here. So this is again same nerves. Now from the below, from the endoscopic view, here we have the V2 here, which is this is the median now. This is the V2. This is the V3 with all the branches. Of course, we have the petrous. This is the petrous part of the carotid artery. So this is a advanced, you can say, endoscopic dissection of this area. Now coming to one of the favorite area of neurosurgeons is the 7th, 8th nerve, retrosigmoid approach, approaching the CP angle, approaching the, you can approach the petroclival region through these approaches. This is a suture here with the burr-hole. Once you open, of course, the tendency of most of the people to attack the lesion, attack the concerned area. But the trick here is to just lift the cerebellum, open this cistern, let the CSF flow. Once the CSF is out, many times people give this argument that for translabyrinthine approaches that there is a lot of retraction of cerebellum, lot of damage to cerebellum. But if you release this CSF and take your steps properly, you may not have to retract the cerebellum also. It will just fall away from your pathology or whatever. So try not to directly go to CP angle. Try lifting this, opening the cistern. Of course, then once you retract the cerebellum, of course, supracerebellar petrosal vein can come into your view. Or if you retract directly, you may avulse this vein and your surgery will be all stopping this bleeding. So be careful about this vein here, petrosal veins. They are important, but if you need, you can take them according to your pathology. So once you retract, then come to the retraction part of the center area. Then you will see these our nerves here, which are CP angle. This is how the CP angle will look once you retract all the nerves. Of course, the landmark here is the choroid plexus. So this is where you can see just this flocculus. Once you retract, you can see 7th, 8th. Of course, these are lower cranials here and going into the jugular foramen. So many times people in the beginning, as from our experience, we also learned that first initial time you can get confused with the lower cranial, whether these are 7th, 8th or so. This is a useful landmark here. So this again is endoscopic view of the same. Now, I'm giving you both the views from, of course, microscopic view is more important, but you should know how these structures, how these cranial nerves are oriented to your brainstem or other areas. Of course, this is basilar artery, ICA here, vertebral, anterior spinal artery. And if you see, this is the 6th nerve. 6th nerve has a very medial course and very oblique. It's a most oblique course of the cranial nerves, but it's quite medial here. And this is the 5th nerve in the background. And if you see, here is the 7th, 8th complex with the ICA here. And these are your 9th, 10th, 11th. And more medially, in line with 6 is your 12th nerve. 12th nerve going into hypoglossal canal. And of course, this is going into the jugular foramen. So this is the, of course, close-up view of the same structures. This is our 6th nerve, very oblique, and the background 5th. And of course, you can reach some Meckel cave lesions through endoscope also. So this is your 7th, 8th complex. This is your 9th, 10th, 11th, and this is the 12th. So 12th nerve, after going out, it joins in 9th, 10th, 11th, and then they travel together for some time. So this is just the close-up view of all the cranial nerve in the internal acoustic matters. We know there are 4 nerves: superior, inferior, vestibular, and cochlear, and our facial nerve. So this is again endoscopic view, but you can see how these nerves are related to jugular foramen. This is our 7th nerve. This is the cochlea here, and this is the your jugular bulb. So many times, if you are taking translabyrinthine approaches, you have to be careful. Where is your this thing? How high is the jugular bulb? You can directly enter jugular bulb rather than entering your CP angle. So be careful about this anatomy. So just wanted to show how this is related to your cochlea. So cochlea is also a very important radiological, or you can say anatomical landmark. Try to see how cochlea is related to your CP angle lesions or other structures. So these are, of course, lower cranials here. So once 7th nerve, it goes out, then it goes through the mastoid, then stylomastoid foramen, then it divides into like pes cavus, like 5 branches, which is supplying the facial muscles. This is the external carotid. This is the internal carotid here. So this is the view from the transmastoid approaches. And this again is the view of the 7th nerve. This is the cochlea here. And you can see how this great petrosal nerve is going along the, here is another carotid. Then this great petrosal join the deep petrosal to form the median nerve, which I showed you earlier. So again, try to remember great petrosal, deep petrosal, and the median nerve. Now, median nerve also called nerve to pterygoid canal. So how, you can see how sixth nerve, how oblique the course is here. And of course, the jugular foramen with the inferior petrosal sinus and sigmoid sinus. So now coming to the lower cranial, far lateral approaches, now we are, or you can say extended approaches. There are different names, transtubercular, transcondylar, this, that, but you can just say extended approaches to the lower cranial area here. So you can open till here in this some cervical part. You can see the vertebral artery here. You can see the occipitocervical joint. And then once you open the duro, this is the view. Of course, you may require some time to mobilize vertebral artery, but most of the time you can manage without doing all these extensive approaches. But this is just to show the anatomy, how these things are related to your your approaches. So we have this occipitocervical, we have a very important muscle here. This is the rectus capitis lateralis. So once you just remove this muscle, you can see the contents of the jugular fossa. So this is the view. Once you lift these tonsils, you have the view of these multiple rootlets of the nerves. All these rootlets are important. Every small nerve is very critical here. Try to save them. Any damage can be devastating for the patient. He can land up with tracheostomy, with the tubes and all. And it is very difficult to manage such kind of complications. So you can see how these nerves are related to in the jugular fossa. So we have two openings here. One is the subcanal here, and this is a large canal here. So this subcanal basically is for the ninth nerve, and then we have the 10th and 11th traveling in a different subcanal, a bigger subcanal, you can say, and hypoglossal canal is just below. So again, same view once, but you see how the hypoglossal canal, once the 12th nerve, it comes out, it immediately joins these 9th, 10th nerves, and then they travel together, of course, for some time. So this is very important here. So this is again a very, I think not a very practical view, but to give you orientation of anatomy. You can see how this vertebral arteries here, you can see how the spinal part of the cranial nerve, spinal accessory nerve, it joins its cranial accessory, then they go into the jugular fossa. We have a vertebral artery entering here, how the vertebral artery is related, how the dentate ligament is located. So when you're dealing with lesions of foramen magnum, all these critical areas, you should know where is this, where the vertebral artery is going, how it enters the dura, how then it goes in front of the brainstem and then form the vertebrobasilar junction. And of course, this is the C2 ganglion here. This is the side of view, of course, of the basilar artery, lower cranials. Here you can see jugular fossa, but you can also see some part of the 9th nerve going here. And this is the 7th nerve and 7th, 8th nerve, then the cochlea, and this is the facial nerve coming out. So coming back to the endoscopic view, we have now this all the ICA here, but not many cranial nerves. So here we, as I told you, there is a separate subcanal. You can see this 9th nerve, it has a separate ganglion and it's going like this. This is the 10th nerve here, and this is the 12th here. So once they come out, then they join. Or this is how they join here. So same view here, you can see now 5th nerve very clearly after removing the arachnoid. This is the 7th, 8th, 9th, 10th, 11th, and hypo. So this is a endoscopic view of all the cranial nerves. You can see here all the lower cranials. You can see some 6th nerve here. You can see 5th. And this is the totally dissected here. And even you can see some part of the spine here. Then you can see the dentate ligament here. So same anatomy, but I'm showing you from endoscopic perspectives to give you a better 3D orientation to all these structures. So we have the 12th nerve here going all the way, pre-olivary sulcus, post-olivary 9th, 10th, 11th. Then we have a dentate ligament, then the vertebral artery entering here. And of course, this is a C1 nerve. So with this, I think that's, I say thank you and finish my presentation. Thank you, sir.
Thank you, Dr. Subbi.
Yes.
Palande, sir.
Yeah, means are we taking the question now, or we'll do at the end of the session, right?
Yes,
I think
one question.
Question.
If any faculty member wants to ask anything, clarification, you can ask one question.
No, beautiful. Very, very nice. Really enjoyed it. I just wanted to know, is it your dissections or you done it all this on your own?
Yes, sir. Most of them I have done at the UPM, CPM, Pittsburgh, and KEM hospital also.
Very, very good. Excellent. Congratulations.
Now, I can only say with great pride that these are amongst the best dissections ever done in the history of dissections. Even Rhoton's textbook, and Rhoton's means he's one of the Rhoton's, one of the fellows in grandchildren of Rhoton, no question about that. But you must see the brainstem dissection, the article that we wrote in World Neurosurgery, one of the topmost dissections ever done. So I'm very, very proud of Sukhdeep, and what beautiful, each slide can be seen for a very long time, and you can spend a lot of time on one single slide, and beautiful dissection. Congratulations, Sukhdeep, to you.
Thank you, sir. Thank you.
Dr. Goel, because the pictures are so clear and sharp, so you can really visualize the 3D anatomy in front of you, which normally we don't see all these things. Thank you, Dr.
Thank you, sir. Thank you.
Yeah, so we move to the next speech by Dr. Abida Shah. So the moderator for this session is Professor Alok Sharma, sir, who is Professor and Head of the Department of Neurosurgery at LTMC, that is Sion Hospital in Mumbai. And he's also the Director at Neurogen, that is Brain and Spine Institute at Nerul, Navi Mumbai. He has done his MBBS, MS, and MCH in neurosurgery from prestigious and GS Medical College in Mumbai. He has over 174 scientific publications to his credit. He has contributed to more than 23 international textbook chapters. He has authored 18 medical books, and he has over 200 international and national presentations. He is the recipient of 17 distinguished national and international awards, including Sushruta Award, then Bharat Gaurav Award, European Award for Best Practices. He is the president of the Stem Cell Society of India and vice president of International Association of Neurorestoratology. His areas of special interest are in stem cell therapy for neurological disorders, stereotactic and functional neurosurgery, psychosurgery, neuroendoscopy, and surgery for ischemic stroke, neuromodulation, neurotrauma, and spinal reconstructive surgery. So over to you, Professor Sharma, sir, to introduce the speaker, Dr. Abida Shah. Thank you, sir.
Hello, it's a pleasure to be a part of this webinar. Thank you, Vandan, for arranging this. And it's also a great pleasure to introduce Dr. Abida. Dr. Abida, are you there?
Yes, sir.
Yeah, yes, all right.
Yes.
So, of course, Dr. Abida did her MCH from my own alma mater, GS Medical College, and she won the gold medal for MCH neurosurgery. She subsequently did endovascular surgery fellowship at the Mayo Clinic. She has almost 114 present publications, lots of honors and awards, including the Indian Society of Neuro-Oncology's President Award for Best Clinical Research, the Vesalius Award, then the Spring 2014 Women in Neurosurgery Award, the American Association of Neurological Surgeons meeting, the Young Neurosurgeon Scholarship she availed of, and it's endless. There are so many things, but this the DL Kothari Gold Medal Award is really a distinct honor. Apart from that, lots of leadership, organizational positions. Her interest is skull-based surgery, vascular surgery, neuro-oncology, and she's associate editor of the Journal of Craniovertebral Junction and Spine, and on the editorial board on the International Journal of Neuroscience. So without wasting much time, Abida, please start. We are looking forward to your talk.
Thank you, sir, for this kind introduction. And I will start my presentation now. Is my screen visible?
Yes, yes.
Okay. So we've just seen an overview of all the cranial nerves by Sukhdeep. Now let's start looking into the cerebral and cranial anatomy. So evolution wise, when the primitive fishes left the oceans, the primitive fishes only had a spinal cord, they had a brainstem, and they had a corpus striatum on top. So when they left the ocean, they developed a amygdala and a hippocampus, and they developed an olfactory system. This olfactory system, as you saw the olfactory nerves demonstrated by Sukhdeep, they progressed as the evolution proceeded and became quite long in reptiles and many other mammals that we see. So this olfactory system was built to perceive the new world, and in coordination with the hippocampus and the amygdala, they perceived the new world and directed it to the hypothalamus to decide the action. Now, as our cerebral cortices have evolved, this is what we have got. Now, to understand this evolution, you have to understand that the primitive cortex, the allocortex, was of 3 layers and constituted of these limbic structures: the amygdala and the hippocampus in this region, and the paleocortex or the olfactory and pyriform cortex in this region. What happened evolution-wise is some cerebral part of the cerebral hemisphere started developing medial to this, and some started developing lateral to this. This was an intermediate cortex between the primitive cortex and the neocortex, and this mesocortex on the medial side was formed by the parahippocampus and the cingulate, which we now know as the limbic lobe, and on the lateral side it was formed by the insula, which we now know as the insular lobe. And surrounding these structures, we then developed the 6 organized layers of the isocortex, and we had the parainsular structures and the neocortex. So with this preliminary beginning, let's go into the cortical anatomy. Just like before learning to read, you learn with ABC. Just like before learning to sing, you start with do, re, mi. Before starting to operate on the brain, you have to know the anatomy of the cortex, of the various gyri and the sulci. So this image you see is a majestic view of the cerebral hemisphere that we open every day and bow to every day. So earlier, the cerebral hemisphere was basically divided into just 4 lobes. So you had the central sulcus. The area in front of the central sulcus was the frontal lobe. The area posterior to the central sulcus and divided by a line from the parieto-occipital sulcus to the pre-occipital notch, and divided by this arbitrary imaginary line of the superior temporal sulcus going here was the parietal lobe. Below this line was the occipital lobe, and here you have the temporal lobe. Anatomists further increase this classification, and you now have a lobe that is the insular lobe, which is hidden within the opercular surface of the frontal, parietal, and the temporal operculum, and it's called the hidden island of Rayleigh. So that is your 5th lobe. And on the medial aspect, we will see later, you have the limbic lobe. So characteristically, there are now 6 lobes. Many anatomists also categorize the precentral sulcus, the precentral gyrus with the central sulcus, and the postcentral gyrus as another ellipsoid, and it is called as the central lobe. So let's look into each one of these lobes individually. Before going into that, we will also see the craniometric points that are important to us while we operate. So this is a very familiar view of the skull and familiar points that you see here. This is the region of the pterion. This is the superior temporal line, the squamosal suture. This is the region of the urion. Here you have the stephanion. Here you have the bregma, and this is the asterion. And this is a very prominent depression just in front of the tragus of the ear, and that is called the preauricular depression, right in front of the zygote. So these are the classical Taylor-Houghton lines. I don't want to go into details because we are all aware of this. So let's start with the anatomy. So this is the view that you obtain when you remove the various bones between the cranial sutures. And this is the view of the brain with the arachnoid intact. When you remove the arachnoid, this is the view of the lateral aspect of the cerebral hemisphere. So this structure here, right in the middle of the hemisphere, is your central sulcus, which is perpendicular to your interhemispheric fissure. The gyrus in front of the central sulcus is your precentral gyrus, and the one behind is your postcentral gyrus. Both these gyri meet. They meet at 2 points, just above the Sylvian fissure and superiorly on the medial aspect of the hemisphere. This gyrus is known as the subcentral gyrus, and the gyrus on the middle aspect of the hemisphere, as we will see, is the paracentral lobule. Up, just in front of the precentral gyrus is the precentral sulcus, and up in front of them, you have the superior, the middle, and the inferior frontal gyri, divided by the superior frontal and the inferior frontal sulcus. This region, the inferior frontal sulcus, joins the precentral gyrus by a very prominent root here. And this area, just in front of this area, is the ventral speech area, ventral premotor speech area. If you stimulate this area during surgery, you will get a speech arrest. And the classical pars triangularis and pars opercularis of the inferior frontal lobe is your classical Broca's area. So let's go into a few more details. So as you see, this is the central sulcus, which is a complete sulcus running from the interhemispheric fissure all the way down where it joins to form the subcentral gyrus. Now this central sulcus has the precentral gyrus has a very prominent posterior convex fold here that is called the middle genu of the precentral gyrus. It occurs at the point where the superior frontal sulcus meets the precentral gyrus. Why is this area important? Because this is your hand motor activation area. This is classically seen on MRI and it has been classically seen on stimulation during surgery. So this is your hand motor activation area. It looks like an omega shaped area, which can also be identified on your MRI. The area of the medial aspect of the superior frontal gyrus in front of the precentral sulcus is your supplementary motor area. And the area in front of that is your pre-supplementary motor area. Both of these are important while performing learned and sequential movements. The area where the superior frontal sulcus joins the precentral sulcus is another important area, and that is your dorsal premotor area. So we had a ventral premotor area, and now we have a dorsal premotor area. So here you can see the superior frontal gyrus, the superior frontal sulcus, where it joins the precentral sulcus. This is the central sulcus and the precentral gyrus. The precentral sulcus is typically interrupted by the middle frontal gyrus, as you can see here. So you have a medial part of the precentral sulcus and a lateral part of the precentral sulcus. Now, as we see on the medial aspect of the hemisphere, this is the region where the precentral and the postcentral gyri meet, and this is the region of the paracentral lobule. This is the central sulcus, and this is bounded posteriorly by the marginal ramus of the cingulate sulcus. This is a very constant and prominent sulcus that you will see, and anteriorly by the paracentral sulcus. On the medial aspect of the hemisphere, you have the superior frontal gyrus, which joins anteriorly the gyrus rectus. You also have the beginning of the cingulate gyrus, which begins here in the subcallosal region and runs over the corpus callosum posteriorly all the way back to the parietal region and then all the way down to the temporal region. Here there are a couple of gyri which are called the paraolfactory and the paraterminal gyri. This region where the cingulate joins the gyrus rectus is also been called, it's a very classical U-shaped area, and it is also known as the cingulate pole. The cingulate gyrus communicates with the frontal and the parietal cortices, which I will show you in another specimen. So now we have finished the superior frontal gyrus, we've finished the precentral gyrus, and we finished the medial aspect of the hemisphere. Again, on the lateral aspect, this structure is the middle frontal gyrus, and the middle frontal gyrus consistently connects with the precentral gyrus by a very prominent root, which corresponds in the depth to a pli de passage of Broca, which will be seen once you remove this. This area is important clinically because it corresponds to the frontal eye fields. And now you have the inferior frontal gyrus, which consists of three parts: the pars opercularis, the pars triangularis, and the pars orbitalis. The pars triangularis is a very classical V-shaped area, and the apex of the V classically corresponds to the anterior Sylvian point, which is a dilatation in the Sylvian cistern. This is the pars opercularis with a classical U-shaped gyrus and its connection with the subcentral gyrus here. And then this is, of course, the Sylvian fissure. And then you have the pars orbitalis. So the pars orbitalis is mainly seen on the inferior aspect of the hemisphere. So the superior, the middle, and the inferior frontal gyri turn over the superior and frontal aspect of the hemisphere and join the gyrus rectus and the orbital gyri. So on the inferior aspect, you have a very prominent sulcus here in which runs the olfactory bulb and tract. The gyrus consistently medial to this is the gyrus rectus. And this area is made up of the orbital gyri, which are divided by this H-shaped cruciform sulcus of Rolando into the medial, the anterior, the lateral, and the posterior orbital gyri. The olfactory tract divides into the medial and the lateral olfactory striae, which form the anterior boundary of the anterior perforated substance. And this posterior orbital gyrus is a very classically identifiable gyrus because it forms like a hat in front of the temporal lobe, which you can see here. And it also connects very consistently with the medial orbital gyrus. And this region is called the posterior medial orbital pole. So this is the anatomy, basic anatomy of the frontal lobe. Looking at the craniometric points that are important, you have the coronal suture. This is the region of the Stephanion. This is a point where the superior temporal line and the coronal suture join. And what does it correspond to in depth is the face activation area, or the area where the inferior frontal sulcus joins the precentral gyrus. So this is the face motor activation area. And this is another point that is the inferior Rolandic point. It's the most inferior projection of the central sulcus, just above the Sylvian fissure. And it can be identified on the cranium by this line, which runs from the preauricular depression here at the root of the zygoma, straight up to the squamosal suture. And basically it is at the highest point of the squamosal suture. When we look from superiorly, you have the coronal suture. You see the precentral gyrus lies posterior to the coronal suture, just posterior to the precentral sulcus. The central sulcus lies at about a distance of 5 centimeters from the coronal suture. And this is the point where the superior frontal sulcus meets the precentral gyrus. And it lies at a point about 1.5 centimeter posterior to the bregma and 3 centimeter lateral to it. And this point here, this yellow circle, is your superior Rolandic point, which is your most superior aspect of the central sulcus as it turns on the medial aspect of the hemisphere. So this is your superior Rolandic point. And on this side, you can see the various short arcuate fibers as the gray matter has been removed in this area. Now going further, why are all these points important and essential to us? They are important when operating on tumors in this region. As you can see here, in this, there is a classical tumor in the premotor area. This is your central sulcus and your precentral gyrus just anterior. And this is your tumor here. You can see that the functional areas are pushed posteriorly. And this is the tracts that you can see in the tractography. And this was the craniotomy that was performed. And this is the extent of resection. An en masse resection has been performed. The surgical details and techniques of how we perform this resection and with or without monitoring, we will be discussing in another lecture. This is just an anatomical view. And this is the post-operative scan. This is another patient with a tumor in the supplementary motor area. It is classically in the region of the posterior aspect of the superior frontal gyrus. Here you can see the central sulcus, the precentral gyrus, and this is your supplementary motor area. Again, this patient was operated under monitoring. An en masse tumor resection was performed. This patient did develop a SMA syndrome immediately following the surgery, but completely recovered within about a month of surgery. And she's absolutely fine now. This is another tumor in the pre-supplementary motor area. You can see the central sulcus, the precentral gyrus, the SMA and the pre-SMA here. And it is going in the area is pre-SMA, but it is just above the cingulate gyrus here. And you can see that we've gone, these are the displacement of the tracts, and we've gone in an interhemispheric approach with monitoring, and a total excision of the tumor was performed. This is another tumor in the basal aspect of the frontal lobe. You can see how the fibers are around the tumor. And again, this patient was operated, and you can see the post-operative resection of the tumor. Now going to the parietal region. So the parietal lobe lies classically behind the central sulcus, and from a line that you can draw from the parieto-occipital sulcus marking on the superior aspect of the hemisphere to the pre-occipital notch. So this is your region of your parietal lobe. The parietal lobe has a bunch of irregular gyri, and it is divided not by a gyral nomenclature, but as a lobule. So you have the interparietal sulcus, which runs from the post-central sulcus down all the way to the intraoccipital sulcus. And the lobule superior to it is your superior parietal lobule. And the lobule that lies inferior to it is your inferior parietal lobule. The inferior parietal lobule is again made up of the supramarginal gyrus, which classically forms a U around the termination of the superior temporal sulcus. And also it joins the superior temporal gyrus. And this junction of where the supramarginal gyrus joins the superior temporal gyrus is your classical Wernicke's area. In this region is another important gyrus, which is related to your naming and all your other calculations on the dominant side, which if damaged will cause Gershman syndrome. It is separated from the supramarginal gyrus by the intermediate sulcus of Jensen, and this is your angular gyrus. On the medial aspect, you have of course seen the paracentral lobule, and basically posterior to the marginal sulcus of the cingulate gyrus, you will have the precuneus, which is the medial aspect of the parietal lobe. It is bounded posteriorly by the parieto-occipital sulcus. So this is your superior extent of your parieto-occipital sulcus. And of course, you have the isthmus of the cingulum, which is going down into the temporal lobe. So the subcentral gyrus is also an important location because as an opercular point, classically, it just lies above the Herschel's gyrus. So this is your temporal lobe, and this is the superior temporal gyrus. This is your planum temporal of the superior temporal gyrus, and this is where your Herschel's gyrus is, and your subcentral gyrus lies always just superior to the subcentral to the Herschel's gyrus, and it is a direct indication of where it lies. It corresponds to the body of the lateral ventricle. The coronal suture, as we know, corresponds to the interventricular foramen, and posterior to this is your atrium. Now the craniometric points that are important is here, the junction of the post-central sulcus and the interparietal sulcus. This lies about 6 centimeters superior to the lambda and 5 centimeters lateral to the sagittal suture. And this point here is another point because it represents the highest point of the parieto-occipital suture, parieto-occipital sulcus as it crosses over into the medial aspect of the hemisphere. And it lies in the angle between the sagittal and the lambdoid suture. This is the most important point on the lateral aspect of the parietal region is your urion. So what is the urion? It is the point where the superior temporal line meets this line which comes posterior to the mastoid tip, crosses this parieto-mastoid and squamous suture junction and goes all the way above and joins this line. This corresponds to the most posterior and superior aspect of your supramarginal gyrus. So this is your parietal bossa, and this is where your supramarginal gyrus lies in respect to the cranial findings. Now this is a tumor of the parietal lobe. Basically it was between the superior parietal lobule and the inferior parietal lobule. Why is this region important? Apart from the cortical representation, it is important because subcortically, there are a myriad of fibers that join in this junction. So you have the arcuate fasciculus, which has been cut here, which goes down here. So this is the arcuate fasciculus. Here you have the fibers of the sagittal stratum, which consists of the IFOF, fibers of the anterior commissure and the optic radiations. This is your IFOF, these are your optic radiations. So there are 3 fiber bundles here. This is your arcuate here. Just beneath it is your ventral occipital fasciculus, and all these fibers here. So if you go subcortically in this area, and especially in the dominant lobe, you will cause a huge speech deficit in this patient. This is another patient with a tumor of the inferior parietal lobule, and you can see how the fibers have been pushed. And again, an en masse resection of this tumor was performed. You can see the craniotomy with respect to your craniometry, and this is a total excision of the tumor, as you can see. Now going to the temporal lobe. So now the temporal lobe, we are all very, very familiar with. It lies beneath the Sylvian fissure, beneath this line that runs from the parieto-occipital to the pre-occipital notch, and by this imaginary line that is going up, which separates it from the parietal lobe, which is divided in the superior, the middle, and the inferior temporal gyri by the superior and the inferior temporal sulcus. Both the superior and the inferior temporal gyri, as you can see here, are huge gyri and they meet anteriorly most of the times. And then there is a separation from the middle temporal gyrus. So the end of the superior temporal sulcus, as we have seen, goes to the supramarginal gyrus. Inferiorly, the temporal lobe is in continuity with the occipital lobe, and it is divided by the collateral sulcus into a medial parahippocampal region and a lateral fusiform sulcus, a fusiform gyrus. And by this sulcus, the inferior temporal gyrus, which actually turns over the inferior aspect of the hemisphere. There is another sulcus here, that is the rhinal sulcus, which demarcates the most anterior aspect of the parahippocampal gyrus, where it has turned over itself. And this is your region of the uncus. And you can see the relation of the uncus to the cerebral peduncle and to the posterior cerebral artery. The uncus harbors the amygdala in its anterior aspect and the head of the hippocampus in its posterior aspect. So it is important, this relation is very important during temporal lobe surgery, especially of the mesial temporal region. And this region here, the fusiform gyrus, lies just beneath the floor of the temporal horn. So that is another important relation while operating in this region. So regarding the craniometry, here you have the most common point that we are familiar with, and that is the pterion. And here you have the pre-occipital depression, pre-auricular depression, sorry. Now this orange circle here is your anterior sylvian point. This is where you enter for aneurysm surgery, for entering tumors of the insula. It is the most dilated aspect of your sylvian cistern, and it lies underneath the most anterior aspect of your squamosal suture. So this is where the anterior sylvian point is. And this is another point which marks the end of the superior temporal gyrus, and it lies at this 3 centimeter above this line where the squamosal suture and the parietomastoid sutures join, and this is the point of the superior temporal sulcus termination. So this is a region in the peri-insular region, in the region of the sylvian fissure. This is a high-grade glioma. The fiber tracts that you will see in this region are the arcuate fasciculus. Superiorly, you have the superior longitudinal fasciculus, and in the depth, you will have the fibers. You'll have the insula with all its white fibers. So this is the typical craniotomy that is based on the pterion or a frontotemporal craniotomy. This is on opening the tumor. You can see how the tumor has jutted out into the sylvian cistern. And this is post-resection. You can see that the middle cerebral artery has been completely preserved. And this is the post-operative image of the patient. This is another tumor in the medial temporal region, which can be very elegantly accessed from either below the inferior temporal gyrus or from the inferior temporal sulcus, which is between the middle and the inferior temporal gyrus. As all the fibers are displaced medially, it is very safe to enter from here. And again, to revise the anatomy, these are the fibers that will come in the region for temporal lobe surgery. And this is the fibers, how the optic radiations run in relation to the hippocampus. So this is your temporal horn. This is your region of the sagittal stratum and part of the optic radiation as they are part of the sagittal stratum. And you can see how they are related here in the roof of the temporal horn. Anteriorly, they are in the roof, and posteriorly, they also run in the lateral aspect. So entering from below will cause least damage to this area. And here you can see the pre-operative, and this is the post-operative resection showing a very good tumor resection. Then the occipital lobe is a very inconstant, there are very inconstant gyri and sulci on the occipital lobe. But basically to identify them, you have this arcus here. This is your most superior aspect of your parieto-occipital sulcus on the superior aspect of the hemisphere. This connection that you see here is a very robust connection that is always there between your superior parietal lobule and your inferior occipital gyrus. So this is your region of your inferior occipital gyrus, which runs also almost transversely here. This is your middle occipital gyrus, and the superior occipital gyrus you will see on the lateral aspect. On the medial aspect, the occipital lobe is more clear because here you have the calcarine fissure, which this is your parieto-occipital sulcus, and this is your calcarine fissure, which divides the occipital lobe into the cuneus and the lingual gyrus. This is the most anterior aspect of the cuneus, and the lingual gyrus continues with the parahippocampal gyrus, as you can see here. And then the fusiform gyrus lies more medially, which again continues with the fusiform gyrus of the temporal lobe, which you can see on the inferior aspect. So this is your fusiform gyrus of the temporal lobe, or the medial temporo-occipital sulcus, as it is continuing from the occipital into the temporal lobe. And this is where your inferior occipital gyrus comes over the base of the hemisphere, and this is the region of your lingual gyrus. So this is your craniometric points. This is your lambda, where the sagittal and the lambdoid sutures meet. This is another point, that is the ophistocranion. It is the most prominent cranial point that you can palpate on the back of your hemisphere, back of your skull. And it is important because it straight relates to the calcarine fissure. And the distance from here to the tentorium actually marks the length of your lingual gyrus. So this is a tumor of the occipital region. You can see here the medial occipital region, and this is the craniotomy, and this is after tumor resection. This is the post-operative image showing the tumor resection. Now the fifth lobe that you see is the insular lobe. So this is your sylvian fissure. You have the frontal, parietal, and the temporal opercula covering the insula. Once you open the opercula or the curtains, you will have the insular lobe. The insular lobe is divided by the central sulcus of the insula, which, if you see, continues with the central sulcus of the brain, of the cerebral hemisphere. This is always in one line with the central sulcus. And the insular gyri are divided into an anterior gyri and posterior gyri. Also, the insula has two surfaces, the anterior surface and the lateral surface. The most anterior gyri here are the transverse gyrus. This is the accessory gyrus. And you have the anterior, middle, and posterior short gyri. And all these anterior gyri actually emanate from this one point, that is the insular apex. And posterior to the central sulcus, you have the posterior long gyri. This region is your Lyman insula. And if you see this region, this transverse gyrus of the insula actually connects at the base of the lobe, base of the frontal lobe, and connects with the posterior middle gyri and the lateral olfactory striae. So this is a transaxial section where you can see how the anterior insular point or the anterior insular surface corresponds with the head of the caudate nucleus in this region, and the posterior part corresponds to the atrium, and how it covers the central core of the brain. It actually forms an external shield over the central core of the brain, which is made up of the caudate, the lentiform nucleus, the internal capsule, and the thalamus. So this is a very typical insular tumor that we regularly see. These are the fiber bundles that are in danger while operating on these tumors, most importantly the IFOF, and of course the uncinate and the arcuate fasciculus. And this is the post-operative resection of the tumor. Now the medial aspect of the hemisphere is the limbic lobe. Now what is the limbic lobe? The limbic lobe is actually a series of C-shaped structures that run on the middle aspect of the hemisphere, which compose of the cingulate gyrus, which terminates as the parahippocampal gyrus. You have the region of the fornix, and we will see each one of these C's as we go ahead. Just typically to show you the cingulate gyrus, this is your cingulate sulcus as it is entering to the parietal and the frontal region. This is the region of the isthmus of the cingulum, where it narrows just in front of the cuneus or at the connection of the calcarine and the parieto-occipital sulcus. And the isthmus of the cingulum then continues down and ends as the parahippocampal gyrus. The parahippocampal gyrus has continuity with both the cingulate and also the lingual gyrus. So these are the fibers that you will see once you start dissecting in this region. Here, once you remove the cingulate gyrus, you will see the cingulum. And this is your very classical connection with the precuneus that you can see in the marginal sulcus, the cingulum connecting with the precuneus. And there is also another constant connection at the superior frontal gyrus level, which is not seen very clearly here. So now these are the series of C's that you see in the limbic lobe. So you have the cingulate here ending at the radiation of the cingulum. You have the fornix that is going all the way down. Then you have the corpus callosum. You have the caudate head, which will turn like this. Here you can see the beginning of the mammillary body and the mammillothalamic tract. Parts of the thalamus have been dissected. And a closer look in this region reveals the head of the hippocampus. This is the white fiber tract, that is the fimbria, that has been dissected here and going all the way to form the fornix, the column, the body of the fornix, columns of the fornix, going all the way up to the mammillary body. And then you have the mammillothalamic tract ending in the anterior nucleus of the thalamus. This is your anterior commissure. From here, you have fibers that go medially and form the anterior thalamic radiation or the medial aspect of the projection fibers. This structure that you see here is your dentate gyrus, and it ends here above the corpus callosum as part of the inducium griseum. So this is the whole Papez circuit that has been dissected. Here you can see that it begins here in the hippocampus, the fimbria, the fornix, the mammillary body, mammillothalamic tract, the anterior nucleus of thalamus, the anterior thalamic radiation, and going to the cingulum and ending again back in the parahippocampal and entorhinal area is the radiation of the cingulum. This is the connection to the parietal region, and this is the Papez circuit that has been dissected outside. This is a classical tumor of the cingulate or the limbic system, and you can see how it is related to the fibers in this tractography image. And this is again resected completely by an interhemispheric approach. You can see the post-operative image here. So basically, this covers most of the lobes of the brain, and more important than the lobes, also as important as the cortical structure, are the fibers. We recently published this I won't discuss the fibers in detail, but I will just give you a short overview. We discussed the architecture of the fibers of the brain and proposed a classification to divide these white fibers into 5 groups, where you have the superficial group, where was the short association or the arcuate fibers. The middle group was the SLF, the arcuate, the ILF, the middle longitudinal fasciculus, the uncinate, the IFOF, and the sagittostratum. This deep group was the one in relation to the ventricle, that was the fornix, the striae terminalis, and the striae medullaris thalami. The central group, right in the between of both the vertical group, was the commissural fibers, the corpus callosum, anterior posterior commissure, habenular commissure, and the hippocampal commissure. And vertical group was the internal capsule and the thalamic radiation, which consists of the projection fibers. So these are the 5 groups. This is the short arcuate fibers. This is the middle group of long association fibers on the medial aspect of the hemisphere. This is the deep group that are related to the ventricular surface. This is the central group that consists of the commissural fibers. And this is your vertical fibers, that is your thalamic radiation and your corona and your internal capsule as it enters to form the corona radiata. And on the lateral aspect of the hemisphere, again, you have the short arcuate fibers, you have the vertical group or the projection fibers, you have the long association in the middle group, that is the SLF, lateral part of the SLF, that is SLF 2 and 3, and parts of the arcuate fasciculus. And these are the first superficial layer or the short arcuate connection. This is a short arcuate connection actually between the inferior frontal gyrus to the arcuate fasciculus, which actually represents the Broca's connection. And again, this is just a view on the medial aspect of the hemisphere as it looks when it is superimposed on the medial aspect of the hemisphere. And that ends my lecture. Thank you very much.
That was a wonderful lecture, Abida. Hello. There was a wonderful lecture, very well described, very simple, and you put it across very nicely. Varnan, no questions now, right? Any faculty? Anybody?
Comment by faculty is allowed.
Yeah.
No, I'd like to. Can I make a comment, Varnan?
Yes, please.
Yeah, sure,
The glioma surgery is, our regular. We are doing glioma surgery all the time. And I am doing personally glioma surgery for 40 years now. All my neurosurgery, we are doing glioma surgery. But understanding the fiber tracts, understanding the white fiber tracts, understanding the anatomy of the region. In the last 5 years or 6 years, we have completely, I will say, changed the way we handle, way we see gliomas, way we operate gliomas, and, the method of resection, the technique of resection, the monitoring that is applied, and the way it has to be done has completely, in the last 4 or 5 years, completely we have changed. And that is based on the basis of these fiber dissection, which are going on in our department for quite some time now. I think what we have to do is all those who are interested in glioma surgery should not take them as a lump of mass that has to be removed and decompressed and all those things. We have to learn what is around that tumor, what fibers are in proximity, what is the function of those fibers. It is not just hand and leg and speech. There are so many other things which are happening in the brain and around the gliomas and inside the gliomas, and what has to be dissected, how has to be dissected, has to be learned and acquired over a prolonged period of time. And I have a feeling that in my last 5 years, and we are going to present our work on various forums now on, this is the first time we have presented our surgical work here and there, but we will be now presenting on various forums, and you will see that the complete, I will not use the word revolution, but a revolution is possible in this field of neurosurgery.
I totally agree with you. I think what you said is very accurate. It's time we stop treating glioma surgery as something which just residents go and remove. I completely agree with you. Well, I think that was very well put. And so you, and I think, and you have a training program for this. Can younger neurosurgeons come and train with you?
Yes, we are having a training program. And Abida, you want to say about that? And also, one before I ask her to answer that question, you know what, Alok, I was reading your profile and your work on stem cell and on your various work. I think you should also give one presentation. Vernon, you should see to it that Alok presents his work and we know his work. I actually don't know his work at all.
Yeah, we'll have a separate webinar.
Yeah. You please see to it that he presents and we know his work.
For sure. Okay. Abida, can you tell because for the audience, younger people, what is the training program you have at the department? I know of it, but I think everybody should know. Yeah.
So basically, sir, whenever whoever is interested can come, but they learn it as a part of their observership or fellowship. So when they are with us for about a period of 3 months or 6 months, so as a part of their observership with us or fellowship with us, they are also given these fibers to do or learn. And we have a very comprehensive training program.
Great.
So anyone is welcome to come.
All right, so we end this session. Any other questions, or we can go on to the next speaker?
Yeah, we'll go on to the next speaker and the
moderator. So thank you, sir. So the next speaker for the talk on associative tracts of the brain lateral aspect is Dr. John Martineau, and he will be introduced by the moderator, Professor Atul Goyal, sir. Professor Atul Goyal, sir, is professor and head of the department at KEM Hospital and GS Medical College since 1998. He is a consultant neurosurgeon at Tata Memorial Hospital and also at Leelavati Hospital and Research Center. He is an honorary consultant to Governor of Maharashtra State of India. He was the chairman of editorial board of Journal. He was a section editor in World Neurosurgery Journal, then editor in journals like Journal of Postgraduate Medicine India, Neurology India, International Journal of Neurology and Neurosurgery, and he is on the editorial board of many neurology and neurosurgery journals. He is the honorary member of Japan Neurological Society, Venezuelan Society of Neurosurgery, Bangladesh Society of Neurosurgery, Egyptian Society of Neurosurgery. He is a past president of Asia Ocean Skull Base Surgery Society since for 2011 to 2014. His contributions to neurosciences are immense. He has a book with on neurosurgery of complex tumors and vascular lesions, also the Bible of the craniovertebral junction, diagnostics, pathology, and surgical techniques. He has 692 publications in PubMed Index journals. His 5 articles are included in highest cited 100 papers published in Neurology India. 2 of his articles are included in the 100 most influential publications in cervical spine research. Then 2 articles in top 50 most cited articles on CV junction surgery. His publications were ranked second in the most influential publication on odontoid fracture in World Neurosurgery in 2019. He's the recipient of multiple awards, which include Dr. Deepak Kothari Gold Medal for the first position in MCH Neurosurgery in 1987. Then he's the recipient of Indian ICMR Award, that is Shakuntala Devi Amirchand Prize for Outstanding Scientific Research in 1995, and ICMR Award, the Amrut Modi Unichem Award for Outstanding Research in Neurology in 1996. Then he is the recipient of Dr. B.C. Roy National Award, the Dandy Medal for Distinguished Neurosurgery Services in 2018, and the outstanding contribution to the Chinese Society of Neurosurgery in 2019. So, Goyal sir, over to you to introduce the speaker. Thank you, sir.
Thank you, my dear, for this small little introduction, which went on for quite some time. So here I am to introduce, the young Spanish brigade of very eminent and very classy anatomical neurosurgeons. And one of these young brigade commander-in-chief is Dr. Martineau and Juan Martineau Gonzalez. And there is no question that I am very happy to introduce him to our audience. Many of the people in the audience are Indian, so they may not be knowing him, but he's a young neurosurgeon who is now very established and very well known by his anatomy and by his surgery. And he has been on several webinars all over the world with Paulo and he. These are the young Spanish neurosurgeons who have lifted Spanish neurosurgery. It was always high, but recently these young people have really taken this Spanish neurosurgery to the next level. Dr. Martino has been very well trained with various top neurosurgeons of the world on the who are dealing with anatomy like Dufault, like Mitch Berger, and with vascular surgery like Ernest Meny, and neuropathology like Susan Chang. And I see several other people where he has been trained and where he has worked, and he has contributed to neurosurgery in several publications and in so many other things. So I don't want to make as big a commentary as was made for me, little bit smaller, because I want to have an upper hand on my dear Dr. Martino. So Joanne, over to you, and we look forward to hearing from you.
Thank you very much, Dr. Goel. I don't know if you can hear me.
Yes, well? Yes, we can hear you very well.
Okay, thank you. So I would like to thank you, Dr. Goel, for your kind words. It's a big honor for me to be here today and to present my work about fiber dissection. I would like to also thank Dr. Benon and all the other organizers for inviting me today. So let's see. Okay, so my lecture is about the associative tracts of the brain. I don't know. You can, yeah. Okay, so I will talk about mainly about these connections, all the lateral associative tracts of the brain, like the arcuate fasciculus, superior longitudinal fasciculus, middle longitudinal, inferior longitudinal, and the uncinate and inferior fronto-occipital fasciculus. Pablo Gonzalez will talk in the next talk about the medial associative tracts of the brain. So we'll have a whole view of first the previous presentation about the beautiful presentation about the surface anatomy, now the lateral associative tracts of the brain, and then Pablo about the medial associative tracts of the brain. So I will talk about each of these connections individually, and then I will talk about the areas where all these connections intersect. But before starting with this anatomy, I think it's important to review a basic anatomical concepts. Because a lot of the terminology that we use to refer to the tracts and the brain anatomy come from the animal anatomy, and sometimes the terminology is a little bit confusing. So in the animal anatomy, here a dog, the dorsal part of the dog is here, is at the spine. So the dorsal part of the dog means superior, and the ventral part of the dog is the abdomen and means inferior. So when we use the terminology dorsal, we are talking about the superior part of a structure, and when we are talking about ventral, we are talking about the inferior part. Rostral is anterior, is the rostrum, and caudal is posterior. The problem is that if we apply this terminology to the human anatomy, it's confusing because the dorsum in the human anatomy is posterior and the abdomen is anterior. So, as I said, we use animal anatomy. So as you can see here, using this terminology, dorsal means superior in the brain, and ventral means inferior in the brain. Rostral means anterior, and caudal means posterior. For example, when we talk about the dorsal stream for language, or the dorsal tracts, like the superior longitudinal fasciculus or the arcuate fasciculus, are dorsal tracts because they are superior in the brain. And the ventral tracts, for example, the ventral stream for language, the semantic ventral stream for language, are inferior, including, for example, the inferior longitudinal fasciculus or the inferior or the uncinate fasciculus. The other term that are also very important is to understand what is longitudinal and transversal. There are also simple terminology, but sometimes are confusing. Longitudinal is parallel to the major axis of a structure. That's the definition of longitudinal. For example, in the brain, so the major axis of the brain is this. So longitudinal is any structure that is parallel to this line. And transversal is perpendicular to the major axis of the brain. So transversal is this direction. Examples of transversal is the transversal gyrus of Hessels, for example, here, that as you can see is perpendicular to the major axis of the brain, that it's here, so it's transversal gyrus of Hessels. An example of longitudinal is the superior longitudinal fasciculus, that as you can see here is parallel to the major axis of the brain. So the superior longitudinal, inferior longitudinal, we call them longitudinal because they are parallel to this line. Okay, so once we have this basic anatomical terminology clear, we pass to analyze each of these associative connections. And we start with the first one, that is the arcuate fasciculus. The arcuate fasciculus, it's a connection that has three different segments. The first segment is the long segment that you can see here in red, that goes from the posterior temporal lobe connecting to the middle and inferior temporal gyrus. Then the fibers goes superior, then curve around the caudal end of the sylvian fissure, and goes within the operculum, crosses the parietal and frontal operculum to terminate at the ventral presentral gyrus and inferior frontal gyrus. So here you can see in red the long segment of the arcuate fasciculus. So as you can see, it's a tract that is perisylvian. This is the sylvian fissure, so it's within the operculum, within the frontoparietal and temporal operculum. Then we also have the vertical segment of the superior vertical segment of the arcuate fasciculus, that is here, that goes from the posterior part of the middle temporal gyrus to the angular gyrus. You can see that this tract is lateral to the long segment of the arcuate fasciculus. And finally, the horizontal segment of the arcuate fasciculus, that is here, that goes from the supramarginal gyrus at the inferior parietal lobe and goes in an anterior direction to terminate at the ventral part of the presentral gyrus, at the ventral part of the presentral gyrus. So this is the horizontal segment, and again, it's lateral or superficial to the long segment of the arcuate fasciculus. Here is a dissection of the long segment of the arcuate fasciculus, and you can see very well here the pars triangularis, the pars orbicularis, and the pars opercularis of the inferior frontal gyrus. So posterior to the pars opercularis, we have the presentral gyrus, the ventral part of the presentral gyrus that we have dissected. And here is the insula. So here we see a long connection that goes around the caudal end of the insula, coming from the temporal lobe, from the posterior temporal lobe, going around the caudal end of the insula and terminating at the mainly at the ventral part of the presentral gyrus. So the ventral part of the presentral gyrus, it's a very important anatomical area that it's located. The presentral gyrus is here. Here is the central sulcus. So the ventral part, as we said, ventral is inferior. So the ventral part of the presentral gyrus, remember the dog anatomy, ventral is inferior and dorsal is superior. So the ventral part is here, is the most ventral part of the presentral gyrus. And this area is very important because, as you can see, there is a termination of three important connections. This is the horizontal segment of the arcuate fasciculus terminating at the posterior part. Then we have the long segment of the arcuate fasciculus terminating a little bit more anterior. And then we have this connection that is the pyramidal pathway. And this is very important because this is the area where we, when we stimulate, we induce speech arrest. We have the block of counting. The patient starts to count 1, 2, and gets blocked and cannot continue counting. And this is because we are stimulating this ventral part of the placental gyrus. In fact, is the determination of the language connections, and is the final output for language. There is a final output area for language here, because here are the connections of the pyramidal pathway to the brainstem, to the phonatory musculature, and to the phonatory nucleus at the brainstem. Here is a detailed view of the termination of these two tracts, these three tracts at the level of the ventral part of the precentral gyrus. So to explain this anatomy, it's important to have a surgical case. So here you can see a temporal lobe tumor. It's a low-grade glioma, a recurrence low-grade glioma. So as you can see in the tractography, the posterior part of the tumor is related to the long segment of the arcuate fasciculus and also to the vertical segment of the arcuate fasciculus. I always review the anatomy for planning a surgical case in the surgical position. The MRI, I put it in the surgical position because I think it's very useful to orientate during surgery. Because if not, you can get lost if you review the anatomy like this and then operate the patient like this. It's very easy to get lost. So if you review the anatomy like this, the case like this, it's easier to orientate during surgery. So as you can see here, the tumor is here, and at the posterior part of the tumor, we have these connections, the vertical segment and the arcuate fasciculus, the long segment. So we are expecting to find function at the posterior and superior margin of this tumor. It's a recurrence tumor. We use intraoperative electrical stimulation with this bipolar electrode. So we apply this electrode to the brain, and here is the surgical view. Here is the MRI in the surgical position, and here is the head with the surgical perspective. It's a recurrence tumor, so you can see the surface is a little bloody because it was difficult to open the dura mater. But you can see here at the ventral part of the placental gyrus, here is the central sulcus. So at the ventral part of the placental gyrus, we have a speech arrest area at the termination of this arcuate fasciculus and pyramidal pathway. And here we have the projection of the tumor. This is the Sylvian fissure. And here we have the projection of the tumor. And at the posterior margin of the tumor, we have areas of anomia. So here we were expecting to find function at the cortex. And here is where we found the function cortically. And also subcortically at the white matter, at the posterior margin of the tumor, we identified areas of anomia. So here was the connection of the arcuate fasciculus, and here is where we found the functions cortically and also subcortically. This is the postoperative tractography. Here is the surgical cavity, and there is a small residue related to the posterior margin of the tumor where it was infiltrated by the arcuate fasciculus. So here is where we found the function, and we have to leave a small residual tumor. Okay, so this was the arcuate fasciculus. We now pass to the superior longitudinal fasciculus. The superior longitudinal fasciculus is, as we say, longitudinal, so parallel to the major axis of the brain. And this tract is composed of three connections. This is the first connection. The first connection is more medial and goes from the supplementary motor area from the superior frontal gyrus to the precuneus, to the superior parietal lobe. In green, the second portion of the superior longitudinal fasciculus goes from the middle frontal gyrus to the supramarginal gyrus. And the third portion is here, that it's more lateral in purple and goes from the inferior frontal gyrus and placental gyrus to the supramarginal gyrus. So there is controversy in the terminology because, in fact, this third portion of the superior longitudinal fasciculus is the same connection as the lateral portion or horizontal segment of the arcuate fasciculus. So this connection is the same as the lateral or the horizontal segment of the arcuate fasciculus, because this connection is at the same position within the frontoparietal operculum. We can see here in another tractography the first segment of the superior longitudinal fasciculus, in green the second segment, and then we see the long segment of the arcuate fasciculus, and in purple we see this connection that it's the horizontal segment of the arcuate fasciculus, but at the same time is the same tract as the third segment of the superior longitudinal fasciculus. So this is the superior longitudinal fasciculus. So just remember that it has three segments and that is different from the arcuate fasciculus, but that this third segment is in fact common to the arcuate fasciculus and the superior longitudinal fasciculus. Then we pass to the medial longitudinal fasciculus. The medial longitudinal fasciculus, it's a deeper connection. So it's deeper to the long segment of the arcuate fasciculus. Here we can see the insula. Here we can see the long segment of the arcuate fasciculus. And just medial to the long segment of the arcuate fasciculus, we see this medial longitudinal fasciculus. The connection goes from the posterior part of the superior temporal gyrus, just below the arcuate fasciculus, and goes and terminates at the superior parietal lobe and intraparietal sulcus. This is the medial longitudinal fasciculus. It's a short, long connection, but a thin tract. And you can see the difference between you can confuse the vertical segment of the arcuate fasciculus with the medial longitudinal fasciculus. The difference is that the vertical segment is lateral to the long segment of the arcuate fasciculus, but the medial longitudinal fasciculus is medial to the long segment of the arcuate fasciculus. This is the dissection of the medial longitudinal fasciculus. So here is the Sylvian fissure here. Here is the temporal lobe. So superior temporal gyrus, middle temporal gyrus, and inferior temporal gyrus. And we had opened the inferior temporal sulcus. If we open this area, we identified the tracts, and here we see the vertical segment, the arcuate fasciculus, the long segment of the arcuate fasciculus, and just medial to the long segment, we see the medial longitudinal fasciculus. The medial longitudinal fasciculus, as you can see here, terminating at the superior temporal gyrus. Here is a surgical case where we identified function related to the medial longitudinal fasciculus. So here is the tractography. You can see the tumor here. Here you can see the arcuate fasciculus, the long segment, and here you can see a connection that goes from the temporal pole and the superior temporal gyrus to the superior parietal lobe and goes medial to the long segment of the arcuate fasciculus. So this area, this tract corresponds to the inferior longitudinal, to the medial longitudinal fasciculus. The inferior longitudinal fasciculus we will see later, but it's here. It's totally different to this connection. Here again, the surgical perspective, the surgical view to review the case. Here is the surgical, after the craniotomy, surgical view. Here we can see the Sylvian fissure. So here is the tumor. And as you can see at the temporal part, at the temporal pole and the anterior temporal lobe, we identified cortically areas of function. And also anomia, for example, here again, speech arrest related to the ventral presentral gyrus, and here are areas of anomia. After performing the craniotomy, the resection, we see that there is function at the level of the cortex and also at the level of the white matter. So this area here, this label here corresponds to this area here. This is a screenshot of the nerve navigation system during surgery and corresponds to this green tract here, that is the medial longitudinal fasciculus. So in this case, the medial longitudinal fasciculus was functional and related to language. Then we go to the inferior longitudinal fasciculus. The inferior longitudinal fasciculus, you can see here the tract in blue. It's a connection that is longitudinal, so parallel to the major axis of the brain, and it goes from the anterior temporal lobe here, from the temporal pole, to the posterior temporal lobe and to the occipital lobe. the inferior longitudinal fasciculus is not a perisylvian connection. It's far away from the operculum. It's at the level of the depth of the inferior temporal gyrus. So we have to open the inferior temporal gyrus and reach the inferior longitudinal fasciculus that is very basal at the temporal lobe. Its close is in direct contact, as we will see, to the ventricle, to the temporal horn of the ventricle. So here we can see the middle longitudinal fasciculus in red, the long segment of the arcuate fasciculus in orange, and the inferior longitudinal fasciculus just in blue, just below the arcuate fasciculus. Here is the dissection of the inferior longitudinal fasciculus. We had opened the temporal lobe to dissect this area, and here we can see the temporal horn of the ventricle. So here we can see the hippocampus, and here we can see the vertical segment, the long segment of the arcuate fasciculus. And here the middle longitudinal fasciculus just passing below the arcuate fasciculus. And what we see here is the inferior longitudinal fasciculus, it's here. So we had here and here. This is the tract, the inferior longitudinal fasciculus. So we had opened the inferior temporal gyrus, that is here, to get to the inferior longitudinal fasciculus that is located right here. So it's very close to the ventricle. We have moved the tract, but this was attached to this, and it's very close to the ventricle, very close to the lateral and inferior surface of the ventricle. Here is another dissection of the inferior longitudinal fasciculus here. This is a surgical case where we identified function related to the inferior longitudinal fasciculus. So here is the tractography reconstruction of the inferior longitudinal fasciculus. Here is the tumor going from the temporal lobe to the insula. Here is the surgical view of the tractography. Again, so we are expecting to find a function at the inferior and posterior part of the tumor. So here we are expecting to find a function related to the inferior longitudinal fasciculus. See, here is the surgical perspective once we have performed the craniotomy. Again, the Sylvian fissure here, the area of speech arrest here, and here at the posterior part of the superior temporal gyrus, we identified function. Here is the projection of the tumor. And here, once we have resected the tumor, we identified at the inferior and posterior margin of the tumor, we identified areas of anomia that corresponds to this white matter, that corresponds to the inferior longitudinal fasciculus. Here we can see the insula surface in this corner. And here is the another picture where we can see this label here corresponds to this blue tract here, that is the inferior longitudinal fasciculus. Okay, and now we pass to the tracts related to the insula, that is the uncinate fasciculus and inferior frontoccipital fasciculus. So we have talked about the tracts that goes in the operculum and the inferior longitudinal fasciculus and the superior longitudinal fasciculus, and now the two only tracts that cross through the insula, that pass below the insula, that are the inferior frontoccipital fasciculus and the uncinate fasciculus. The inferior frontoccipital fasciculus, here in red, is a long connection that goes from the anterior frontal lobe at the level of the basal frontal lobe and frontal operculum, and then the tract crosses through the insula, through the anterior isthmus and superior isthmus of the insula, gets within the insula at the ventral part of the insula, the ventral part, so inferior part of the insula, and then crosses the temporal isthmus to get to the temporal lobe, and then goes at the sagittal stratum, medial to the arcuate fasciculus, as you can see here, to terminate at the superior parietal lobe, occipital lobe, and temporal lobe. So here is the inferior frontoccipital fasciculus. And we also have the uncinate fasciculus, that is a connection that is a little bit more anterior and more ventral to the inferior frontoccipital fasciculus. Is a hook-shaped tract that goes from the temporal pole, from the anterior temporal lobe, crosses the temporal isthmus, crosses through the Lymen insula, and then terminates at the basal frontal lobe, and at the basal frontal lobe. So this is the uncinate the uncinate fasciculus. So as you can see, both tracts pass through the insula, through the ventral part of the insula, at the level of the lumen insula, at the level of the most ventral and ventral and anterior part of the insula. Here is the dissection of the inferior fronto-occipital fasciculus. As you can see, here we have removed the insula surface, and what we see is this. Here is the temporal horn with the hippocampus, and here is the inferior fronto-occipital fasciculus going from the frontal lobe, from the operculum of the frontal lobe, crossing through the insula at the ventral part of the insula, lumen insula, that is here, and then goes posteriorly just below the arcuate fasciculus that is here, below or deep to the arcuate fasciculus that is here, to terminate at the parietal lobe and the occipital lobe. And here we see the uncinate fasciculus. So if we elevate the inferior fronto-occipital fasciculus like this, what we see below is the optic radiations. These are the optic radiations here that are just below the inferior fronto-occipital fasciculus. And just below that, we see that there is the tapetum and then the temporal horn of the ventricle. And here we see the uncinate fasciculus going, crossing through the ventral part, through the lumen insula, going from the temporal pole to the frontal lobe and crossing through the lumen insula, just a little bit more ventral and rostral to the inferior fronto-occipital fasciculus. You can see here that medial to the inferior fronto-occipital fasciculus, we see the putamen, the lateral surface of the putamen. And here we will start to see the lenticular striate arteries. Here is a surgical case where we found the function related to the inferior fronto-occipital fasciculus. Here is the tumor going from the temporal lobe to the insula. Here is the surgical view, the surgical perspective. Here is the inferior fronto-occipital fasciculus. Here is the surgical view once we have performed the craniotomy. Here is the projection of the tumor. Here is the functional areas we identified at the cortex. And subcortically, here we found at the temporal isthmus, we found a semantic periphasia. A semantic periphasia right here that corresponds, as you can see here, to the inferior fronto-occipital fasciculus. The inferior fronto-occipital fasciculus is part of the ventral semantic stream of language. So if we stimulate this tract, we are expecting to find semantic periphasias. So here, semantic periphasias related to the inferior fronto-occipital fasciculus. Here is a screenshot of the neuronavigation system. And here is the postoperative tractography, where you can see a residual tumor related to the tract, but the tract was preserved. Okay, and just to finish the presentation, I think that it's very important to understand that all this, we study this connection in order to all of these connections one by one, because it's the best way to learn. But we need to know that they are all very close to each other within the brain. So when we perform a surgery, we have to have all of them at the same time in our own mind in order to identify the different areas, because they are, all of these connections are very close one to each other, just separated by a few millimeters. There are specific areas within the brain where there is an intersection of lots of connections, lots of tracts, that these areas are very important. And one of the most important area is here at the posterior part of the temporal lobe and the inferior parietal lobe, where there is an intersection of 7 different associative tracts. As you can see here, there is this area, there is an intersection of the vertical segment of the arcuate fasciculus, long segment of the arcuate fasciculus here, middle longitudinal fasciculus in red here, the inferior longitudinal fasciculus, also very close, the inferior fronto-occipital fasciculus in pink, in red, in green, the optic radiations, and also the tapetum just medially. So if we go from medial to lateral, we see first the tapetum, then the optic radiations here, then the inferior fronto-occipital fasciculus here, then the inferior longitudinal fasciculus here, middle longitudinal fasciculus, long segment of the arcuate fasciculus, vertical segment of the arcuate fasciculus. So as you can see here, there is this area And if we do a surgery here, we will have all these connections very close. But as you can see, if we perform a surgery here, we are also have lots of connections very close. The medial longitudinal and the inferior frontooccipital fasciculus are just separated 1 millimeter one to the other, and same with inferior longitudinal fasciculus. So we need to know all the connections, all the anatomy at the same time. This is the area where there is the projection of these 7 tracts. So if you want to find this area here, you have to find it at the posterior part of the inferior parietal lobe. Here is the angular gyrus, and the posterior part of the superior, medial, and inferior temporal gyrus. So here is the area of fiber intersection. And this is the dissection of this area here, where you can see this. Here is the insula, and you can see all these connections here: vertical segment, long segment of the arcuate, medial longitudinal, inferior frontooccipital fasciculus crossing through the insula, optic radiations, and inferior longitudinal fasciculus. Here is the temporal horn. So here, in this white matter block, there is the intersection of 7 different connections. And here, just to finish, it's a surgical case where we were very, very close to this area, temporoparietal fiber intersection area. As you can see, the tumor is here, so the superior margin of the tumor is related to all these connections. Here is the surgical view, the tractography. Here is the tumor, so the superior margin, we are expecting to find function. Here is the surgical view once we have performed the craniotomy. Here is anomia. And once we have resected the tumor, at the superior margin of the tumor, we found function at the superior margin of the tumor related to the arcuate fasciculus, vertical segment, inferior longitudinal fasciculus at the level of the cortex and also at the level subcortically. And again, there is a small residual tumor related to all these connections. So just to finish, wanted to invite all of you to this online advanced fiber mapping course that we are organizing for next January. It's all online course, and we review the anatomy, the brain mapping concepts, and surgical cases. So thank you very much for your attention, and I will be delighted to answer any question. Thank you very much.
Joanne, that was absolutely fantastic presentation. And I'm very happy to hear from you. And I'm sure that many people in the audience who are young students of neurosurgery, young students of the brain, young students of the fiber tracts, and more than anything else, young students of glioma surgery will be benefited by a very fantastic lecture. And I'm sure there will be several questions, but the chairman of this session, Dr. Vernon Bello, has said that the questions can be after every talk. So we will hold on, and I will like, if there is any faculty member who wants to make a comment. Otherwise, we move on to the next speaker.
Hello.
So, yes.
We'll take the questions later on. So we move on to next talk. I think John has to stop sharing his screen.
You on?
Sí.
Yeah, please stop sharing the screen.
Yeah.
Excuse me?
Share. Stop sharing.
Okay, yeah, 1 second. I have to... yeah, okay.
Yeah, Rishi.
Yes, better. Very good, John. Very fantastic.
Yeah, so the next talk. We'll move on to the next talk by Thomas Santorius, which will be on the anatomy of brainstem and cerebellum. So this will be moderated by Professor B.K. Mishra, sir. who is head of the Department of Neurosurgery and Gamma Knife Radiosurgery at PD Hinduja Hospital in Mumbai. And he is a past professor of Department of Neurosurgery at Richitra Institute in Trivandrum, clinical professor at Department of Neurosurgery, New South Wales, Australia. He is a recipient of prestigious BC Roy National Award for Eminent Medical Person in 2018, as well as International Lifetime Recognition Award by ANS. He is first Vice President of World Federation of Neurosurgical Societies and Honorary President of ANS, and he is the President of World Federation of Skull-Base Surgery. So over to you, Mishra sir.
Hello, good afternoon, good morning, good evening, everybody. It's a pleasure to see our friend, Mr. Thomas Santarius, who is going to contribute to the anatomy session here. Mr. Santarius has come here before. He has, in fact, demonstrated in Grand Medical JJ Hospital, the anatomy lab, Vernon, which he had organized, I think, a couple of years back. Mr. Santarius is a consultant neurosurgeon at Edinburgh Hospital, as well as an affiliated lecturer in clinical neurosciences and affiliated lecturer in physiology, development, and neuroscience at the University of Cambridge. His clinical practice is almost entirely focused on brain tumor surgery, especially meningiomas. He has significant work on meningiomas, which is very, very eminent work there. I'm aware of it. And also diffuse low-grade gliomas, ventricular and periventricular tumors, pituitary adenomas, and other cellular tumors. Mr. Thomas Santarius is going to talk on brainstem and cerebellum. Thomas, please go ahead.
Professor Mishra, thank you very much for your kind introduction. It's a true honor to be introduced by you. I'd like to say hello to everyone in India. Sadly, we can't travel there physically, but it's wonderful that we can connect via the internet. And particularly, I'd like to say thank you to Professor Vernon Bello and all his colleagues for preparing this truly wonderful meeting. And I'm really learning a great deal. I will get the talk up and running in a second. I believe it's on the screen, but I need to get it on the first slide. So moving from the ground floor to the basement, what I often call the posterior fossa, and there's a lot to talk about brainstem and cerebellum, brainstem in particular. So I thought let's narrow down the topic a little bit, and I came with a little subtitle: "What's around the fourth ventricle?" And I need to acknowledge some of the sources that I'll be using. Especially Professor Roten, who has a great deal influence on whatever I've been doing, and so did Professor Hibas and Rames Kirolos. And some of the slides, wonderful slides, have been produced by, or the dissections by Dr. Yagmulu, and you can actually find them in this book, which I'll recommend, that has also 3D images if you'd like to use. But let's start from the beginning, from the creation. It's always worth remembering the very basic architecture of the brain, and the fact that the brain started as a neural tube, and the neural tube has on the inside ependyma, on the outside pia, and in between there is a brain, and inside the ependyma, or inside the tube, there's a ventricle. And during the development, the tube undergoes various different growths and bends and so on. And this is sort of exhaust pipe of a car, just to show what happens if you bend the tube. You know, it will in some areas become wider and thinner, and in some places so thin that it will even perforate. And similar thing happens during the development, particularly of the brainstem. And you will see later on in some areas of the brain, there's a thick area of the brain between the ventricle and the pia, like here in the telencephalon. In some areas, there's sort of medium amount of neural tissue between ependyma and pia. And in some places, pretty much there's no brain whatsoever between ependyma and pia, and the PL vessels, because the arteries come pretty much with pia. There is a complete opposition of ependyma to pia, and of course we have choroid plexus. So that's an example from the supratentorial compartment, but similar thing happening in the infratentorial compartment. And this is a good example of when there is complete thinning of the neural tube, where there is no brain tissue between the ependyma and pia, and we have the tila choroidea of the fourth ventricle. And further distally in the midline, the thinning is so thin that even the ependyma and pia get perforated, and we have foramina of Magendie. More laterally, as you know very well, we have foramina of Luschka. If we continue from complete hole to no brain to a little bit of brain tissue, we had inferior medullary velum, where there is a little bit of brain in between. And as you will see later on, the inferior medullary velum is actually connecting the sort of lowest part of the cerebellum, forming the uvulofloccular lobe, nodulofloccular lobe. So that's pretty much it. So you have the inferior medullary velum here, flocculus and nodulus here, and there's a bit of there's a tonsil, there's a uvula, and if we lift the uvula a little bit or look from the side, we have nodulus. So let's talk about the roof, because I kind of started talking about the roof a little bit. So the fourth ventricle has this kind of tent shape, and the tip of the tent, or the apex of the roof, is called fastigium. And it's called fastigium because fastigium is another word for apex, and it's also used in architecture, particularly in the classical architecture, when you have the portico over sort of classic buildings like that. So there's a fastigium, and there's upper and lower half of the roof. The upper half of the roof is complete. The lower half, as we discussed, is incomplete because there's two holes. And actually we can use this to gain access from the inferior to pretty much the entire fourth ventricle. Just looking upwards again, the roof extends. The fastigium would be about here, and the upper end of the roof is between two columns, which is the left and the right superior cerebellar peduncles, and in between them is stretched superior medullary velum, and the superior medullary velum is complete. There are no holes in that, and that's the inferior medullary velum, and eventually it becomes thinner and thinner up to the point that it doesn't actually have any neural tissue in between the ependyma and pia, and we end up with a hole medially and hole laterally, i.e. the foramina of Magendie and Luschka laterally, excuse me. So what is underneath the surface? So these are the fibers of the right and left superior cerebellar peduncle, and they are coming from the cerebellar nuclei, the biggest of them being dentate nucleus. So that's again a recap of that. If we spread the tonsils as we've done here, we expose uvula, and underneath the uvula is nodulus, and as we previously discussed, the nodulo floccular lobe of the cerebellum, and we can open entirely this structures here, which is the inferior medulla velum. Although it has brain structure in it, it is not known that it has any function. It pretty much is well known it doesn't have any function, so we can safely do that and gain access to the entire fourth ventricle. This is to show the inferior medullary velum after the choroid plexus has been removed. And note how thin this is and how actually closely it sits on the inferior cerebellar peduncles. We'll talk about it later, but basically on the firm brain structure. It's very relevant functionally because it actually, although it's not particularly taught and known, it does function as a valve mechanism. So as you very well know, brain pulsates like a heart, and it's pretty much like a pump as well. In systole, blood gets pumped into the brain becomes thicker, and it expunges the CSF through foramina Luschka and Magendie, and they open. In diastole, when brain becomes thinner, the pressure of the CSF from outside causes the tila choroidea and the inferior medullary velum to oppose against the brain structures, and pretty much there's no flow into the ventricles unless we have some pathological situations. So what is around? So let's start with some sort of organizational nomenclature here. So we have median sulcus in the center. We have stria medullaris over the fourth ventricle, ventriculi quadripiculomini. We'll be talking about it a bit later on as well. And we have, so these can divide the floor of the fourth ventricle into upper half or lower half, but also we can talk about upper third and lower third, and then perhaps the transitional zone, which is around the foramina of Luschka. It's also known as the vestibular and cochlear zone, because vestibular and cochlear nuclei just are underneath the ependymar right here. The stria medullaris, which are very prominent and useful to know where they are. People always wondering where they come from. Well, basically, they come from, they are sort of internal arcuate fibers that come from the anterior very ventral pontine nuclei, and they run in the midline and then cross on the other side and join usually the inferior cerebellar peduncle running to the cerebellum. So that they are or middle cerebral peduncle, and they are pretty much like the other pontocerebellar fibers running in the middle cerebral peduncle. So we talked about the median sulcus. It's very important to realize that, right next to it and very superficially underneath the ependymar is medial longitudinal fasciculus. And as you know, medial longitudinal fasciculus is an important pathway for coordinating eye movements, and the components of that are output from the abducens nucleus, which is also major center for horizontal pursuit movement. That there are spinal input there is a vestibular input, and they all run right next to the midline. So they're so superficial that if we, even a minor injury will cause internuclear ophthalmoplegia, which of course is virtually impossible to correct ophthalmologically. We had a wonderful lecture about cranial nerves, and we had lots of notes of caution not to injure nerves. And unlike, for example, injury to unilateral trochlear nerve, which can often be corrected either surgically by ophthalmologists, oculoplastic surgeons, or even with prisms and so on, correcting interocular ophthalmoplegia is just very hard. So if we can, we should prevent that from happening. Just going back to this picture, there is the other sulcus which is worth mentioning is sulcus limitans, which has paramedian eminence between it and the median sulcus. And the sulcus limitans has two widened areas, which is the superior fovea and the inferior fovea. And the reason we are mentioning it, because it is also useful orientational landmark, because, for example, in this case, we can see the facial colliculus quite nicely, but sometimes it is not so well visible. So in the median aspect of the superior fovea, we can always find the facial colliculus. Just lateral to it would be inferior cerebral peduncle. In the inferior lateral aspect, we have vestibular and cochlear area. We'll be talking about the inferior fovea later on, but I'll just mention that in here we have vagal triangle. The reason we call it vagal triangle because it looks like a triangle, and also there is there's hypoglossal triangle, and it is triangular in shape and also has hypoglossal nerve fibers underneath. I mentioned vagal triangle by mistake, but the vagal triangle lies laterally and laterally to the hypoglossal triangle and inferiorly to the inferior fovea, and underneath it has dorsal nucleus of vagus, and we'll be talking about it a bit later on, but it's worth using these landmarks to orientate ourselves. Now, I mentioned facial colliculus. We all know that it is not because there's a facial nucleus underneath. There's a abducens nucleus underneath, and the facial is the fibers of the facial nerve, which is located deep in the pons. So here is the facial nucleus, and from the facial nucleus, there's proximal loop and distal loop of the facial nerve that comes out then anteriorly in the pons. And that's the, just as for completeness, and this is spinal tract and spinal nucleus of the trigeminal nerve, and then trigeminal nerve coming out forward in the middle of the pons anteriorly there. And the abducens nerve nucleus is right here, and its fibers running straight forward to come out in the pontomedullary sulcus towards the midline. We could talk about it for a long time, but we need to limit ourselves here just to show again the spinal tract of the trigeminal nerve running deeply in the brainstem, and eventually the nucleus proper of the trigeminal nerve would be around here somewhere. So, for example, when we stimulate brainstem around here, when we do operations, often we might get bradycardias or even arrest simply by stimulating the trigeminal nerve, similarly as you can get bradycardias when you stimulate dura somewhere in the even supratentorial compartment. You will see the relationship to the trigeminal nerve and trigeminal tracts and nuclei, and the ambiguous nucleus a bit later on. So let's look at the cross section. In fact, let's have a look at it now. So these are cross sections through the brainstem, going from more superior and be going more inferiorly. So you can see here there is superior medullary velum. So we are in the upper half of the fourth ventricle, and of course on the sides it would be the superior cerebellar peduncles. This is mostly middle cerebellar peduncle, and bit here you can see the inferior cerebellar peduncle. I will get back to it a bit later on because it's sometimes a bit confusing. And here we have the principal nucleus of the trigeminal nerve. A little bit more medially, we have the motor nucleus of the trigeminal nerve, and right here the dark blue is fibers and the white is nuclei. So here would be the medial longitudinal fasciculus. So here is median sulcus. Right underneath we have the fibers of the MLF, and you can imagine, or you can see how easily you can cause problems with it. There's a lot to talk about. So here is the anterior part of the pons with all these pontine nuclei and the corticospinal tract and corticopontine fibers and pontocerebellar fibers running in the with the brachium pontis, or the middle cerebral peduncle. Here we go slightly lower down in the medulla, and similarly we can see the spinal nucleus of the trigeminal nerve. We can some echo. I hope you can hear me. Can you hear me okay? Okay, we carry on. Hopefully you can hear me. So here is abducens nerve and fibers of the abducens nerve going anteriorly, and you have facial nerve fibers going around the abducens nerve in the facial colliculus. That's the facial colliculus area. Here is something important, because you can see the juxta retiform, which is
Thomas, there is some echo coming, some overlap of the sound. I don't know who, somebody talking. I can't. There are two sounds coming.
Yeah, I think it is because somebody is not muted, and
can the support system please ask everybody to mute?
Yeah, I will mute everyone.
Yeah. Okay, please go ahead. Okay. Sorry, Thomas.
Yeah, I think so.
Muted, Thomas. You are muted. I think the support has muted you also.
I know, but I think I've muted myself now.
Okay.
Can you hear me?
Yeah. Go ahead.
Perfect. Yeah. So here is the inferior cerebellar peduncle with the spinal cerebellar fibers here, and the also vestibular cerebellar fibers that it picks up. Lateral to it is the middle cerebellar peduncle. Here we're going a bit even lower on, so we are at the level of the stria medullaris, and here is the fibers coming from the arcuate nuclei through the anterior internal arcuate fibers that become stria medullaris, and they're joining the inferior and middle cerebral peduncles. Here is again the restiform body, which is the main component of the inferior cerebellar peduncle. So the inferior cerebellar peduncle is running from the spinal cord, mainly having spinal cerebellar fibers in it, sort of deep to the lateral floor of the fourth ventricle and eventually forms the medial aspect of the lateral wall of the fourth ventricle. Yeah, I'll show it to you later on. But I want to point out what I mentioned earlier, that the spinal nucleus of the trigeminal nerve is very close to nucleus ambiguus. So it can be direct stimulation. So as you know, nucleus ambiguus is the parasympathetic component of various nerves, including vagus nerve. And if we were to stimulate it, will cause cardiac arrest, among many other things. But if we stimulate the spinal nucleus of the trigeminal nerve even away from here, and even in fact, purely, let's say, dura or some other part of the trigeminal nerve sensory fibers, it can have effects on the nuclear ambiguous because of its proximal location, and reflexively cause bradycardias and even cardiac arrest. Now, the other nucleus of the vagus, we talked about the vagal triangle. So here is a hypoglossal nerve in the midline underlying the hypoglossal triangle. Lateral to it is the vagal triangle with the dorsal nucleus of vagus. And dorsal nucleus of vagus are also motor nucleus of vagus. Unlike the ambiguous nucleus, innervates motor muscles, such as muscles of pharynx and mouth and larynx. So if we damage, particularly even unilaterally, but particularly bilaterally, the patient will end up with tracheostomy and PEG, because swallowing and protection of the airway will be impaired. So that's because of the dorsal vagal nucleus, unlike the nucleus ambiguus, which is parasympathetic. So here are the centers for control of heart rate and respiratory rate, and all the glands and function of the gastrointestinal respiratory tract and so on. And so, of course, yes, we're talking about certain named nuclei and named fibers, but in between there's lots of dispersed, unnamed, and not very well characterized, because it's just impossible. They're so diffuse and irregular reticular formation. And the reticular formation is developmentally very old and naturally very basically important for our function. I think we just skip that. I'll always be here forever. And just going even lower, now we are in the lower aspect of the medulla. Here we are at the decussation of the pyramid, and you can see that the spinal nucleus of the trigeminal nerve continues all the way down to spinal cord. So, of course, we have this decussation of the pyramids, but also we have another decussation as decussation of the fibers belonging to the dorsal column, medial lemniscus fibers, and so the decussation itself, it's called internal arcuate fibers. As you know, the fibers are running in the dorsal column of the spine, and then form, come and intercalate with the nuclei at the nucleus of the fasciculus gracilis or nucleus gracilis and nucleus cuneatus, and then come on the other side and run along the midline as a medial lemniscus. Here is this kind of cartoon to summarize what we've been talking about in very sort of simplified yet useful way. So here's our abducens nucleus underlying the facial colliculus because of the facial nerve, which then joins the vestibulocochlear nerve running to the internal auditory meatus. Then we have the lower cranial nerves, glossopharyngeal, vagal, and accessory nerve running to the jugular foramen. And higher up in the middle of the pons, we have the trigeminal nerve that we've been talking about, which has its mesencephalic nucleus and then spinal tract and spinal nucleus running period. And here is the principal sensory nucleus of the trigeminal nerve. And then sixth nerve is coming directly through the pontomedullary sulcus in the midline. Now, it is very important to understand the blood supply. Blood supply pretty much coming from the anterior and lateral. For the area that we've been talking about, i.e. the pons and the medulla, and particularly around the fourth ventricle, really pica is the key vessel, of course, with the vertebral and basilar arteries, which hopefully in most surgeries around the fourth ventricle we won't be dealing with very much. And sometimes classifications are not terribly useful, but the classification of the segments of pica are really useful to know, not least because its name. So we have anterior medullary segment, which is from its origin from the vertebral artery, or maybe from the basilar artery, mostly from vertebral artery, to the olive. Then there's lateral medullary segment from the olive to the tonsil. Then there's a tonsillar medullary, and then there's a tilovelar tonsillar, and then we have finally cortical branches going both to the vermis and to the hemispheres. Now, in red we have medullary, and the medullary adjective is relevant because there are perforating branches supplying the medulla. From the tilovelar tonsillar onwards, there is no supply of the brainstem. So we have choroidal branches or cortical branches from the fourth segment onwards. So if we were to damage the pica since then on, of course, we don't want to do that. We will cause cerebellar infarct, not brainstem infarct. And here are the segments. You have the beginning of the pica in its anterior medullary, lateral medullary, and as you can see, I've been listening, I've been learning, I've used Dr. Jawar's beautiful dissection to demonstrate the lateral medullary and the tonsillar medullary segments of the pica, and the pica continues here as the tonsillar medullary segment, and eventually tilovelar tonsillar higher up. So here is the tilovelar tonsillar segment, and from the tilovelar tonsillar segment, the branches pretty much supply choroid plexus, which is the part of the brain that, or the neural tube that doesn't actually have any brain in it. Yeah, so we have tila choroidea with choroid plexus, and there's no brain. The inferior medullary velum similarly is supplied from the choroidal branches, but again, there is no functional brain, so we can take all the vessels if we need to. So this naturally brings us to the tilovelar approach, which again is, I think, worth going through because this is something that I've been using all the time. I generally operate in prone position. It's important to flex the patient, not just in the spine, quote unquote, but it's important to flex the patient in the atlanto-occipital joint, and this allows the cervical spine to be in better plane for us. And also the modern tables allow us to tilt the patients in various ways. It's important to strap the patient. So this is kind of the demonstration that we can tilt the patient downwards and then have the direction of the brainstem more easily. This is kind of cartoon orientation. I usually start from operating from the feet of the patient, and depending on the pathology, particularly if it's higher up in the fourth ventricle, I would then move to operate along the axis of the patient, and strapping helps because one can tilt the patient as you want. So that's not really the craniotomy we do. Craniotomy is much smaller. That's the dural opening, which I call it a red wine glass shape. Here we have tonsils. We separate the tonsils, and then we incise the tila choroidea and inferior medulla velum as on the pictures here, and this opens us the fourth ventricle wherever you want to go. Here is kind of a very good picture showing the inferior medullary velum, superior medullary velum, superior cerebral peduncles. That's the apex of the fourth ventricle called fastigium. We also see here the dentate nucleus. Just anterior to that is the inferior cerebral peduncle, which actually will be running here inside and lateral of the superior cerebral peduncle and dentate nucleus. Remember the mnemonic for the cerebral nuclei: dentate, emboliform, globose, and fastigial nuclei. So again, to show it in greater detail, superior cerebral peduncle, dentate nucleus. If it wasn't 3D, it would actually come out a bit better, but I hope you can appreciate that on the left side of the patient, the dentate nucleus is covered with fibers of the inferior cerebral peduncle here. So let's have a look at the case. 48-year-old woman, progressive dizziness for 5 years, a few months progressive blurred vision, headaches. So we first went to do third ventriculostomy to see whether things are going to improve. Headache got improved, but lots of other symptoms didn't. And you can see she has a tumor in the upper part of the fourth ventricle, right at the exit of the aqueduct of Sylvius. So you can see theta here, top of the head is here, rostral here, caudal here. We can see the left-sided pica, and we can see here the inferior, the tila choroidea with choroidal vessels and choroid plexus. So we simply bipolar it if required and cut, basically disconnect it from the brainstem, and that's the tinea of the tila choroidea. Just bipolar and cut any vessels that we bipolar here that go away from the pica, away from cerebellum, are choroidal vessels, and we don't have to worry about it because they will not cause any infarcts. They are all choroidal vessels supplying the choroidal plexus. So we do the same thing on the other side, identify, buzz, and cut without any trouble. So here you see the inferior medullary velum. Again, we can cut it, no problem. And then we turn, so caudal here, cranial here, and that's the floor with the median sulcus. You saw the colliculi, so the tumor is arising just above the superior colliculi. And not surprisingly, this woman called it blurred vision, but she actually had diplopia with bilateral interocular ophthalmoplegia by damage of the MLF, as we have discussed before. So we are removing this. Now we're looking at the aqueduct. That's the superior commissure at the entrance to the third ventricle. We remove the rest of the tumor, and as you can see, very comfortable, direct view of the entire surgical field and entire tumor. I think we're pretty much done. Yeah, so I think I'll stop here. We could talk forever, but I think there are lots of other important topics to cover. Thank you very much for your attention.
Thank you. Thank you. So we move on to the next talk, which is on limbic and paralimbic tracts by Dr. Pablo Gonzalez. And moderator for this session will be Professor Devpujari sir, who is head of the department at Bombay Hospital and Institute of Medical Sciences, Mumbai. Then he is honorary consultant in Wadia Hospital and a visiting consultant at Gamma Knife Center in Hinduja Hospital, Mumbai. He is currently the chairman of endoscopy and endocrinology committee of WFNS, and he is the past president of NSI, Indian Society of Pediatric Neurosurgery, and ASPN. So he has published multiple books on endoscopic transsphenoidal surgery, clinical neuroendoscopy, practical neurosurgery, pediatric hydrocephalus. He has multiple chapters to his credits in textbook of neurosurgery, WFNS textbook of neurosurgery, and textbook of hydrocephalus. He has published over 71 papers in peer-reviewed journals. He's also the visiting professor at in Shinshu University of Japan, Kuwait National University, and SGPGI Lucknow AIMS. So it's over to you, Devpujari sir, to introduce our next speaker. That is Dr. Pablo Gonzalez. Devpujari sir is there?
Yeah.
Yes.
Thanks, Vernon, and thanks, Rishikesh, for a kind introduction. It's my pleasure to participate in this meeting, and a bigger privilege to watch some interesting talks as well as some upcoming dissection. So my task here is to introduce Pablo. Is Pablo with us already? Okay.
Yes, I don't know if you can hear me.
Great. Nice to see you, Pablo. So Pablo is professor of neuroanatomy at the St. Miguel Hernandez University in Alicante. Apart from being a consultant neurosurgeon, mainly interested in skull base and tumor surgery, and he is very interested in neurosurgical education and is an integral part of the 3DN, the 3D neuroanatomy lab which they have created, and very interested in the training, and I think he is official part of the training committee of the EANS. So over to you, Pablo, for a lecture on limbic and paralimbic system for this talk.
Thank you, Professor Devpujari. I don't know if you can hear me because I have been charging the microphone. That's okay?
It's perfect.
Thank you. So thank you for your introduction. A special thanks for inviting me to this fantastic event. I'm learning a lot from previous speakers, and I'm very happy that Tom, Juan, and Abida have already covered some of the interesting topics about brain anatomy. And let me thank Professor Vernon Velo and his team for this outstanding course. We should be there in Mumbai today, but unfortunately we cannot. But I'm sure in the future we will be able to. So my idea is to try to, as Abida has already introduced, some anatomical nuances brilliantly about the limbic and paralimbic tracts. My plan is to try to give an anatomical and surgical perspective of how we can understand these tracts and how we can optimize our surgical procedures. And I cannot start this lecture without giving credit to my biggest mentors. I spent 1 year with Professor Ture in Istanbul, and I had a chance to learn from them, and also from Professor Yatharpil. And most of the pictures I will be sharing with you today are coming from my work in this fantastic place. So coming to the limbic system, the first concept I would like to introduce is why it's called limbic, and the limbus means the edge, the limit. And indeed, it's the edge, let's say the medial edge of the brain hemisphere. So if we have a look at the medial aspect of the brain, we could see most of the limbic structures, as you can see here in green. We have the parahippocampal gyrus and the cingulate. And it's due to this cephalic flexure that Tom and Abida have already been discussing about. And this cephalic flexure that has been happening for millions of years has been pushing the so-called limbic areas to the medial aspect of the hemisphere. And that's why they have this very, very special shape. And the shape is mainly a circle shape all around the ventricular system and the central core. So here in green, we can see the most important limbic and paralimbic structures. And I will try to discuss in detail some of them illustrated by some surgical cases I have been collecting during these years I have been working in Alicante. So here we have an overview of the most important parts of the hemisphere, and it was Professor Yasser Hill in the 80s who first introduced some surgical perspective of this limbic and paralimbic area. So we have the subcallosal area, which is just below the corpus callosum, as you can see here. Then we have the cingulate gyrus and the cingulate bundle, which is wrapping around the corpus callosum, as you can see here. Then we have a very important structure, which is the isthmus, which is a pivotal point in between the cingulate bundle and the parahippocampal fibers and the hippocampus. Finally, we have the ancus, which is mainly composed by the head of the hippocampus and the amygdala. So let's see how we can optimize this knowledge and apply it to our surgical scenarios. And the first concept we have already introduced is this belt shape of these limbic fascicles. And this is something different to what is happening in the lateral aspect, as Juan Martino has perfectly shown us. And another important issue is where the feeding arteries are coming from in this medial aspect. So most of them are coming from the anterior cerebral artery and also from the distal branches of the posterior cerebral artery. So how we can optimize our approach and apply all these anatomical concepts. So this is something I have been learning from my mentors. You have to go through anatomical corridor. You have to respect the surrounding structures, and you have to try to perform anastomotic manipulation. This is the key in every single neurosurgical approach. And for that, you need a strong neuroanatomy understanding. This is what I believe. You have to try to understand the tumor biology for every single case. And to perform anatomotic manipulation, you need to choose perfectly your approach and position the patient in the ideal position. So finally, you have to try to enter the sick functional unit, trying to respect the healthy tissue and try to stay within the tumor as much as possible. And for that, we have the anatomy, but also we have some intraoperative devices that are really, really helpful nowadays. So let me share with you some cases so we can discuss the anatomy in practical real scenarios. And this is a young patient, 43 years old, that came to the department during the COVID era, last April, if I remember well. He came with some personality disturbances and some headache. He was feeling great, but his wife was complaining about his behavior. So let me share with you how we can optimize our approach understanding the anatomy. And this tumor is mainly located in this area of the brain, just below the genu of the corpus callosum. So here we do have subcallosal area. We also have the subcallosal part of the cingulate gyrus, and two important structures that we should try to discover are the anterior subcallosal sulcus right there and the gyrus rectus. So in this case, all these structures can be visualized. So this is a purely extraventricular lesion. Also, it's invading the ependyma, as we can see here in the frontal horn and the third ventricle, but we can see the gyrus rectus, which is pushed downwards. The genu of the corpus callosum as well as the rostrum are pushed upwards. So the cingulate gyrus is completely intact. So we could say that this is a subcallosal or paraolfactory area tumor. So we decided to perform an anterior, quite anterior interhemispheric approach so as to come in this direction to find the most cortical part of this tumor and to enter this sick functional unit. So the patient is in a kind of lateral position. So this is the midline. This is the anterior aspect. That's the superior and posterior aspect. This is medial and this is lateral. So this is the superior longitudinal sinus. And the first thing I try to do is to identify the bridging veins. So we can see some of these bridging veins which are running to the midline, to the superior sagittal sinus. And if we see them through the dura, it's very helpful to respect them. Sometimes we do have them inside our approach, so we can try to avoid disrupting them. Then we enter the sick functional unit, and we realize that there is a part of the tumor which is being pushed to the contralateral aspect, so we can always open the valves so as to take this part, which is being pushed to the left side. Then we are reaching the suprachiasmatic system, so that's the optic nerve. This is the anterior communicating complex. This is the chiasm, right optic nerve. And finally, we are entering the ventricle. So this is the right frontal horn. This is the septum. I'm doing a septostomy just to communicate and release some pressure. And we are taking the last part of this tumor, which is in the septal area. So this is how we can optimize our approach in order to have a good postoperative course. So here we can see that two important issues are that the hydrocephalus has been released because this patient has a unilateral hydrocephalus due to the compression of the right foramen of Monro, and we have attacked this tumor through the cortical surface of itself, which is one of the concepts I really like about my mentors. So something we have already just discussed is how we can optimize our windows, working windows, trying to respect the veins, and these veins, especially in the anterior third, can enter the dura quite lateral, as in this case. So in these cases, we try to respect them. And otherwise, in other cases, we can have a confluence of these two veins at the level of the superior longitudinal sinus. So in this case, we don't need to respect the dura, and we can reach the interhemispheric fissure. So case 2 is a 53-year-old man who came with headache and seizures to the emergency room, and this is what we found. This looks like a GVM, and we could say that it's invading the contralateral aspect, but if we have a careful look at it, we will see that it's obviously invading the corpus callosum in this area, but this is the anterior cingulate gyrus, which is being pushed to the contralateral aspect, pushing the contralateral cingulate gyrus. It's not invading the contralateral cingulate gyrus. So this is the anterior cingulum. So this is where this tumor is growing, just in front of the genu of the corpus callosum. And if we do a white matter dissection, we will see what's below this cortex. So we have this cingulate bundle, which is wrapping around the genu of the corpus callosum. So this is the direction of the growing of this tumor, mainly in this direction. And obviously, as we saw in the axial cut, it's also invading the lateral projection of the genu of the corpus callosum, also known as forceps minor. So again, in these cases, we do this kind of lateral position. It's a supine position, as you can see, but we are pushing the healthy hemisphere, in this case, the right hemisphere, towards our side, so as to take advantage of the gravity and opening the interhemispheric fissure. So this is the concept I'm trying to highlight. So the idea is to place this patient in this kind of oblique position. So once we release CSF, we will have a direct view of the main part of the tumor arising the cortex. So we will be able to enter directly the cortex without damaging the healthy tissue. So this is what we are doing. So this is the midline. This is the right frontal lobe. And again, we try to respect the veins. That's really important, if we can do it, obviously. We are extending our opening, and then we start trying to release some CSF to relax the healthy hemisphere. And in this case, we needed to open the valves from the beginning because the tumor is on the other side. So this is a contralateral transfalcine approach. This is the GVM, so we are attacking directly. We can see it with 5 ALA. So this is the anterior cingulum. And one of the weak points of this approach is the upper part of the tumor. But in this case, we can use the speculum, or even in some cases, angled endoscope. So we can see how in the roof of our cavity, just below the cingulate sulcus, we have some tumor remaining. So after the removal, this is the view we do have. This is the cingulate sulcus in the contralateral side, and that was the anterior third of the cingulate gyrus. So we try to replace the facts to avoid meningocerebral adhesions. We will use Spongostan, and in this case, this is what we have been doing. We have been going through the contralateral interhemispheric fissure space. This is the cingulate sulcus. This is where that remaining tumor was placed, and we were able to manage it with a speculum, as I just shown you. Let's move a little bit more posteriorly. This is a terrible case which also came to the department during the COVID era. And this patient came with a very, very severe hemiparesis. In this case, this tumor is mainly located in the central aspect of the cingulate gyrus, but it's quite advanced because it's invading the corpus callosum in this area, and it has started growing towards the contralateral hemisphere. In this case, there is something also very important, not only about positioning and choosing the approach, but understanding where the tumor is located. So this is the cingulate bundle, which is wrapping around the corpus callosum. We are in the central area. And when we are dealing with tumors in this area, we must be aware of something very important. This yellow line is representing the corticospinal tract, which is just lateral to the lateral extension of this cingulate gyrus tumor. So this is something we must be aware of. And obviously, we have to try to avoid this approach, this transcortical approach, because we will be damaging these fibers. For that, and to understand it much better, we can have a tractography showing the corticospinal tract in the lateral aspect of this tumor. So that's why, again, we decided to do an interhemispheric contralateral transfalcine approach. In this case, we want also to take this part in the corpus callosum, so we will be able to release CSF after opening the ventricular system. So this is what we want to do, and in my mind, this is the best route in order to have control of the most delicate parts of this tumor. So this is what we will be doing, entering through the left interhemispheric space, trying to take, first of all, the part in the corpus callosum, which is just below the cingulate gyrus. So then once we enter the ventricular system, we will be able to release CSF and then attack this part in the contralateral cingulate gyrus. For these cases, we always do neuromonitoring. And that we are in the contralateral aspect, it may be difficult to understand how we can do that, but if we dissect this contralateral part of the dura, we can introduce these two electrodes in the motor strip and in the somatosensory strip, so we will have direct control of the contralateral corticospinal tract. So this is very important, and we also use transcranial neuromonitoring just in case these ones are failing. So once everything is located and we are sure, again, we go to the interhemispheric fifth. In this case, the venous anatomy was a little bit difficult to deal with, but with patient, the micro dissection, we can create a good space. So once we have dissected these veins, we are watching now the valves there. We try to increase as much as we can. And remember that the veins have 360 degrees layers of arachnoid covering them, so we can open them. And with the ultrasound we are using, we can optimize the opening of the valves, and we realize that the tumor is just in that area. After that, we attack, as we say, the part in the corpus callosum. So we are opening the ventricle. This is the body of the lateral ventricle, of the contralateral lateral ventricle. This is the choroid plexus, which was a little bit attached to the tumor. And again, with the speculum and neuromonitoring in the tip of our suction device, we realized that the corticospinal tract was really, really close of our resection cavity. So that's why we decided to stop surgery there, and we left a remaining of this tumor just in more lateral part, but our goal in this GVM was to try to respect as much as possible this corticospinal tract. So this is the close relationship I wanted to show you in between the cingulate gyrus and the corticospinal tract in the central aspect. Let's move a little bit more posterior, and this tumor is mainly, this is a metastasis, carcinoma, and it's located in the posterior third of the cingulum. So we are moving from the subcallosal area, anterior cingulate, central cingulate, and this is probably the most delicate part for surgery because it's very close to this area here, which is the paracentral lobule. So that's why we have to understand that the function here, motor and sensory, are really, really mandatory to be respected. And also the lateral, again, lateral contact of this tumor with the corticospinal tract, the somatosensory fibers anteriorly and laterally, and the very important tracts that Juan have highlighted, which are located in the temporoparietal junction. So that's why in this case, again, we decided to do an interhemispheric approach, contralateral one, because the bridging veins were quite favorable. So what we wanted to do was to reach this area, and this was our limit, the lateral projection of the tumor with the corticospinal tract and the thalamocortical projections. So this is, again, interhemispheric contralateral transfalcine. Again, the venous anatomy in this case was a little bit tough, but with patients, you can dissect and create a small corridor where you will be working through. So in this area, we will be opening the valves. We can also use the ultrasound to optimize our opening of the valves, because in this case, the paracentral lobule is going to be quite close to the medial projection, medial cortical projection of that tumor. So the metastasis is right here in what we call the ascending ramus or marginal ramus of the cingulate sulcus. So this is the paracentral lobule, and everything behind and below it belongs to this metastasis. So it was quite cystic. So after opening it, we released the pressure and we were able to enter the tumor. And again, with the speculum, I found this speculum really, really useful. We can take the superior part. Superior temporal sulcus. This is T2, and we are going a little bit downwards in order to try to enter this hippocampal lesion from below to try to respect the optic radiations. So once we start debulking this lesion, we will come to the ancus. So this is the carotid artery, this is PCOM, this is anterior choroidal, and this is the ancus, which is completely herniated towards the basal cisterns. So these are our landmarks: tentorial incisura, uncal recess anteriorly, and these are the very, very small hippocampal arteries, some of them coming from P2 directly feeding this tumor. Now we are moving posteriorly to the atrium, which is our posterior limit. And after the anatomical resection, we can see again tentorial incisura, atrium, uncal recess, choroidal fissure, and medially we have the basal cisterns with the carotid artery, PCOM, anterior choroidal, this P1, P2, and this is the third nerve. So if we see this anatomy, we will be sure that the tumor has been nicely removed. And this is the post-op CT scan, MRI, sorry, in which we can see our T2 trans T2 approach decompressing the basal cisterns. Let's move to case 8, which is illustrating again a very important part of limbic and paralimbic areas. Now we are watching these areas from the lateral aspect. This is a baby, 18 months baby with a terrible seizure despite 2 anti-epileptic drugs. And in the MRI, we can see a tumor which is mainly located in 3 different areas. Temporomesial aspect, 1A from Yasser classification. 1B is the amygdala. So you can see also tumor in the amygdala. This is the uncal recess, and this is the head of the hippocampus, which is 1C. So it's a tumor in the temporomesial region, which is extra and intraventricular. In this case, we will do a transplanum polare approach in order to have direct control of all these 3 structures, because in this case, we want also to do epilepsy surgery. So this is these are the 3 structures we want to deal with. We are releasing CSF from the optocarotid cistern, and then we will split a little bit the Sylvian fissure anteriorly, and we'll perform a transplanum polare approach. First structure we will attack will be the temporomesial region. so quite anteriorly, transtemporal, transcortical approach. So we are dealing with the superior surface of the anterior aspect of the temporal lobe. Now we are dealing with the amygdalar compartment, moving posteriorly to the head of the hippocampus. So this is the arachnoid covering the third nerve. In the ankle aspect, you can see the tissue of the tumor, which is quite different. And we are protecting the optic radiations, the Meyer's loop with this cottonoid. So this is the last part of the tumor, which is in the head of the hippocampus. I left a small part of the tumor. So 3 days later, we went to take it out. And this is the post-op MRI. Now it's 6 years since this baby was operated. So she's almost 8 years old. And she's free of seizures and she's free of anti-epileptic drugs. And this is one of the cases that makes you quite happy to overcome our disasters, as the one I showed you before with the subdural, acute subdural hematoma. Case 9, we are almost done. We have been trying to cover most of the important limbic structures. And this is a tumor which is mainly growing, as you can see again, in the hippocampal formation. So this is the ankle recess, anterior limit. This is the atrium, posterior limit. This is the choroidal fissure. So this patient was doing perfectly. He was having seizures, and this was located in the left hemisphere. So in this case, I didn't want to go through the cortex, through the temporal lobe, because of the possible eloquent regions. I didn't do a wake indication in this case. So this is why we decided to do a supracerebellar transtentorial approach, entering through the floor of the tumor, decompressing it, and going anteriorly. So you can see in this anatomic specimen, this is the hippocampus, this is the head, this is the body, this is the fimbria, which is wrapping around the thalamus, pulping around the thalamus. We will see later on. And this is the amygdala. So you can see how the amygdala and the head of the hippocampus are separated by the ankle recess, which is right here in this MRI. So let's go. This is a supracerebellar exposure. So medial, paramedial, suboccipital, releasing CSF. You can see with this small trick, we place a cottonoid in the cisterna magna. So during surgery, we will be releasing CSF continuously in case it is needed. Again, we are using the ultrasound to choose which is the best part of the tentorium to enter through. So we decided to coagulate and cut the tent. This is a trick I learned from Professor Bradley Virbenes to cut it in an L shape. Fashion. So once it's completely cut and we are sure that the fourth nerve is not being damaged, we enter through the hippocampal gyrus, and this is where the tumor is located, just above the parahippocampal gyrus. So this is the superior surface of this hippocampal GVM. So with this approach, the tumor is coming towards us, and after removing that GVM, we can see the choroid plexus, which comes towards us. So sometimes we have to use some tricks and to place some cottonoids to push it upward. This is one of the problems of this sitting position, that not only the tumor is coming towards us, but also the healthy anatomical structures. So this is the post-op MRI in which I left some part of the tumor in the most anterior aspect, but it's not enhancing. So we will use, indeed, we are already using radiation chemotherapy for this GVM. So I have covered almost all of these structures. So this is the external limbic belt, and we will be discussing right now this internal limbic belt composed by the fimbria alveus, hippocampus, and the fornix finally. So sometimes we can find some tumors like this one in which we have this glioma invading not only the parahippocampal gyrus and the external limbic belt, but also the internal limbic belt. So you can see how the tumor is also invading the hippocampus and the fimbria, just attached to the posterior aspect of the thalamus. Here we have, and this is an important point, so this is a Y-shaped growing of this tumor, also invading the isthmus. So the tumor is not only invading the extraventricular part of the limbic system, the parahippocampus, isthmus, and the posterior cingulum, but also the internal part, the intraventricular part of the limbic system, the fimbria, alveus, and the fornix. So the tumor is growing towards this area here. So we were discussing which could be the best approach in order to remove this tumor in one sitting. But in this case, as I will show you, we decided to start again with a supracerebral transtentorial to enter this area, try to go anteriorly as much as possible to remove this temporal part, and then to turn our microscope toward the superior aspect. So this is what we did. We started with this supracerebellar transtentorial, same thing. We release CSF from the cisterna magna. we try to respect these veins if possible. We use the endoscope to get a good anatomical orientation, but also it's very helpful to use the ultrasound to check where we should enter the parahippocampal gyrus from below. So this is the tumor already, and we start debulking. And it's very important to, once we are debulking, to enter as fast as possible the ventricular system. So this is the choroid plexus in the atrium, and we are using now the 30 degrees endoscope to try to go upwards to the part in the isthmus and the posterior cingulum. So this is the pulvinar. This is the part of the fimbria which was attached to it. This is the body of the lateral ventricle. This is where the tumor was growing through the fornix, just attached to the splenium. We are now moving through the temporal horn. So this is the lateral aspect of the temporal horn with the optic radiations. But we left a part of the tumor in the posterior cingulum. So 2 weeks later, we did as an interhemispheric transfalcine approach, small opening in the falx. And in this case, we were able to reach this area much easier than from a supracerebellar approach. So this is the interhemispheric fissure in the right side. So we are approaching the left atrium. So this is the choroid plexus, this is the pulvinar. And now with this endoscopic view, these are the optic radiations in the lateral aspect of the atrium and temporal horn. And we finally took the last part of the tumor growing towards the posterior part of the pulvinar. So understanding the anatomy can help us to optimize approaches. And this is what we did. First of all, supracerebellar to remove this part, and finally an interhemispheric transfalcine approach to remove the part in the isthmus and the posterior cingulum. So we have reviewed all the possible approaches, mainly in the anterior, central, and posterior part of the cingulate. We have to be aware of the positive things about the interhemispheric approaches, medial approaches. But once we are moving anteriorly and laterally into the parahippocampal region, we should consider transylvian, transplanum, transcortical, subtemporal, transtemporal. And finally, in this area here, we can make use of the supracerebellar transtentorial approach in order to expose this anatomy, which is a very, very good approach and very safe in my mind. So just to remind what we have been discussing, and this is the message, go through anatomical corridors. This is why it's important to spend time in the lab understanding the anatomy, respect the surrounding structures, and for that we have to understand tumor biology. And then performing anatomatic manipulation will depend on the approach and positioning, because positioning is key. We must be comfortable with the positioning, but the best thing is that the patient should be really, really comfortable. So limbic system takeaway messages is mainly approach through the interhemispheric fissure, because they have a very, very specific white matter arrangement there. We have already been discussing that. These midline structures are in relation, close relation with the falx, with the interhemispheric fissure, with the arterial system we have also discussed, and be aware of the venous anatomy, which could influence the site of the approach. Lateral exposure, in my mind, will give us a better maneuverability, and we will have the aid of the gravity. And finally, the contralateral transfalcine, in my mind, will give us a better lateral view, and we will have no need to deal with a sick hemisphere in most of the cases. Let me finish with this nice video. The limbic system, as Abida has been highlighting, has been mainly designed to escape and to survive. So this is what this fish has. And these two telencephalic guys have fished this massive one. But what they want to do is take a nice picture for Instagram and for social media. But the fish is much smarter. He wants to survive. And this is what he has been doing, escaping from them. We can use also our telencephalic central nervous system to survive. So this guy needs money to buy food, and he's going to the bank, but then finally he has to escape. So he's using also his renencephalic or pallial areas, and always we have our limbic brain to escape and survive. So I thank you so much for your attention, for your invitation, and I want to thank all my colleagues in the department who are a fantastic team. I'm really, really proud to be part of it. Thank you so much.
Thanks, Pablo. That was a nice tour around the whole paralimbic system and all the possible approaches to reach various areas to achieve maximum kind of a resection. Now, I understand that you are going to show us some live dissection. So does it start immediately or do we have some time for question answers?
I think we'll take some questions till the time Pablo sets up. Rishikesh has those questions which he can address to the respective speaker.
Okay, the one question is from Dr. Mazda Turel. It's for, I think, Pablo. He wants to know, what do you think is the cause of acute SDH in a case of temporal metastasis?
Well, to be honest with you, I cannot tell you. The patient was under antiplatelet medication, but we obviously stopped it 5 days before. And there were some bridging veins in the subtemporal space, but we went quite anterior to them. So I don't know, probably it was due to the release of CSF and we created some space there. I cannot tell. I cannot tell which was the problem. And this is the worst thing. Whenever you cannot identify which has been the problem, you cannot take advantage to avoid it in the next cases.
Thomas?
There's always one reliable answer, the trainee.
It was a trainee. I was quite young at that time.
Any other questions, Rishikesh?
Yeah, I think one is for Johan. This is from Dr. Doris. He finds the term medial longitudinal fasciculus, which is confusing for him as there is one in brainstem. So he's a little confused with that term, Johan. So you can address that.
Yuan, what is the difference between the MLF of the brainstem and the MLF which you talked about? Switch yourself on. You are on mute.
Okay, now, yes. Well, it's totally different. I mean, the medial longitudinal, the one in the brainstem is called because it's longitudinal, is parallel to the major axis of the brainstem. And the other one is totally different. I mean, there are two tracks. One was described many years ago, and the other one was described recently, and they use the same terminology. But as we have a superior longitudinal fasciculus and an inferior longitudinal fasciculus, and it was a tract that is between these two, they call this tract medial longitudinal fasciculus. That's the only reason. But
that's middle, not medial.
Medial longitudinal fasciculus, yes. Yes.
Thank you.
Thank you.
Pablo, I just want to comment. You said going on the contralateral side and opening the fox and then attacking tumor from the other side. Now, in one case, you said you had to leave some tumor behind. What if you went from both sides? Because many times we do go from both sides. We open the fox and move from both sides. So what's your opinion on that?
Well, unfortunately, I have left tissue behind in many cases, but specifically in that one, it was mainly located in the lateral aspect, and I had to leave it intentionally because we started having a response on the motor tract, on the corticospinal tract, which was very close to the limit of the tumor. But obviously, it's very helpful if you can have control with both sides. Myself, I have never done it because as I'm placing the patient in an almost lateral position, opening the ipsilateral side in this case will be quite tough because the hemisphere will come towards me. So that's one of the problems of this lateral positioning I'm using.
Okay, Varnan, can I make a comment?
Yes, please, sir.
Pablo, that was an absolutely fantastic presentation as usual. Now you have become a real master of presenting your work, anatomical correlation, tumor correlation. That is no question fantastic. But you know what, in your previous webinar also, I had told you that this Transfine approach was described by me 25 years ago. But you have failed to acknowledge that. Second thing is, even the supracerebellar approach to middle fossa tumors supracerebellar approach to middle fossa tumor was first described me about 20 years ago. You have failed to even recognize that. And I have a feeling that, you know, if it was your baby, it looks like as if your baby is being taken away by Pablo to Spain. So that is my little bit of a worry. But no, that is just maybe you can ignore those things, but that is a fact that your presentation has been quite anatomical, quite beautiful, limbic system and all those things. But I hope in the corner of your mind, you will thank me for my contribution, which is 25, 30 years ago and published. It is not that it is not published. And even Vernon, what you said about bilateral, you see, I have published even bilateral approach. You see, when I approach AVM, I go from contralateral, I have published this. I go from the contralateral side to take the arterial feeders and then come from ipsilateral side to take the venous and the rest of the nidus. So bilateral approach has also been published. So I think publications have a value and they have to be recognized no matter what. Pablo, yes. Your comment.
Professor Goel, thank you. I'm sorry about not having given credit to you. And it's truth. It's truth that obviously if I said that, I apologize. It's not my baby. Obviously, I did not invented these surgical routes. Obviously, I have invented nothing in my mind. What I'm doing is I'm taking advantage of all the knowledge that I'm getting from you all. And this is I'm very happy to be here in this kind of events because I'm feeding of your knowledge. So I thank you. And obviously I will do it in the next chances.
Thank you. Thank you. We shall now move on to the dissection course, as we have a long session to go also after the dissection course, and we have to see Abida dissecting too. She'll be dissecting after this session number 2. So Pablo, if you're ready, I can introduce our moderator. We have 2 moderators. One is Professor Dev Pujari, who's already introduced Pablo.
Yes.
We have Dr. Suresh Sankla, who is the president of Neuroendoscopy Society. He's the past president of Skull-Based Surgery Society of India, past president Indian Society for Pediatric Neurosurgery, past president Indian Society of Neuro-Oncology, past president Bombay Neurosciences Association, and he's presently a good friend of mine, and in the future also is going to be a good friend and close friend of mine. So Dr. Suresh, over to you to just brief us on what Pablo is going to be dissecting, and then he's going to start the dissection. Over to you.
Thank you, Werner, for this nice introduction. And how much time is Pablo going to take to prepare the dissection? How much time before we start the dissection? It will take 5-10 minutes before we.
I think he's ready.
I'm ready.
Okay, fine. So, just correct me if I'm wrong, Pablo. You are going to start with the dissection of the limbic system and the paralimbic system to begin with. Is it correct?
Well, I was trying to show you some of this anatomy that I have been during the morning, and not in deep detail, because I think Abida, I don't know if Abida is with us now. I think Abida will cover also this area.
Okay, fine. Then you're going to move over to the lateral aspect of the various fiber projections and the fiber tracks like arcuate fiber, SLF, etc. Yes?
Yes, that's my problem. Let's see how it works.
And if the time allows, will you be able to show us some visual fibers and the external capsules and all these structures as well? Correct?
Let's try that.
Okay. Yeah. So, right, Pablo, it's all over to you. Please start.
Okay. So, first of all, let me thank those ones who arranged this live for us, which is mainly coming from Medtronic. So they have helped us a lot placing these cameras here. And secondly, it's something like 35-40 minutes what you planned this dissection to be. And I will be very happy if you let me know the time once I have 10-15 minutes left. And I will also be very happy if this is interactive. I mean, if you interrupt me and Juan and Tom are there, so they could, while I'm doing some dissections, you could comment on that. I think for the latter aspect, Juan has a very, very nice tractography of the most important tracts that we will be dealing with in the temporoparietal area. So really, I am trying to dissect them. I would be very happy if you can, Juan, comment on them or even show your tractographies. So let's start with the medial aspect, where we have been working already in a previous talk. So I have been working on this specimen this morning. So this is the medial aspect, purely medial aspect of the hemisphere, where we can see the most important white matter fiber tracts. And I tried to show you mainly the cingulate bundle. So this is why I was scratching away the cortex on the cingulate gyrus, on the isthmic region. And also, if we move it a little bit, we could even see the temporal occipitobasal area, where we do have the parahippocampal gyrus, in which I have been removing the cortex. So these are the parahippocampal fibers. So as we said before in previous lectures, this cephalic flexure of the human brain has caused this belt-shaped structure of these limbic belts. So external to the ventricular system and just above the corpus callosum, we have this cingulate bundle, which we could dissect and we could try to remove. So if we follow the direction of these fibers, which is actually what the tumors growing here mainly do, we will be able. You let me know if the image is appropriate, because I cannot look at the video.
Very good.
This is the cingulate bundle, and if we follow, this is one of the most important things about white matter dissection. If we follow the direction of fibers during our dissection, we will be able to understand how they are arranged. So this is part of the cingulate bundle. So you can see this belt-shaped structure. This is the subcallosal area. I have already removed partially. This is the anterior cingulate bundle, and this is the central cingulate bundle, which was located and is located very close to the supplementary motor area and the paracentral lobule. So that's why it's important to understand the three-dimensional relationship in between all these fibers. So we can keep going on this dissection, trying to remove the cingulate bundle. So if we remove it completely, we will be uncovering the lateral projections of the corpus callosum. And once we are reaching the isthmic region, it's very important to try to appreciate that the posterior projection of this cingulate bundle is not only going to the parahippocampal area, but also to the precuneus. So here, once we arrive to this area, we will realize that it's quite difficult to remove them without entering the precuneus. So these are the connections from the cingulate to the precuneal region. And the most ventral part of this bundle is joining the parahippocampal fibers in the isthmus, in this area here. Another important belt, limbic belt, in phylogenetic terms, get older, is to have a look inside the ventricle. So here we do have, if we turn it, we will be able, and we push the midbrain a little bit medially, we will be able to see the inner aspect, where we can see the dentate, gyrus, and the lower aspect of the alveus and the fimbria. So let me try to split this colloidal fissure so you can see the fimbria, and I have cut it partially. Once it's wrapping around the pulvinar, which is right here, it's quite attached to the splenium. I have disconnected it to show it to you. So this is the fimbria, crus fornicis, body of the fornix, and here, once we are reaching the foramen of Monro, it goes down in order to reach the mammillary body. So this is the hypothalamus, in which thickness we can uncover the anterior column of the fornix. So if we remove the medial aspect of the hypothalamus in the third ventricle lateral wall, we will see how the anterior column of the fornix, just posterior to the anterior commissure, is joining the mammillary body. So I think Abida has shown beautiful slides and dissections about this area. And the idea was to move now to the lateral aspect. And I have also already advanced a little bit this dissection. And the first part of the dissection consists on removing the cortex, mainly at the level of the inferior frontal sulcus, at the posterior area, where we have the inferior parietal lobule, and in the superior temporal sulcus. So the cortex has been removed. So we are exposing the so-called U fibers, that, as you can see, are U fibers joining, in this case, T1 and T2. For this part of the dissection, I don't know how to make it interactive and not to bore you too much. So let me share with you a case, and maybe we can discuss the anatomy. I'm going to try to dissect based on it. So you let me know if you are watching this case. Can you see it? Yeah, I think so. So this is a 33-year-old man who came to the department, previously operated in another department. An open biopsy gave rise to this diagnosis, pleomorphic xanthoastrocytoma grade 2. So this tumor was mainly located in this area of the brain. And the first thing we have to try to understand is the cortical functional unit in which it is growing. So if we have a look at this sagittal image, we can see the Sylvian figure, and where it's ending, we have the supramarginal gyrus. And if we follow the superior temporal sulcus, where it is ending, we do have the angular gyrus. So this tumor is mainly growing in the number 9 area, just posterior to the supramarginal gyrus. So in the area which we call the angular gyrus. But as we saw in the MRI, it's quite deep. So it's not only in the cortical surface, but even it's reaching the ventricle. So it's crossing many fiber tracts that Juan has brilliantly exposed. So my idea, the patient was neurologically intact, completely intact. He was a right-handed man, and we did the functional MRI, and we checked that dominant hemisphere was located for speech functions, was in the left side. So this is the area we have been discussing, and my idea is to try to show some of these fibers in this dissection we are going to perform together. So this is a nice video I took in Turkey, in which the steps of the dissection are shown step by step. So what's done? First of all, we will identify the frontoparietal operculum, the temporal operculum. We will remove the cortex. We will remove the operculi to expose the insula. But before we do that, we want to see the superior longitudinal fasciculus, mainly in the temporoparietal region. So in order to do that, what we will start doing after removing the cortex in the superior temporal sulcus, inferior frontal sulcus, and the temporoparietal junction. And I have learned this technique from Juan. So Juan, let me show you what I have been doing here. This is T2, near the temporal gyrus, where we have done a cut in this area. And what we want to do is to uncover the association fiber tracts, which are in the center of this compartment. I don't know if it can be easily understood, but for that purpose, I have prepared this slide. So let me show it to you. What we will be doing, first of all, we split the gyri, we remove the cortex, we expose the U fibers. So U fibers are here represented in blue, and this is the first layer we will uncover if we go to the depth of the sulci. But look at the long association fibers. This vertical component of the arcuate, of the SLF3, is going to be represented in green here. So what we want to do, once we have completed this first part, is to do this cut, the posterior aspect of T2, And then once we cut here, we will try to uncover these fibers, long association fiber system. Then we, with the wooden spatula, we will try to push them superiorly. So that's the theory. And we will try to uncover the vertical compartment of the arcuate and the arcuate itself. So let's see if it works. And I have done that in this hemisphere. The light is gonna be a problem. I'm sorry for that. But please let me know if you can see that this cut in T2 and going deep. Can you perceive the direction of those fibers which are going deep? Professor Suresh?
Yes, we can. Yeah.
So what we do again is we just follow the anatomy. So we will be pushing.
Okay.
Pablo, can you have the camera guys zoom in a bit?
I think its zoom is maximum right now.
Okay.
So we are pushing. Indeed, the supramarginal gyrus with the U fibers. So we are exposing partially the vertical complement. Of SLF of the arcuate. And once I complete it, I hope you will be able to realize that it's wrapping around the posterior sylvian point. Now, following the fibers, we are getting into the area of the horizontal segment of the arcuate. So now we have to follow these fibers anteriorly. So here we have the supramarginal gyrus and the angular. So we can see some connections between the posterior temporal lobe and the supramarginal gyrus. These connections are the so-called vertical component of the arcuate, which was represented in orange in your slide, Juan, if I remember well. Once we have realized that, we can remove the last part of this vertical component so as to continue the dissection anteriorly. Let me try to focus a little bit. It's being quite difficult as I am alone here, and that looks better. So now we are moving to the frontoparietal operculum. Where we have the junction of the vertical and horizontal components of the arcuate. So you can see how these fibers are wrapping around the insula in the depth of the operculi. Now we are in a difficult area because we have the central lobule, which is just above, and I'm removing it. And now it becomes much easier once we have crossed it. And we can see in the depth those fibers of SLF3 and the horizontal segment of the arcuate. I don't know if you can see them there. So now that we have the plane, let's keep going anteriorly. And here we have a problem because this is the precentral gyrus. So obviously most
Pablo?
of the fibers. Say
Pablo,
again?
can you hear?
Yes,
Can you hear me, Pablo?
I do. I can.
Okay. Is it possible to put something below the hemisphere so we can see it closer? Yes, like
I
this.
can do this.
Yeah, that way we can see better the fibers, you know, because there is a little, yes, if you put something just below, it will be much better to see the fiber because it's a little far.
Thank you. Let me try to place my box.
Much
Is it better now?
Much better.
Yes.
Okay. So I will repeat again. We started in the...
Yeah, we saw everything just to see the small details of the orientation of the fibers.
Okay, so I'm turning a little bit the hemisphere and I will keep going anteriorly. So trying, I was saying that here we are in the precentral gyrus. So most of the fibers here are projection fibers, which will be crossing and intermingling with this association fiber tract, which is perpendicular to them. So that's why in this area, we have to crack and to break these projection fibers so as to uncover SLF3, directed to the pars opercularis, as we can see. So here we are at the level of the pars opercularis, and most of these fibers are ending there. So now I think we can see much better the anatomy of these two tracts. So here we are, vertical and horizontal, and both together are composing the so-called arcuate. Am I right, Juan?
Yes, yes.
You can see how the, how this, yeah. Let me show you a cranial.
Fibers turn around to terminate in the operculum anteriorly.
Here we have the pars opercularis and how these fibers are terminating right there. So this is the first layer of fiber that we will find in this area where our tumor was growing. So next step of this dissection will consist on cutting the frontoparietal, frontoorbital, and temporal operculi. So that's my plan now. And I'm doing it through the posterior Sylvian point.
Can I make a point, Pablo?
Please.
So my theory is that the SLF fibers actually continue more widespread into the frontal lobe, but these are actually technical issues, both fiber dissection and DTI tractography, particularly because of the crossing fibers that make us think that most of them just stop at the level of M1 or the frontal opercular. Some of the resting state data suggest that actually showing in fact that the connection is actually much more widespread with the frontal lobe than we think.
Thank you, Tom. So now I'm cutting the frontoparietal and frontoorbital operculi at the level of the superior semicircular sulcus of the insula. So I'm gonna keep intact pars opercularis for the time being, so we can see much better how these fibers, let me try to focus. Oops. You are watching all my secrets now. I'm going to use as much zoom as I can. That's okay. Now it looks better.
So what's the next plan, Pablo?
So next plan is to continue the section deeply.
Okay. One more step maybe, because we'll need to stop in a few minutes.
Okay. So here we have the view of the superior surface of the temporal lobe. And a very important gyrus here is the transverse gyrus of Heschel, which as we can see is coming from the posterior insular point. So let me cut this and also the pars opercularis and pars triangularis, so as to see the relationship with the insular surface. So removing the insular cortex, we will be uncovering the extreme capsule, which is right there, the most superficial part, white matter fiber tract in the insula.
Yeah.
That's the extreme capsule.
That's nice.
Usually this could take much more time. So please apologize it. And next step will be removing this extreme capsule and showing the external capsule. Which is right there. And then I don't know if you can perceive a gray area here.
Yeah.
Which is the claustrum. And if we move ventral, we will uncover the uncinate, joining fronto-orbitary gyri and the temporomesial region, which is at the level of the Limen Insula. So right here, we will have the uncinate. If we remove the external capsule, we will uncover the putamen, which will start appearing right now as a gray structure, dark structure. So these are all the fibers of the external capsule. Yeah. And now we will have the putamen. Right there. So let's cut the external capsule fibers and expose the putamen. Generally, right now, we will try to uncover the IFOF and the uncinate, which are just ventral to the putamen. So here we have the junction of uncinate and IFOF. So let me try to do it a bit faster. This is the posterior projection of the IFOF, which runs just below the arcuate. So here we have the relationship in between the IFOF and arcuate. I don't know if you can perceive it. In the ventral aspect of this IFOF, at the level of the Limen Insula, now we work towards the fronto-basal lobe, so we can see close relationship with the uncinate. And this is curious because this is the only fiber tract in the lateral aspect, which is, let's say, hook-shaped, similar to the limbic ones. And indeed, this is a limbic fiber tract connecting the temporal mesial and frontal orbitary gyri. Because if we turn the hemisphere in this area, we will expose the whole limbic and paralimbic system. So let's move now posteriorly. And let's try to remove what I usually do here. So I cut the arcuate partially, so as to prove that the IFOF is just underlying this fiber tract. And now I'm removing the angular gyrus, where that tumor I showed you was growing. So you can see the close relationship and understand much better the close relationship of this tumor with these very important tracts, arcuate and IFOF right there. Even some part of the arcuate is remaining here. If we continue the dissection, you let me know, Professor De Pujari, when you want me to stop.
Well, whenever you think you can. It's the order I am receiving.
Okay. So let me try to do something which generally it requires time, at least for me, which I will be removing now, the putamen, aggressively. And now we should perceive a harder tissue, stronger,
internal capsule,
which is before the internal capsule. We could try to feel the globus pallidus in this area. So this is all putamen. And the globus pallidus is starting to appear here, and we can perceive that it's not as dark. That's why it's called globus pallidus. Because as Professor De Pujari has highlighted, our goal is to reach the medial part of the basal ganglia, the medial limit, which is given by the internal capsule. This is our pallidectomy.
Right. It's very, very well seen.
And this is the globus pallidus. I don't know if you can perceive the different texture, and it's whiter. So now we have the internal capsule in the depth.
Yeah.
So we will see some fibers, projecting fibers. Can you see the internal capsule?
Yes.
Here we have it perfectly. Here I have to work a little bit more. So this is the anterior limb. Here is the genu, and this is the posterior limb. And something that it's quite difficult is to see the anterior commissure lateral projection. But let me try to have a look. So I'm cutting the IFOF and the uncinate so as to have a more ventral view. And here we have it.
Right.
It was by chance, but I'm happy it happened. So here we have some fibers. Difficult to perceive, but these white fibers, this is the lateral projection of the anterior commissure. Can you see it?
Yep.
There? So if we follow it posteriorly, we will realize that it has two limbs. A very small one going to the amygdala, following the direction of the uncinate, and the most prominent one, which is running posteriorly and joining the IFOF and the next layer, which is given by the optic radiations. So let me show you. I'm cutting the amygdala now.
Mm-hmm.
And here we do have nicely the anterior commissure. So if we remove the IFOF and part of the anterior commissure, we will see the next step, the next layer of fibers.
Right.
So anterior commissure and optic radiations.
Yeah.
So to see the optic radiations, what I used to do is I cut the anterior commissure quite medial, and I try to get it in one layer. And this is the best way in my mind to try to uncover the Meyer's loop. So this is the anterior commissure, I have cut it, and I'm gonna push it posteriorly, following its direction. So now we can start understanding the Meyer's loop. So now these fibers, indeed, they belong to the internal capsule, the optic radiations. They are coming from the central core. So you see how they are coming from the lateral geniculate nucleus, and then they are turning 90 degrees and moving posteriorly. So these are the optic radiations. So let me be a little bit more aggressive, exposing all the optic radiations to show how they go to the occipital lobe. Covering, as we said before during the previous talks, covering the lateral aspect of the temporal horn and atrium. So here it's very nice seeing how this Meyer's loop is in close contact with the amygdala here.
Mm-hmm.
And if we touch the optic or Meyer's loop at the level of the ankle recess, we can elevate this Meyer's loop and see the head of the hippocampus. So head of hippocampus, amygdala, ankle recess where the knife tip is located, and the whole hippocampal formation if we move superiorly the optic radiations.
Beautiful.
So now it's understood. And this tumor was growing in this area. So in close relationship with arcuate, with IFOF, anterior commissure, and optic radiations, as we can see here. So now just to correlate this dissection with the case, let me show you the tractography if we are on time. And this is the tractography of that patient. So in green, we do have the arcuate, just anterior to the tumor. And in yellow, we have the optic radiations quite open. So in this case, we wanted to check intraoperatively the arcuate, which was, this is the limit between the tumor and the arcuate. We are stimulating with the tip of the CUSA. So we had some speech problems in this area. So that's why we stopped in this region. And then we started stimulating and looking for the optic radiations. So we were doing an intraoperative campimetry. And once we were stimulating in anterior and inferior aspect, we were having this scotoma. He was describing it perfectly as a shadow, dark shadow. So it means that we are directly in the optic radiations. Once we stimulate the optic radiations, we get a negative stimulation, which means a block of the information. So that's why he was watching this shadow. Again, in the superior aspect of this visual field, he experienced a different one. So that's why we stopped also in that area. And this is how we finally stimulated the calcar avis in the medial aspect. And he perceived a very, very clear central scotoma, which is what has been previously described. So this is the post-op MRI. If you have a look at this post-op MRI, you may think that this patient must have a visual deficit. But the thing is that pleomorphic shunt-astrocytomas, sometimes they completely open the fibers. And this is what the tumor was doing. This is 3 months after surgery. And this is the post-op campimetry in which we realize a small deficit in the inferior field. So I don't want to bore you too much now. So I thank you.
Excellent display of the tracts, and the dissection was really the highlight.
Thank you.
So Dr. Varnan, anybody else has questions?
I had a question, if I may.
Yeah, please go ahead.
Yeah, Dr. Pablo, that was a very impressive dissection. What I wanted to know was the dissection is obviously after much experience. But if you were to start for a beginner, what would you advise? Do you go by feel, or is it by your inner sixth sense?
Thank you. Thank you.
And no, do you do the dissection by feel with the spatula?
Yeah, I understood it. Well, the thing is, obviously, you need to do this dissection many times in order to understand the three-dimensional arrangement of these fibers. Once you do that, these specimens, I didn't mention that, but they are prepared with the Klinger's technique, which means that the brain has been formalized for 2 months and then it has been frozen for a couple of weeks. So what we get with this is that the fibers, the water in between the fibers pushes the fiber with different directions. So if you study properly before doing the dissection, the arrangement of these fibers, the key is to follow the direction of them and to go step by step, layer by layer, like uncovering an onion, and just follow with this is why it's important to do it with a wooden spatula. If you do it with a knife or with a forceps or with a dissector, the Olive Corona dissector, you may break them and you will create a false plane. So that's why the wooden spatula is so useful, because you can go with the fibers and follow their direction. If you do so, you will do it much accurately.
I think you can use an ice cream stick also. The ice cream stick.
It's the same.
Yeah. That's the best way, indeed.
Thank you.
Thank you.
Thank you.
For a very
wonderful. Thank you.
Yeah, I would like just to invite Dr. Kishore Shetty, who is the MMC observer for today, if he could be there on screen. Dinesh, can you have him on screen? Dr. Kishore Shetty is a neurologist. He's a practicing neurologist, and he has passed out through Grant Medical College and the Sir J.J. Hospital. So is Dr. Kishore Shetty there? I have seen him in the participant list. If we can have you on the screen, please.
Is there?
Yeah. So he's the MMC observer for today's program. And thank you for being there and attending the session throughout. Dinesh, can we have him on screen? Yes. Sure. Yeah, good to see you, Kishore.
Same here. I'm enjoying the conference. It's much of neurosurgery, but I'm enjoying it.
Yeah, there's a lot of neurophysiology also going on.
Yes.
And also I see our past president of NSI, Dr. Lokendra Singh here. So, hello, Dr. Lokendra Singh. Welcome.
I'm not past.
Is his president
till December 21?
Sorry.
You have to tolerate me till 21 this month.
Okay. We are sorry for that. Okay.
So do we have a break or do we start with the lectures again?
We take a short break. A short break of 5 minutes, and then we get back to the second session. Those who want to take a break can take a break for 5 minutes, and then we start with the second session. And just to inform the delegates that we would be having another dissection by Dr. Abida Shah. So please don't leave the program. And also it is essential for you all to be there throughout the program to get the certificates. There are a lot of questions being asked. One of the most commonest question is, how quickly do we get the certificates for MMC credit hours? So, I think you'll have to attend the program fully to get the certificate, and which would be given to you by Monday, Tuesday, after we have confirmed that everybody has attended it for more than 4 hours. So those are the regulations, and we have the MMC observer who's still there on the program, so we cannot leave before that. So please see that you are in the program. So
Vardhan, Abhida's discussion is after the next round of talks, or is it now?
She would be doing the dissection. Yeah.
After the talks?
Yes, after the talks.
Oh.
Yeah.
So thanks, Pablo. And if there are any questions related to the dissection itself, maybe you can allow that for a couple of minutes.
Those who want to discuss can discuss. Yuan, you want to say something? Yuan.
Yes. No, I would like to thank Pablo because all that effort to organize the dissection, I have experience on that, and I think it's a complex work to organize everything, and I would like to thank him very much to the effort of doing that. And I wanted to ask him about just a question about these cases he presented in the medial surface. I don't have much experience in this type of approaches, but in the case I had of a cavernoma located right in the isthmus of the cingulum, the patient had a deficit, a postoperative deficit in episodic memory, because I think it's very unknown the anatomy and also the function of all these structures are related to memory, are related to social cognition, but most of us, I think, it's difficult to understand the function of these connections. And I had a patient that after surgery, before he had an hemorrhage related to the cavernoma, but after surgery, he had a deficit in episodic memory, and now he has lots of difficulties to remember the things that have been the episodes that he had experienced. So my question is, what is your experience related to this type of deficits in the hippocampus and the parahippocampus and the cingulum area? Do you have any such deficits, like for episodic memory, or for example, there has been described also deficits related to spatial orientation, like some kind of difficulties orientating with a map, or do you have any patient telling you about this type of deficits?
Well, thank you, Juan. Unfortunately, we don't have in our system. I know you have, but we don't have neuropsychologists. So it's a big effort to send a patient pre and post operatively for a regular deep neuropsychological recognition. So I can just tell you about clear deficits that we ourselves can explore with our team, which are mainly memory problems. And yes, the answer is yes. But I think in cavernomas, the story is different than in low-grade gliomas. Once these low-grade gliomas or high-grade gliomas are infiltrating these structures, most likely these patients have experienced this deficit before. Indeed, most of the hippocampal tumors I have been showing, one of the most common problems the patients were having preoperatively are memory problems, most of them. So obviously you can increase the deficit after surgery, and this is something we don't explore intraoperatively due to the kind of the approach. We don't do these patients under awake conditions. And about the isthmic lesions, I have only been dealing with 2 tumors located in this area, and we didn't experience this kind of spatial recognition or spatial memory problems. But this is a crazy area. Because as we have been able to see during the dissection, once the cingulate fibers and parahippocampal fibers, which carry different functions, arrive to the isthmus, it's not just a connection. That's, you know much better than me, that area. That's a central point in which these fibers are spreading toward the medial aspect of the parietal lobule. So there are many functions that we should explore in this area. And unfortunately, we cannot go so deep due to the lack of neuropsychology in our hospital.
So Yuan, how did you approach that cavernoma?
I did interhemispheric, like approach through the posterior part of the superior parietal lobe, interhemispheric, and
the contralateral approach would be better for a cavernoma, because the cavernoma, if you can go contralateral and have it head on, rather than going from ipsilateral.
Yes.
So it would be a better approach, in my opinion.
To be contralateral, yes. In our case, we did it ipsilateral in the same side, but I agree with you that
you might
it's an option.
Retract a lot to get into the cavernoma.
Yeah, of course. I agree with you that it's a really good option to do the contralateral approach in a case like that.
Professor Goel, do you have any comment on the approach?
Retraction causes much more damage to the brain.
And you know, unfortunately, Vernon, I was a little bit out. Can I see the image again, Joan, if you don't mind?
He doesn't have the image. It was, you have the image, Yuan?
Of this case? No, not here. I'm sorry.
It was a medially based cavernoma, and there was a spatial deficit post-operatively. Okay.
No.
So Harish, can we start the second session?
Yes, sir.
Yeah. So please, I think we should start the second session.
Yeah. So moving on to the second session, we are almost behind the schedule by 40 minutes. So hope the next speakers in the second session make up to the time. So coming on to the first talk in the second session, which will be by Professor Dr. Vernon Vello, and the moderator will be Dr. Hemant Kumar Bhartia. So basically, this second session is to apply the neuroanatomy into the management of surgical management of important lesions in the eloquent areas. So wherein we are dealing with cavernomas in the brainstem region and insular gliomas, intraventicular tumors. So moving on to the second session, the first talk will be moderated by Dr. Hemant Kumar Bhartia. A brief CV, he is a director and head of Department of Neurosurgery at Fortis Hospital, Jaipur. He's an alumni of JJ Hospital and then joined SDM Hospital in 1988 at Jaipur, wherein he joined as a consultant and built the Department of Neurosciences at that hospital till 2009, almost for 22 years duration. And then he moved on to Fortis Escorts Hospital at Jaipur, where he's presently working as director and head of Department of Neurosurgery. And his surgical experience includes he has operated upon almost 12,000 neurosurgical cases, which includes both brain and spine. And he has the experience of more than 500 cases of brain and spine endoscopy. And Dr. Bhartia is a pioneer in the following surgeries, wherein he introduced for the first time the history of Rajasthan neurosurgical era. That includes anterior surgical approach to cervical spine lesions, transnasal approach for the pituitary tumors, endoscopic brain and spine surgery, stereotactic surgeries, artificial disc implants in the cervical region, and odontoid screw fixation for odontoid fractures. So moving on to the second session, I hand over the session to Dr. Hemant Kumar Bhartia.
Hello, good evening. And I have the task of introducing Professor Vernon Vello, who is the first speaker.
नमस्कार डॉक्टर साहब, मी कांबळे बोलतोय.
हाँ बोला.
रिपोर्ट जी दिले होते ना 5 वाजता पाठवून, तुम्ही म्हणाला की 2 तासाने.
नहीं अभी मैं मीटिंग में हूँ. मैं ही फोन करूंगा तुमको थोड़ी देर में.
Okay.
Hello, can you hear me?
Yes.
Yeah. So Professor Vernon is the speaker, and Professor Vernon is professor and head Department of Neurosurgery at Grant Medical College and Sir J.J. Group of Hospitals, Mumbai. He has been elected as president-elect for the Neurospinal Surgeons Association for 2021. He is also executive member of Board of Super Specialties in Maharashtra University of Health Sciences at Nashik. Dr. Vernon did his microneurosurgery fellowship from Fujita Health University, Japan in the year 2002. Dr. Vernon has written some books and articles in some books, like some brain tumor surgery book. And then he has a chapter on transaxillary approach to upper dorsal spine in the WFNS Spine Committee textbook on thoracic spine. He also has written a redo surgery for Arnold-Chiari malformation with syringomyelia, a technical note in recent advances in clinical neurosciences, and also written on extrahexial ventriculostomy, rescue techniques in hydrocephalus. He has published more than 100 papers and has almost same number of paper presentation at various national and international journals and in the conferences. He has great organizational capacity that we are all just seeing it, how his ship is sailing right now. So I don't have to say about his organizational capacity, but definitely I'll have to mention that he has organized more than 30 cadaveric dissections, live dissection workshops. So that is wonderful, Dr. Vernon. He has professional activities and is life member of MNA, MS, ACNS, NSI, BNA, IMA, NTSI, NSSI. And besides this neurosurgery, his hobby is just he plays drums. That is, and he has performed drummer in professional band, that is rock band. And he has fond of Western and Indian music, classical music, and rock and jazz. So let me hand over to Professor Vernon to play his drums and rock the band on management of brain cavernomas.
Thank you, Hemant Bhartiya, for that wonderful introduction. I'm humbled. So just to start, without wasting time, management of cavernomas and experience at our institution. So the first session was a warm-up session for the neurosurgeon. As we all know, that every neurosurgeon before going for a case has to warm up with neuroanatomy, just like a musician, just like a sportsman, just like any other professional. So our warming up is we warm up in the cadaveric lab. We have to get refreshed with our anatomy before we go for a case. And that has to be our principle before doing any neurosurgery. So this is the man who started the JJ Hospital. He donated the property 175 years ago for the poor people so that a hospital could be built. And I cannot start this presentation without acknowledging his good deed. Because of him, we are here. He's Mr. Gigi Boy. And this statue is the first thing which one would see when you enter our hospital. So coming to cavernomas, they're clusters of abnormal hyalinized capillaries surrounded by hemosiderin deposits and a gliotic margin without intervening brain parenchyma. They're basically low vascular malformations. The incidence 0.4 to 0.8% in the general population. The supratentorial are more common, 70 to 80%, where the risk of bleed is 0.8%, and infratentorial are comparatively lesser, where the risk of bleed is 3.8%. So coming to the annual risk of bleed, it is 0.7 to 1.1 per lesion in the first bleed, and 4.5 per lesion if there is a previous bleed. So there is a familial type, which is autosomal dominant, and it gives rise to multiple cavernomas. And we have the sporadic form, which can give rise to a single cavernoma. So if you come to the pathology, the cavernomas are dynamic lesions which grow, bleed, and regress. And there is intralesional thrombosis, calcification, recanalization, and reactive angiogenesis, and which are the typical features. And these are the features which a surgeon should understand when he's excising them. So this is what you see: a thrombus, a thinned out vascular wall, and a hemosiderin deposition. So what are the basic imaging characteristics? It is the MRI of brain, which is the best choice for investigation. They are the T1 and T2 variable signals, which depend upon the age of the blood products. And the classical finding would be a popcorn appearance. There is a hypointense rim of signal loss due to hemosiderin deposition. And there is a prominent blooming on susceptibility weighted sequences. These tumors are angiographically occult, so there is not much of a role of DSA in this type of tumors. So what is the management strategy? One is a conservative management if the cavernoma is incidental, if it is asymptomatic, and the microsurgical resection is the best. It can be done after the first bleed in a non-eloquent area or after 2 or more bleeds in an eloquent area. And brainstem cavernomas have a different type of management protocol. So if they are surgically accessible, one should go in and excise that, especially if the safe entry zones are viable for excision of these tumors. Stereotactic radiosurgery has also been used if they are surgically inaccessible. However, disadvantages of the conservative management is that the natural history is also done by neuronavigation. We use intraoperative monitoring, and the intraoperative ultrasound was very, very helpful in doing these cases. So the surgical approach depended upon the location of the tumor. So this is what we use: navigation, monitoring, and now we also use DTI imaging, which can show us the orientation of the fibers. And the intraoperative ultrasound is a very important tool. So just to show you the first video, this is a young girl who came to us with a depressed gag reflex. She was micro-aspirating. So this is the tumor involving the lower part of the medulla. And she had a depressed gag reflex, so she was tracheostomized and sent to us. When she came to us, she was already tracheostomized. So this is the patient. So she had a pretty depressed gag. She's tolerating the handling of the posterior pharyngeal wall with the tongue depressor. So we went in by a posterior suboccipital craniotomy. We also did an ultrasound localization, which comes in very handy. So we opened the dura down up to the C1 arch. And I think Thomas has explained this anatomy, which you will be able to see here. So you see a slight discoloration over the cavernoma. It is important to preserve as much of vasculature. And here is the cavernoma, which one can see. So that's the superior limit. So one has to do a gradual shrinking with bipolar and a sharp dissection. So we use monitoring during the surgery. And the gradual separation of the tumor from the base achieve a proper hemostasis. This is the tumor which is excised. A check ultrasound to see that everything is out. And achieving proper hemostasis is important. And a closure which is watertight. So this is the post-op scan. And the patient did well post-operatively. She improved, she was discharged, and she was weaned off the tracheostomy, and she went off after 10 days. So this is another patient who came to us in the OPD. The first time I saw her, this was a suprachiasmatic lesion. She was having only headaches. So the first time I saw her, I said, no, nothing doing. We will watch it. But she came back in 6 months with severe headaches, and she said she could not bear to withstand those headaches. So we went in by a small subfrontal craniotomy, and the technique is to develop a plane and to preserve as much as normal brain as possible, because one has to enter normal brain to get to the abnormal cavernoma. I don't use retractors. For me, retractors are a big no-no. If I have to use it, I use dynamic retraction. It would be a number 1 penefill dissector and gradually shrinking the cavernoma by coagulation, getting a plane around it, and the interface between the cavernoma and normal brain has to be identified. And that is excision. One has to be looking out for small daughter cavernomas which can occur. So you have to look out, see that the field is examined properly. And this is the patient who did well. Her headaches have disappeared and she's happy. So she did not have any neurological deficit pre-op, and the responsibility on the surgeon is to see that she does not get the deficit post-op. This is another patient, cavernoma, pretty deep-seated, close to the pons. We use the lateral semi-sitting position for these patients. So this was the position, and this was the entry, 1 centimeter above the trigeminal nerve exit. And this cavernoma had bled recently. If you see, there is fresh blood in it. So this patient had a fresh bleed. Again, no retractors. There's no need to use retractors. Sometimes when it is an acute bleed, it becomes difficult to identify the tumor, cavernoma, and normal brain interface. So a gradual dissection of the cavernoma all around. So it should be a gradual traction and excision. And then a complete hemostasis of the bed. So this is the post-op scan down. So this is a parietal cavernoma. So here one can do a localized craniotomy and a very small topectomy after localizing it with the ultrasound. Preserve as much as brain and veins as possible. And always look out for daughter cavernomas, which might be there in the periphery of these tumors. Sometimes they tend to have daughter cavernoma cysts, like this one. So the ultrasound is very helpful in localizing these small lesions. And that is the bed which one should have post-operatively. This is the patient who did well post-operatively. No deficit. This is another multiple cavernoma in the pons as well as in the temporal lobe. So this patient came with hemiparesis. So we tackled the one on the left side. Again, a lateral semi-sitting position. I don't use retractors. I use the silicone sheet over the cerebellum to retract. And the entry point has to be identified properly. So we're going into the folia, just at the junction of the cerebellum and the pons, and that's the cavernoma. I also use a silicone tip for the suction to prevent any injury because of the suction. So a little bit of coagulation of the cavernoma can shrink it and bring it towards the surgeon. And that is the cavernoma which is out. So one can irrigate, use a little bit of Surgicel if required to cover the bed. That's the post-op scan. We are observing the other cavernoma on the other side. So this is a deep temporal cavernoma. This patient came with severe headaches and also had seizures. You see the lesion is pretty deep-seated. So can you put this on? So here we use the transsulcal approach. It's the left temporal side. Preserve as much as veins as possible. No need to take the veins unnecessarily. So one can go transsulcal. And if you see this cavernoma, it is pretty tough. It is calcified, as you have seen on the MRI. And it is quite deep-seated. It's almost going down into the temporal horn. So if you require to retract, I would prefer to retract on the tumor rather than retract on the brain, and using some cottonoid balls to dissect the cavernoma. This we had to remove it in piecemeal because it was pretty tough. So we had to excise it in a piecemeal as it was digging deep inside down. So we removed one part first. As the topectomy is tailored, so you sometimes have to get it out piecemeal. You can't get it out fully. So that is the interface which you see inferiorly. And you really don't require retractors. If you want to retract, do it with a dynamic retraction with the Penfield dissector. That's the tumor which is out. We have to spend some time on hemostasis. Don't be in a hurry to close. Spend some time in hemostasis. You can also give a Valsalva to check for any venous backflow, because these are sort of venous angiomas. So you can get a postoperative venous bleed in this patient if you do not do a proper hemostasis. So this is the patient. His speech was good postoperatively. He did well. So this is another patient. This was on the left side. We use navigation to localize the lesion, and just a limited, this is the ultrasound, a limited craniotomy. Here we did a topectomy to get into the lesion, and one can tailor the incision on the brain and limit it just to suffice the excision of the cavernoma. Here, if you see this patient, had some cavernomas which were hidden below the bigger cavernoma. They were like daughter cavernomas. Yeah, and this is post-excision. So the surgery of the cavernomas is not that difficult, but in the areas which these cavernomas come, that is the problem. And how to tailor the craniotomy, how to tailor the approach is the challenge for the neurosurgeon. So this is the patient. He's a cricketer. He plays cricket. He's gone back to his cricket because the seizures were causing problems for him. These are some cavernomas which we have done, which we have excised, the symptomatic ones. This is another one, pre-op, post-op. This is a big one, large one, pre-op, post-op. This is another medullary cavernoma, pre-op, post-op. So this was our series. Younger groups were more involved, 10 to 29 years, supratentorial more than infratentorial. And these were the different approaches where we could excise these lesions with. We had some complications, but mostly 2 patients had a deficit and we had 1 mortality. However, the overall outcome of these patients was very good once operated. So coming to discussion, basically they're dilated thin wall sinusoids covered with a single layer of endothelium. This was first reported by von Rokitansky, and the first successful removal was done by Bremer. And the natural evolution of cavernomas is totally unpredictable. So no one knows which one is going to be silent and which one is going to cause problems. However, microsurgical excision, this eliminates the risk of bleeding and seizures, and I feel surgical excision is the best treatment which can be given to them. The supratentorial lesions can be approached by keyhole craniotomies and tailoring of the craniotomies and the approach. Infratentorial, you have to stick to the safe entry zones so that no more additional deficit occurs to the patient. So to conclude, they represent a surgically curable cause of epilepsy and cerebral hemorrhage. Knowledge of the fiber tracks helps in planning a safe entry zone for this excision. Use of navigation, intraoperative ultrasound, and neuromonitoring are useful tools for resecting these deep-seated lesions of the brain, thus minimizing the neurological deficits and morbidity rates. So this is a publication of us which we had done long back, our earlier series. Thank you.
Thank you. Thank you, Dr. Vernon, for a wonderful, comprehensive presentation. Some certain things like surgical approach is one thing, but the most important thing in cavernoma, as you have already said, that is to decide which case you should operate and which case you have to treat conservatively. This is the most important thing, because sometimes in asymptomatic patients in the non-eloquent area also, some of the people have suggested surgery in asymptomatic non-eloquent because of the pressure and the mental stress on the patient's head, and also because of the difficulty in follow-up and the money they spend on medication. So they suggest surgery in such cases. In the brainstem cavernoma, the one which you showed in the pons, I don't know what was it was a first bleed or it was a second bleed, because in brainstem cavernomas, it is said that to operate after the second bleed in most of the cases, because after first bleed, with the post-operative mortality and morbidity may be too high. So it is suggested to operate after the second. And I don't know the experience with the developmental venous anomalies, they are associated with cavernomas. And it is suggested that you should leave aside the developmental anomalies. So overall, the comprehensive presentation, it was excellent, and you covered almost everything. If anyone has any question from the faculty.
Yeah. Dr. Bharatiya, Hemant, can I, Masant Misra here, can I make a comment?
Yes, yes, yes.
Yeah, Vernon, very nice, comprehensive, and I agree with you, microsurgery, the mainstay. I just want to re-emphasize the radiosurgery role in cavernoma is a very controversial thing. We don't agree with it, and we don't want to do. We have not done in last more than 20 years a single cavernoma which has been treated who need treatment by radiosurgery. That's number one. Number two, I think you mentioned that probably, but I just want to re-emphasize, if there are young neurosurgeons there, the main difference between a supratentorial or a non-brainstem cavernoma, to my mind, and a brainstem or a spinal cord cavernoma is to leave the hemosiderin ring in the brainstem and spinal cord. We leave that to avoid morbidity. And quite often in the eloquent areas which you nicely demonstrated, we do it under awake craniotomy with neurophysiology monitoring, because cavernoma surgery is really not very difficult. It is more, if you're going for epilepsy surgery, we would like to have the full neurophysiology monitoring, including corticography associated along with our neurologist in the team to take out the hemosiderin and also excise the area which may be involved with epilepsy. But very nice presentation. I enjoyed it. Thank you.
Thank you. Thank you.
Dr. Bhartia, can I say a word? Quick word.
Yeah, quick.
Go ahead.
Just to inform you all that we have in the UK, we have got a Cavernous Alliance, a UK organization, and they have been awarded about £1 million very recently by the National Institute of Health and Research for a 3-year randomized controlled trial study to address this question: how effective is treatment either with neurosurgery or stereotactic surgery versus conservative management in people with symptomatic brain cavernoma. We have recently started recruiting patients. We get about 120 patients per year at our institute. So this is a nationwide trial, and hopefully this will be able to address the question that Vernon was saying, or everyone is saying, whether really when to go in and when not to go in. So over to you guys. Thank you.
I think what you are saying about this study, because I think there are not many studies which have been, comparative studies which have been done for the stereotactic radiation surgery versus surgery. And also it is said that radiation causes cavernomas, particularly in children. If you give, then there are chances. I think we should, now it is time for the next presentation. And thank you very much, everyone. And I hand it over to Dr. Harish.
Yes, thank you, sir. Thank you, Dr. Hemant Bhartia, and thank you, Dr. Professor Vernon Velo. Now moving on to the second talk by Thomas Santorius on insular gliomas, which will be moderated by Dr. Trimurti Nadkarni. He is a professor and head of Department of Neurosurgery at Nair Hospital in Mumbai, and a visiting consultant neurosurgeon at HN Reliance Hospital in Mumbai. He did his neurosurgery residence from KM Hospital, and then did the clinical fellowship in cerebrovascular surgery at Barrow Neurological Institute in USA under Dr. Robert Spetzler. He did clinical fellowship in endovascular neurosurgery at Seoul, South Korea, and he was awarded NTSC by NCRT New Delhi and National Merit Scholarship, the Ministry of Education and Culture by Government of India, has presentations at several national and international meetings, and has published several book chapters and more than 100 publications in various national and international peer-reviewed journals. He is a recognized teacher of MEHS Nasik and an examiner for MCH Neurosurgical final year exams. Over to Dr. Nadkarni, sir, so that he can briefly introduce our speaker, Dr. Thomas.
Yeah. Thank you, Dr. Harish, for that introduction. At the outset, I need to congratulate Dr. Vernon Velo for this excellent symposium on neuroanatomy. As neurosurgeons, we all know that mastery of neuroanatomy undoubtedly is a must to perform any neurosurgical operation with zero morbidity and zero complication rate. Now, to come to my, it's a great pleasure to introduce Mr. Thomas Santorius. He's a consultant neurosurgeon at Addenbrookes Hospital, Cambridge, United Kingdom. His research has focused on biology and surgery related to brain tumors, including intraoperative brain mapping. His research interests also include those of CSF physiology and chronic subdural hematoma. He's a director of the Cambridge Lectures in Neurosurgical Anatomy, in existence since 2005. He is presently the president of the British-Irish Meningioma Society and has served as program director of the neurobiology program for the Cambridge Cancer Center. Mr. Thomas, please go ahead.
Dr. Nadkarni, thank you very much for your kind introduction. I will get the study up. I hope you can all see that. So the meeting is about anatomy, so I'll talk about anatomy that is relevant to insular surgery. Again, in Dr. Rotten's publications and the related publication, there's a lot of information about it. There is, I could spend the whole day talking about the philosophy of surgery for low-grade glioma. I won't do that, but recently a book came out where we produced a chapter about it. If anybody's interested about my philosophy about it, it can be found in this book. Essentially, it is about obtaining the right oncofunctional balance for the patient. So, of course, onco means maximum survival, functional means maximum quality of life. And we need to balance them somehow, and it's not always easy, and certainly it's not easy in the context of insular tumors. The important issue to keep in mind is the time function, because it's not only about the surgery, what happens immediately after surgery, but how much the patient is willing to invest at the time of surgery in terms of functional impairment, how much of it will get better over time or completely recover, and how much this will influence the outcome medium and long term. Focusing on insulars, these are one of the nicest pictures of the brain demonstrating insula from Professor Matias Baldacchini from Argentina. And I thought I'll show them here. This is good a demonstration, as we have heard many times earlier, that the insula itself is located just deep, covered by the frontal, parietal, and temporal opercula. Now, of course, there are also blood vessels on top of it, which we have to deal with. So surgery, neurosurgery in general, surgery for tumors in particular, it's about getting in, getting the money, and getting out without being caught. And we have to be very wise about it and decide beforehand with the patient whether it is worth going in and how much money we want to take and how much it is going to cost. And one of the things that we need to consider is what route we're going to take. And essentially we have transopercular or transsylvian routes. Some people only use transopercular, some transsylvian. I tend to use both. And as a rule of thumb, I would use a transopercular route as a route of choice, especially if we're talking about low-grade gliomas. Most of the talk is actually about low-grade gliomas, but we can have all sorts of other lesions in there. When I say low-grade glioma, I mean diffuse low-grade gliomas, i.e. gliomas grade 2, maybe grade 3, sometimes difficult to say, or even 4 before we start the surgery. But essentially, this is about diffuse low-grade glioma. The transsylvian route I would prefer if we're dealing with non-glioma lesions, such as cavernoma, for example, or gliomas confined to the insula. We know very well that most diffuse low-grade glioma, diffuse gliomas are actually not confined to the insula. Often they are frontal insula or temporal insula, or even most commonly frontotemporal insula. And if there is any, if let's say the patient cannot be done awake and we are quite sure that there is no speech dominance in that patient on that hemisphere is also okay to do it. You know, we have to do it asleep. Now, what are the dangers? What can we damage? Of course, it is cortex, and cortex is probably the most forgiving. Again, depends where, and we'll talk about it. And in the case of insular surgery, we have to keep in mind pars opercularis, perhaps also pars triangularis, but mostly pars opercularis. And there is M1, and there are superior temporal gyros, as we've seen, particularly the posterior part. And, you know, we don't really go through supramarginal gyros, but in theory, that's something we also have to keep in mind. Now, more importantly, it is the white matter. We don't have really time to discuss why, but the particular concept fibers that we need to keep in mind is arcuate fasciculus that we talked about it quite a lot, which can particularly result in phonological paraphasias and mentalization to an extent. Inferior fronto-occipital fasciculus, particularly semantic paraphasias, but also mentalization, and uncinate fasciculus involved in mentalization to an extent, as we discussed earlier. And then there are optic radiations and of course, corticospinal tract. And last but not least, vascular issues, which we'll discuss in greater detail. Now, of course, we know that there is certain sort of condensation of fibers in certain areas, which we call fascicles and so on, but in reality, things are a little bit more complicated than that. And we're spending a bit of time trying to study preoperatively, postoperatively, and also intraoperatively various networks, functional networks, which I think will become more and more important. Again, a little recapitulation is always worth keeping this sort of paradigm very clearly in mind. So temporal lobe here, frontal lobe here. There's the cortex of insula, and there's first layers of white matter, which is the extreme capsule. Then there's claustrum that's very thin, usually posterior inferiorly located, bit of gray matter, and then there's external capsule and putamen, which together with a chordate nucleus forms striatum, and deeper to that is globus pallidus, then anterior and posterior limb of internal capsule and thalamus. Of course, this is for junior trainees and potentially medical students who are with us. And once we know that, when we look at scans, whether they have any lesions or not, you will actually understand the scans much better. Again, you can see in gray matter, there's a simple T2 scan, gray matter of the insula, and then we have extreme capsule, claustrum, external capsule, putamen, chordate nucleus, anterior posterior limb on internal capsule, and thalamus. So once we know the anatomy, we will see much more on even and very simple scan. So here is to recap the dissection again. So the insula is covered by the opercula, which we've discussed quite a lot. There is the paracentral lobule or central lobe with subcentral gyrus, and then there is Sylvian fissure, which in depth of it has insula. We can sort of we can see the insula in this particular case in nicely atrophic and stripped off vessels and pia brain with its apex right in the anterior Sylvian point. And if we continue the dissection that we've seen, I'll go through that very quickly because we've done it before. We have the SLF. Here with the cortex has been stripped, extreme capsule, bit of claustrum here. And you can see the uncinate fasciculus again, and the fibers of IFOP slightly posteriorly to that. This is already internal capsule with striatum, and beyond that again, I-FOV here, uncinate fasciculus here, I-FOV running underneath underneath the arcuate fasciculus, which has been already stripped, and together with optic radiation, we form the sagittal stratum. This is kind of picture for us to understand where the optic pathway fibers come from. So to recap, we're looking from underneath, so from the base upwards, and we can see the optic tract going to the lateral geniculate body, and from the lateral geniculate body we have the fibers of the optic radiation fanning out anteriorly and laterally in the wall of the in the sort of superior lateral wall of the temporal horn, as we have seen many times before. This is to show again the anterior commissure, and it's functionally not important apart from spreading, understanding the spread of gliomas, but also intraoperatively it can be helpful in orientation, and also as a conceptually will help us to understand the sort of deep gray matter, particularly striatum and putamen, and its continuation anteriorly of the anterior commissure, and this is called so ventral striatum, ventral putamen, and eventually more medially nucleus accumbens and so on. Not that we particularly operate that very often, but it's worth to understand it as a concept. I'll skip through that, but also show you on an example of a simple MRI scan that we can actually see all of these anatomical concepts and structures on the scan. So we can see pars opercularis, triangularis, we can see central sulcus, subcentral gyrus, we can see the Sylvian fissure with supramarginal gyrus, you can see the superior temporal sulcus with the angular gyra. And if we go inside, again, insula starts coming up with its apex first, short anterior gyri, long posterior gyri. We can start seeing the extreme capsule, a little bit of claustrum there, here, an external capsule. You can see the putamen now. You can see the anterior commissure, so we know exactly which fibers are where. Going deeper, you can start seeing the fibers of the internal capsule into the into the centrum semiovale. More striatum fibers. That's chordate nucleus coming on a bit more medially, and that's again ventral striatum, and so on. So this is just to show that actually we can see it all on scans. Vessel is very important because most of the permanent and most severe morbidity in insular surgery comes from vascular injury. Of course, we're all aware of the MCA branches, M2s and M3s in the insula, covering the insula and the opercula. But really, these are the lateral lenticular striate arteries, which are the most sort of dangerous that we are dealing with. And I won't be going into details of it, but I recommend this paper if you want to study all these vessels very carefully. This is just to show that when the MCA comes out, it usually sends frontal branch, small temporal branch, and then upper trunk and lower trunk, or the superior trunk and inferior trunk that goes underneath the insula, lips over the opercula, and eventually comes as M4 on the surface of the brain. And here, this picture is worth spending a little bit of time on because it shows the lenticular striate arteries, lateral lenticular striate arteries. They come from MCA, usually M1, some M2s, and they travel through the anterior perforated substance. Just to orientate everyone. So this is optic nerve, internal carotid artery. On this picture, you can see olfactory tract. So therefore, it's the lateral olfactory stria. This would be a medial olfactory stria. Posterior to that, by definition, is anterior perforated substance lateral to the optic tract, and the lateral lenticular striate artery going through the anterior perforated substance up both anterior to the anterior commissure and posterior to the anterior commissure, supplying internal capsule and the rest of basal ganglia with blood. Usually there are, on average, there are about 7, and it can be 2 to 14 of them. Some are small. Most of them are smaller than half a millimeter in diameter. Some are more than 1.5 millimeter in diameter. So this picture is to show again where the anterior perforated substance is. So that's the lumen of insula, as we've heard before. We've heard of the posterior orbital gyri. That's the olfactory tract with median lateral olfactory striae, and lateral to the optic chiasm and optic tract, and posterior to the olfactory striae is the anterior perforated substance. So the ICA comes here, then divides into ACA that runs over the chiasm medially, and then MCA goes through the just anterior to the lumen of insula through the Sylvian vallecula into the Sylvian cistern. And here we can see all the perforators coming up into the basal ganglia. Again, that's at the level of anterior commissure. So there are some go in front, most of them posterior to the anterior commissure, and that's all the vessels in transection here. So you can see chordate nucleus, head of nucleus, then you see putamen here, the upper part of the putamen, lower part of the putamen, then again thalamus here, posterior limb, anterior limb of internal capsule, genu here. This is a beautiful picture, which I can't remember where I got it from, but a long time ago. Maybe it's Professor Gold's picture. If it is, I apologize that I don't know that. But again, we can see all the lenticular striate arteries here. But importantly, some of the MCA branches, the insular branches, not only feed insula, but go really deep down into the centrum semiovalar and can occasionally cause ischemic problems. In fact, about 5% of all the branches go all the way to corona radiata, and damage to any of the vessels which actually can be supplying both insular tumor and corona radiata can result in neurological deficit. So in awake surgeries, in the kind of general awake surgeries, this would be the typical position for surgery, but in insular surgery, I no longer put patients asleep like that. I rather use this sort of angle view in order to go along the Sylvian fissure to more comfortably reach the posterior aspect of the Sylvian fissure. Even if I go transopercular, in particular, if we go transopercular, that's kind of more or less the position we would use, particularly if we need to reach the posterior aspect of the insular tumor or tumors that affect this the Berger 2, Berger 3 zone of insula. So let's have a couple of cases. First one, 62, vivid dreams, awaking with odd taste in mouth, so seizures, and some potential speech problems. So that's the tumor, quite extensive. There's no way on earth we would ever be able to remove it completely. So we have to be quite judicious what we are planning to remove. Nevertheless, the less tumor, the longer overall survival. So we did the patient awake first, and we usually always use cortical strip for MEPs. We use both cortical and extracranial MEPs just in case we have some issues here. So as we can check, we do As you can see, it is a transopercular surgery, so Sylvan Fisher's here. This is temporal lobe largely removed and doing subpial dissection of the temporal lobe. Again, these are frontal opercular windows. And what you can see here, we are through the frontal operculum, and now we're making a hole in the pia of the insula. So actually, when we go transopercular, we really breach three pial surfaces, the one on the outside, then the inside of the operculum, and eventually the insular pia. And we're working through vascular windows, and similarly as anywhere else, we are separating the tumor from pia, and you know, going deeper and deeper, watching for vascular injury. We use monitoring and mapping. Monitoring is particularly for vascular injury. Mapping is simply to map both speech, mentalization, optic irradiations, as well as corticospinal tract. Again, opening another window, vascular window. The key thing is not taking any vessel, handling vessels very gently. Pretty much I use very little bipolar. Primarily I would use Saka, but I use CUSA as well on low setting, careful around blood vessels. Also, it's important to keep in mind that sometimes I generally use low power setting of CUSA, but we need to be aware that CUSA can also pretty much cause occasionally stimulation as well as vasospasm. So I think there's nothing much to show. Pablo showed similar pictures, so we won't spend any time on it. Usually we can see nice anatomy when we remove temporal lobe. So it was done some years ago. In fact, I've spoken to this lady only 2 days ago. She's doing well, and actually her tumor is stable. As you can see, we had to leave a bit of tumor here because of changes in MEPs, and I wonder whether there was one of the long perforating arterioles was quite close by, and we decided not to pursue it any further. It remains largely stable. So 7 years ago now, no radiotherapy or chemotherapy required so far. And this is an important case, 19-year-old female, ambidextrous, and seizure. So, and this area showed high relative blood volume, high RCBV, which we often use to demonstrate highest perfusion, which corresponds with highest metabolic rate, suggesting early transformation. And when we are operating in the, show you the scans again, when we were operating in the posterior aspect of the tumor at the precisely where we wanted to take the tumor most aggressively, we had this sort of EMG MEPs, particularly abductor digiti minimi and flexor carpi ulnaris pretty much disappeared. We often use papaverine, increasing of the blood pressure. In this case, nothing was happening. The patient woke up hemiplegic, completely hemiplegic. This is the postoperative T2. This is diffusion, and you can see there is ischemia happening there. This to show that they didn't recover. I'm glad to say that I was absolutely devastated, and this is my only permanent neurological deficit. However, it is very mild. She completed her studies and as you can see, is pretty much leading somewhat, if you examine her, you find out that there's a neurological deficit, but it's very subtle. But yeah, we have to be really very careful and need to keep in mind that particularly extensive tumors in the posterior insula can have branches that feed not only the tumor and the insula, but also can go as far as corona radiata. Just one more case, I think I'm aware that I must be running out of time. Right-sided, again, look like lower glioma, and just a tiny bit of enhancement here. So we felt this is really going to be the key target of our surgery. We used the 5-ALA. I won't show you the surgery, and we managed to completely remove the 5-ALA enhancing or fluorescing tumor with a good margin. It actually turns out to be glioblastoma in a young man, but he had pretty decent resection, underwent chemoradiotherapy afterwards, and no neurological deficit. We neurosurgeons tend to see ourselves in the mirror a little bit like that, and often speak to patients a little bit like that. But I think we need to review our results very carefully, very objectively, so that all our patients can do better and better. And I thank you for your attention.
Thank you, Mr. Santorius, for that comprehensive talk on insular gliomas. So as I understand, if it's an extensive insular tumor, you would be more conservative, if I've understood correctly, and if it was appearing entirely low grade on scans.
Well, I do believe that the less of the tumor in patient's head, the better. But I absolutely don't want to leave anybody with permanent neurological deficit. Of course, like the first case, there was extensive infiltration of the areas that there's no way we can remove completely. I would be less aggressive there. Because I usually give patients estimate how much I'm going to remove. And I have to say most of the time in insular gliomas is, I would say on average, I'm aiming for about 80%, because I have to be honest, very rarely one can achieve complete resection. This would have to be limited insular tumor or limited insular temporal, or rarely we can do absolutely complete or supratotal insular tumor resection without genuine neuropsychologically proven no problem.
Yeah, Thomas, great talk. I enjoyed. I want to know what would be your strategy for a high-grade insular glioma?
Okay, so in high-grade tumors, I would be less aggressive. I strongly believe that there's absolutely no room for any neurological deficit in a person with high-grade glioma. Because people, particularly with insular glioma, they would have on average 18 months. The median survival of high-grade glioma is 18 months. So if the person is going to spend 3 months recovering from a neurological deficit, potentially I'm taking away the best 3 months the person would have from their life. Chemotherapy, radiotherapy may in itself prolong their life by maybe 1 month, 2 months or something like that, depending on the, on average. So absolutely no neurological deficit is allowed in high-grade glioma, as far as I'm concerned.
Wow. Professor Atul Goel, would you like to comment?
Yes, Thomas, that was quite a fascinating talk. One thing I liked about your lecture was, what you said about the blood supply to the region. You see, what my feeling is, you can do radical resection, you can do complete resection. There is only one issue, that you just cannot take one small little vessel or a perforator, that is, if you have done it, you create a disaster. So from disaster, otherwise, you know, there are so many layers of protection, extreme capsule, and so many layers of protection to, you know, to be able to damage the internal capsule. You can do a good job, you can do a radical job, you can do a radical job even in a high-grade glioma, and a safe radical job. One premise is that, as you rightly said, one vessel that makes the difference. You just cannot coagulate one perforator. If you do that, you had it. You agree, Thomas? What is your...
Absolutely, absolutely. It's absolutely correct. Because, for example, in diffuse low-grade gliomas, if we push it hard, we can, to an extent, you know, take some functional fibers and through the contusion of the surgery, maybe reduction of the volume of the fibers, the patient may have a deficit for a few days, few weeks, but if they recover from this is okay. In high-grade gliomas, there's no time to recover, so there's no worth this investment. And if we cause vascular injury, it is absolutely no time to recover. And even in low-grade gliomas, there's going to be some permanent functional deficit.
So what would be your reason for operating on the high-grade glioma?
Well, it's a good question. Again, if it's been shown in high-grade gliomas, i.e. glioblastoma, and again, a high-grade glioma, I mean one that looks preoperatively like high-grade glioma. For example, the one GBM that I showed was also GBM, but we didn't know that. So we cannot assume it could be. But so if, let's say, high-grade glioma GBM prior to surgery, I wouldn't say I would operate on every single patient, but if I feel that I can remove at least 80% of the tumor volume without any neurological deficit, then I think there's a benefit to the patient, because they will have a longer overall survival. But I would say, again, my philosophy is very strong. Absolutely no neurological deficit of any sort is allowed.
Pablo, would you like to comment?
Well, I just can say that everything I know about the insula, I learned it from Tom. So I thank you for reinforcing that.
Pablo told us lots of truth today, but now he's starting to lie.
Difference of opinion.
No, I fully agree with him. Indeed, high-grade gliomas, in my humble and very short experience, are terrible diseases when they appear around the insula. Generally, because when you are getting close to the, let's say, red zones, which are the level of the lumen insula and the posterior aspect, posterior superior aspect of the tumor, you are getting quite close to the internal capsule, and we are talking about 2 or 3 millimeters, no more than that. You can damage the lenticular striate, you can damage the corticospinal tract, and that's something that, as Tom has said, the patient will not have time to recover from that deficit, and that's terrible.
So my question is that if the patient has 18 months, why you want to operate at all?
Well, because he has 18 months, if I understood well, he has 18 months if you complete a quite extent resection and the patient is in good conditions to receive chemo and radiotherapy. Otherwise, it's not 18 months, I believe.
I have to say, you know, the insular glioma surgery looks sort of tremendous, yeah, or big surgery, and patient would be, you know, in bed for forever. But actually, in case of GBM, you can, I'm not saying in every single case, but in some cases you can get in, debulk 80% of the tumor, and sometimes even more, and the patient can be just go home, you know, 2 days later. So you know, I would say just purely you know, what's the proportion of patients with insular GBMs I would operate on? Probably about 50-60%, no more. So okay. not every single one that comes along.
Thank you. Thank you. Harish, thanks.
Yes.
Harish.
Yes, sir. Yeah. So moving on to the next talk will be on intraventricular lesions by Dr. Pablo Gonzalez. So this talk will be moderated by Dr. Netalkar. Dr. Netalkar is a senior consultant neurosurgeon at Manipal Hospital in Goa. He did his neurosurgery training from KM Hospital, Mumbai, and passed out in the year 1985, after which he worked as clinical assistant in PD Hinduja Hospital and was later a consultant in HN Hospital in Mumbai. He later did his stint in microneurosurgery at Preston Hospital in Lancashire, UK for extended period, and also worked as a visiting fellow in Newcastle Hospital in UK. He worked in Kola Hospital in Muscat, Oman, and he then came back over to Goa in the year 2003 and set up neurosurgery departments in 5 different private hospitals, including Apollo Victor hospitals. He single-handedly managed all these hospitals for more than 10 long years, and he was also honored by his appointment as consultant in Goa Medical College in 2006. He was honored by Government of Goa with Top Medical Award for his exemplary medical services in 2011 at the hands of Home Minister. Over to Dr. Netalkar so that he can moderate over the next talk.
Thanks, Harish. Thanks for a nice introduction. Let me at the outset thank Professor Varnan Velo and his team for an excellent webinar, which is being registered over 1,100 delegates and live being around 500 at present. I also thank his team, Rishikesh Kharusekar, Harish Naik, Lakshmikant Gopli, Nimesh Jain, and Yogesh Savkare for an excellent webinar. We are really thrilled by watching the live dissection particularly. Now coming to the introduction of Pablo Gonzalez Lopez, who is a renowned Spanish neurosurgeon with specific interest on neurosurgical education and the Spanish delegate for European Association of Neurosurgical Societies Training Committee and member of the World Federation of Neurological Societies Neuroanatomy Committee, co-director of the project 3D Neuroanatomy and 3D Neurotrainer, trained in the University of Valencia, Spain, and in well-known centers around the world by Professor Fukushima in Tokyo, Michael Lawton in San Francisco, Professor Evandro D'Oliveira in Sao Paulo, and Professor Jua in Helsinki. Completed a 1-year fellowship under the supervision of Professor Ture and Professor Yasser Gil in Istanbul, Turkey. And before I finish the introduction, let me also invite the next conference after the COVID to be held in Goa, and invite all of you, including Professor Atul Goyal, who missed the last conference in Goa. Please, Dr. Yes, Atul?
Yes, of course.
Thank you.
Netalkar, you are an old friend of mine and a very respected and loved friend of mine. And I just don't want to miss the next one, at least. Otherwise, you will kill me.
We took baby steps in neurosurgery, isn't it, together?
Yeah.
Thanks, Atul. Professor Pablo Gonzalez, please carry on.
Thank you, Dr. Netalkar, for your kind introduction. And I must say that I have been once in your beautiful city in Manipal, and I was delighted with that place. I thank you for your introduction. I will be very brief, and I have short experience with intraventricular lesions, so that's why I want to share with you my work and how again anatomy can change our surgical approach in order to choose the best route. So this is a concept that Professor Roton has brilliantly introduced, and the ventricular system surgery is something very unique, as the ventricles are indeed positioned near the center of the intracranial space. They are completely encased in neural tissue, and their shape and size are completely variable depending on every single case. So that's why surgery in and around the ventricular system is so special, and we should really study carefully every single part of it. So we will be discussing the frontal horn, the body, the atrium or occipital horn, and the temporal horn. And we will have a brief overview of the third ventricle anatomy and possible surgical routes. So something important about the ventricular system is that as we said, they are located in the center of the intracranial space, in the middle of the brain, and they are completely encased by very important neural structures. So let me highlight some of them. Of the septum pellucidum, which is located in the midline, separating both lateral ventricles. Let's go to the lateral aspect, where we will mainly find the caudate nucleus, fornix in this inferomedial location, the corpus callosum, which is mainly representing the roof of the lateral ventricles and the anterior wall of the frontal horn, the internal capsule that we have been able to see during the dissection, just lateral to the thalamus and the caudate nucleus, and finally the thalamus, which is a very, very important structure located mainly in the floor of the body of the lateral ventricle, anterior wall of the atrium, and representing both lateral walls of the third ventricle. So again, how we can choose the best approach, and these are concepts that are very classic, but still very, very important to understand. We should choose an anatomical corridor. We should try to perform an atraumatic manipulation, and this is why I'm so influenced about that. And I really like for the interhemispheric fissure approach to perform this in lateral position, because obviously we will have a wider exposure and our bimanual maneuverability will be much easier. And finally, preserving the surrounding structure. So let me share with you how we can approach a tumor as the one I showed you, just posterior to the foramen of Monro. So we are entering through the left interhemispheric fissure. We are doing a small callosotomy and center mainly with the ultrasound. This is what I generally use. And then to make sure that we are in the correct location after expanding to match the callosotomy, we can take advantage of technology and have a look with the endoscope. So this is the septum pellucidum. That's the foramen of Monro, which is completely blocked, and just posterior to it, we have the tumor. And we know that the foramen of Monro is there because we can follow the choroid plexus. And once it's disappearing and the septal vein junction, we should have the foramen of Monro. So this is how the anatomy again can help us to identify a tumor located in the floor of the body of the lateral ventricle. So once we have completed our resection, we can have a look again with the endoscope to realize that the tumor bed is not bleeding and the foramen of Monro is now opened. So most of the cases I used to leave 24 hours ventricular drainage. We close it and we measure the intracranial pressure. So this is what we have been doing. It was a 17-year-old lady with this subependymoma. And the most important thing is that we were able to identify the foramen of Monro and decompress it in order to release the pressure on this lateral ventricle. So translating these concepts, anatomical corridors, atraumatic manipulation, and surrounding structures preservation to the intraventricular surgery, it's very important to identify where do we want to enter through. So ideal cortical gray matter entry point should avoid always highly eloquent regions. It's very important also to understand the general arrangement of the white matter fiber tracts, which are underlying the cortex. And this is why we should understand the three-dimensional arrangement of all these very eloquent fibers. And finally, identify and understand the regional anatomy of every single tumor in order to decide not only the entry point, but also our trajectory and the surgical strategy. And we will have a look at the different parts of the ventricular system through some real scenarios. So this is a 61-year-old man who came with diplopia to the emergency room 3 years back. And we were checking this tumor. Once we realized that it was growing, we decided to offer surgery to him. And the concept is the same we just have highlighted. First step before trying to choose our surgical approach is to identify and to understand the regional anatomy of this tumor. So this is a tumor which is growing in the floor of the frontal horn, of the right frontal horn. So in this case, we should be aware of the location of the septum pellucidum, of the caudate nucleus, head of the caudate laterally, and just posterior to it, we should be able to visualize the foramen of Monro. So we can have different surgical strategies. We can go through a transcallosal approach, anterior transcallosal approach, or we can choose a transcortical approach to the frontal horn. Depending on each surgical strategy, our entry point will be obviously different. In this case, we decided to perform a contralateral approach again, avoiding opening the valves. There is no need for that, obviously, but we need to identify the pericallosal arteries. And this approach will give us two very important features. We will be able to have much better control of the lateral expansion of that tumor without retraction of this hemisphere. So this is why, again, we place the patient, as we have been discussing before, in this kind of supine lateral position. And this is what we are planning to do, to go quite anterior from the left side to open the right frontal horn. So once the frontal horn is opened, and we used to do it with the bipolar and expand it, we try to avoid coagulation if not necessary. Then we have a look at the foramen of Monro. This is the septum. So obviously the tumor is in this angle in between the foramen of Monro and the fornix and the septum pellucidum. It was finally a subependymoma. And with this surgical trajectory, we were able to identify all these anatomical structures. Let's move a little bit more posterior. And this is a 33-year-old lady who came with headache and blurry vision. So in the MRI, what we can identify is a massive lesion occupying, we could say, both lateral ventricles. We will discuss about it in a few slides. So what we can see is what we suspect to be a central neurocytoma, which is mainly occupying the lateral ventricle and causing, as we can see here, unilateral posterior right-sided hydrocephalus due to the block of the CSF circulation because of the growing tumor. So which is the ideal goal of surgery? So we can potentially cure a benign disease like this one and reestablish the CSF. So these are our main goals for this surgery. And is this a right or left-sided central neurocytoma? Sometimes they are occupying both lateral ventricles, but in this case, we can carefully study the MRI, understanding that the septum pellucidum is pushed towards the left side. So it looks like a right-sided central neurocytoma. So in my mind, it would be much better to perform a contralateral approach to have a better control of this area. But due to the bridging veins, I did it ipsilaterally, as I will show you right now. So important to study carefully our anatomy in the MRI. So due to the bridging veins, we decided to go ipsilateral through the right side of the interhemispheric fissure. And this is what we were expecting to find once the callosotomy was performed. So this is what we were doing. This is the midline, this is anterior, this is posterior, this is left, right. And we are gonna open the dura and again deal with the bridging veins in the best way we can do. So always we try to find a window in between the superior longitudinal sinus and the ipsilateral hemisphere. And this is something that I found very, very useful in order to keep the interhemispheric fissure open, to use these two cotonoids on both sides. So once we start the callosotomy, the thing is that first of all, we will find the tumor. And we really want, in this case, to go to the left side in order to release CSF and to have more control. So once we are in the left side, we start coagulating the septum pellucidum, in this case, looking for the foramen of Monro, which was open already in the left side, and then we move anteriorly. As we are moving anteriorly and to the ipsilateral height, we are opening the right-sided foramen of Monro. This is the choroid plexus in the left side, and we are moving anteriorly to the level of the foramen of Monro. Again, the speculum was really useful to see that there was some tumor remaining in the roof of the ventricular system. Here we do have the atrium, and we are moving posteriorly now. Moving posteriorly in this case is a bit more difficult because the tumor is growing towards the lateral aspect, towards the atrium. So again, the speculum and the endoscope I used in this case were very useful to realize that there was some remaining tumor in the hidden corner that we couldn't see with the microscope. So moving laterally, we are working with the speculum and the suction device, and then we will be introducing the endoscope to have a look at the posterior aspect. So this is the septum, this is the left side atrium, choroid plexus wrapping around. This is the stria terminalis, something very interesting to see. This is the right side atrium, and we can see a remnant in this area, and we are trying to attack it with the 30 degrees endoscope. So this is the atrium. We are looking for the occipital horn. This is the hematoma that was coming to that occipital horn. It's very typical to find some blood in the post-op scans and MRI in this area, and that is why, due to the gravity, the bleeding is coming there. So this is the caudate nucleus in the left side. This is stria terminalis. So we are happy with the resection in the anterior aspect. Septum pellucidum has been removed. Both foramen of Monro are completely opened, both head of the caudate nucleus in the left side and in the right side. So here we have both frontal horns, left and right head of the caudate. And the best thing is that both foramen of Monro's are completely open, and the lateral ventricle is now, as you can see, foramen of Monro on the right side, lateral ventricle is communicated. So this was the post-op MRI. The patient, she's a home designer, and it took 2 or 3 months to recover her normal life, working properly. And now, luckily, she's doing very, very well. Let's move a little bit more posterior, and this is the typical meningioma growing in the atrium. You can see the relationship with the choroid plexus here. For these cases, there are many approaches. We can go supracerebellar transtentorial, we can go even subtemporal, which is something I don't usually do, or we can go through the intraparietal sulcus. We could even go a little bit more medial, as we will discuss later on. The idea with this transcortical approach is to try to respect as much as we can the neural tissue we will be closing, and this is our goal. We want to reach this area because the feeding of this tumor is mainly coming from this choroid plexus. But something we must keep in mind, as we have been discussing, is the relative location of the optic radiations, mainly covering the superlateral aspect of the temporal horn, and also all the lateral wall of the atrium, and partially the roof of the atrium and occipital horn. So our ideal trajectory should be quite medial and anteriorly based. There are certain craniometric points that we could take advantage of. This is the intraparietal sulcus, so a transsulcal approach will be carried out through this area here, which is more or less 4 centimeters anterior to lambda, 9 centimeters posterior to pregma, and 1 to 2 centimeters lateral to the midline. So this is what we were choosing in order to reach this area here. And the resection was quite good. We could take it out, but I will show you the post-op campimetry later on. Before that, let me show you this case. This is a pilocytic astrocytoma, which was growing, as you can see in the pulvinar. So it's partially exophytic with this cystic component. It was biopsied in another city in Spain, and the patient came with his family to Alicante to receive the control. The tumor was growing after 2 years, so we decided to offer surgery, and the patient came with a deficit, already a visual deficit due to a transtemporal transcortical approach. So where the tumor is located, we could have some doubts, but it's obvious if we use a multiplanar reconstruction that taking a look at the sagittal and coronal cuts, we would realize that the tumor is growing in the ependymal layer of the pulvinar of the thalamus, just in this area here. So this is the internal capsule, this is the putamen, and this is the lateral aspect of the body of the lateral ventricle and anterior aspect of the atrium. So this tumor was growing mainly in that area, as you can see, completely covered by these optic radiations. In the previous surgery, the biopsy was carried out, crossing these fibers, and this is why the patient was having this problem. But also we took advantage of that lesion already, so we used the same small craniotomy, and after opening the dura, we tried to go as basal as possible using the same surgical route. We always have this control of the motor pathways. So once we entered the atrium quite basal, we wanted to make sure that the cystic component was there. Once we exposed, removing the ependyma, opening the ependyma, we realized that the cystic component was just in front of us. So we took it with a needle, we emptied, we sent it for cytology to check if there were some cells there. And then after releasing the pressure inside the cystic component, we tried to debulk the tumor and find the limits, anatomical and functional limits, because if we go quite anterior, we could reach the posterior limb of the internal capsule in the most anterior part of this pilocytic astrocytoma. Indeed, we found some function, some motor response at that area. So this is the post-op MRI, which was quite good. The patient had the same deficit, visual deficit, and we were lucky he was not experiencing any motor problem. But both patients I just show you with this transparietal and transtemporal approaches had these post-op campimetries a little bit uncomfortable for their normal lives. They were both active and young patients, and the reason why they had these deficits is because in the transparietal we were crossing some fibers covering the roof of the atrium and the occipital horn, maybe some optic radiations going to the calcarean fissure, and in the transtemporal approach they were crossing some fibers, the most lower aspect of the optic radiations in the lateral wall of the temporal horn. So this is the damage we can create with a transparietal, and this is the damage we could create with a transtemporal approach. So both tumors could have been much better resected with probably with an occipital interhemispheric transismus or transprecuneus approach, or even with a supracerebellar transtentorial approach. So I just wanted to show you these two cases because I was showing before in the limbic system presentation how we can avoid this damage, and this is the reason why we can do that. Let's move to the temporal horn, and this is a young lady who was on holidays in my city, in Alicante. She's from the north of Spain, and she came to the hospital in GCS 13. She was experiencing some headache in the weeks before surgery, and when we decided to go to the OR, the patient had an anisocoria, a right-sided anisocoria with mydriasis due to the compression of this massive tumor, low-grade glioma of the third cranial nerve in the basal cisterns. So something important is to identify and to understand where this tumor is growing. It looks like a huge temporal lobe lesion, but as you can see, the neocortex of the temporal lobe is completely healthy. So the tumor is mainly in the parahippocampus, invading the subiculum and the hippocampus already. This is the collateral sulcus. So T1, T2, and T3 are completely healthy, and even partially the fusiform gyrus is healthy in this area here. Also, the tumor is invading it. So in this case, we decided to go a transtemporal, basal transtemporal approach, so as to try to go through T3 in order to reach this area and identify our anatomical landmarks again. Choroidal fissure will be our superior limit, the basal cisterns will be our medial limit, and anteriorly we want to find the ankle recess and the amygdala, and posteriorly we want to find the atrium, which is going to be our posterior limit. Finally, inferiorly, we should find the tentorium and the tentorial incisura, and in this area we will try to find the lateral aspect of the midbrain. So this is frontal or fronto-orbital, frontoparietal, and temporal operculi covering the insula. And what I wanted to show you here is the relative location of this area here of the hippocampus. So in between T2 and T3, if we go transcortical, we will end directly in the temporal horn, and we will find in front of us the hippocampal formation, which is mainly where this tumor is growing. So this is why a quite basal T2, T3 transcortical approach was helpful in this case. After entering the ventricle and releasing pressure after debulking the tumor, we are going to the superior limit, which is the choroidal fissure, posterior limit, which is the atrium with the choroid plexus, inferior limit, tentorial incisura, tentorial limit, and here we are taking care of the part of the uncus, which, as you can see, was completely, the tumor was completely surrounding the third cranial nerve. It was not invading it. So this is the uncal component of the tumor, which was completely in between or inside the basal cistern. So this P1, P2, this is PCOM, and final part of the tumor, which was in the interpeduncular cistern. So after the resection, this is the anatomy we really want to see, because it means that we have completed a good anatomical resection. So let me show you. This is the superior aspect of clivus. This is the pituitary stole going to the sella, basilar with superior cerebellar artery and the third cranial nerve. It was completely damaged by the tumor itself. And this is P1, P2 with PCOM, and the anterior choroidal artery, which was entering the inferior choroidal point. So if we see this anatomy with the tentorial incisura, ankle recess anteriorly, and atrium posteriorly, we will make sure that the resection was quite good enough. It was a low-grade astrocytoma. This surgery was done in 2013, and for 7 years after radio and chemotherapy, it has been completely stable, and the patient was so happy with Alicante that indeed she is living here in the city since then. So let's move now, after covering the frontal horn, body of the lateral ventricle, atrium, and temporal horn, to the third ventricle. And this is a small tumor in the tectal area, which is causing a collapse of the aqueductus sylvius, so creating this hydrocephalus. And in these cases, we generally don't touch the tumor, we just solve the hydrocephalus and just follow up the lesion. And this is what we did. We can place a BP shunt, or we can do an endoscopic third ventriculostomy. In this case, there are some issues that will help us understanding that probably a third ventriculostomy, endoscopic third ventriculostomy, will work well. One of them is that the tuber cinereum is completely pushed downwards. We have a good prepontine space, and the hydrocephalus is obstructive. So there are many chances to solve the hydrocephalus with an endoscopic third ventriculostomy. And this is something interesting. These are the success anatomical predictors for a third ventriculostomy: bulging tuber cinereum, bulging lamina terminalis. We have a wide prepontine space, we have control of the basilar artery, which is in the prepontine space just in front of the pons and in the interpeduncular fossa. We have a very thick, very thin, corpus callosum. So this is going to be our surgical trajectory through the foramen of Monro. How we do plan the entry point? We said before that obviously we must understand the cortical anatomy so as to avoid highly eloquent areas. We must understand the three-dimensional arrangement of the white matter fiber tracts. So this is how we do it. First of all, in the MRI, we mark our target. Secondly, we mark the location of the foramen of Monro. And once we have these points in our mind, what we do is we trace the trajectory in between these 2 points. So then we will have the ideal cortical entry point. So we do it like this. Another important thing is understanding this optic and working channels display. This is our eyes. These are our eyes. This is the working channel for our eyes. This is the camera, but we have 2 working channels, and in cases we can even have 3. And why I want to show you this, because we are having a blind spot in this area. We are not controlling these 3 millimeters of the endoscope because our view is in this blue area. So we are missing this, and this is very relevant, especially when the foramen of Monro is narrow. And let me show you what happened in this case, which was very sad. We were entering through the foramen of Monro. This was a slit ventricle we want to rescue and to do a third ventriculostomy, and we did a nice job. But suddenly, this is what happened. We had no control of this part of this black area. So it's important not only knowing the anatomy, planning a good surgical trajectory, but also being aware of the technical problems we could have. So we don't have a mirror as we have in the cars, and look at this guy. He wanted to exit through this road, but he was not paying attention at what was happening behind him. So very important, be aware of all these technical issues. Once we reach the floor of the third ventricle, it's ideal to identify this rhomboidal shape in between the pituitary, the recess, also the interpeduncular fossa in between both mammillary bodies. And in this area of the tuber cinereum, we should try to do our third ventriculostomy, always being aware of the relative location of the top of the basilar artery. So once we have performed our perforation of the tuber cinereum, we expand it, we enlarge it with the Fogarty, and we must make sure that they are communicating the systems. Let me go to the last 2 cases. These are both colloid cysts with different presentation. This patient presented with headache and memory problems, a small colloid cyst causing a bilateral hydrocephalus. And this lady, she came in GCS7 with headache, and at 2 a.m. in the morning, one of my colleagues placed a bilateral external ventricular drainage before we did this MRI. So where are these tumors growing? They are mainly growing in this roof of the third ventricle, which is completely surrounding of very, very important neurovascular structures we must identify as the junction of the septal vein and the thalamostriate veins in the most anterior aspect of the internal cerebral veins, and also the branches, distal branches of the posteromedial choroidal arteries. So this is something we must try to control. This is why, generally in these cases, if we do them with the endoscope, we should go quite anterior in order to have control of the superior aspect of the third ventricle. So this is what we are doing in this case. We are first of all coagulating the choroid plexus. This was the first case I was doing with the endoscope, and I was doing with one colleague who is very experienced on this. So then we perforate the lateral wall. We take this mucinous component inside, and then with this maneuver, this is something that we should be avoid. Pushing the colloid cyst, because we created a bleeding, probably one of the branches, anterior branches of the posteromedial choroidal arteries. So with irrigation and slight Fogarty compression, we were able finally to coagulate it. This is one of the problems that we can have if we are not patient and our exposure is not good. So in this case, we were not quite anterior, so we couldn't have a look at that small artery. So let me show you what happened in this one. We are planning to do it endoscopically. And suddenly, once we cannulated the lateral ventricle, we entered there, and this is what happened. We had this technical problem. The IT guys came to the OR, but they were not able to solve it. So we should do something. And what we did, we converted it to a microsurgical resection. So we did a transfrontal microsurgical exposure. We entered the lateral ventricle, and this is exactly the same concept. We are coagulating the wall. We are releasing the pressure, this mucinous component. This is the fornix.
So we are working with 2 hands, which is much better in my mind in order to remove these lesions. So once the tumor is debulked, the colloid cyst is being shrink with the bipolar, we can coagulate and cut with 2 hands. And this is the aqueduct of Sylvius. So in this case, we were quite anterior. So it's exactly the same thing, but working with 2 hands that I'm sure I'm proving that it's much, much more comfortable and safer for the patient. So that is what I wanted to show you. These are the post-op MRIs, and being 100% honest, I must say that this patient, the 41 years old lady, she had seizures after surgery. So we should use, in this case, anti-epileptic drugs, and we are using them for 1.5 years right now. So I wanted to stop before 15 minutes, and this is what I wanted to share with you. There are many different approaches, but again, what I believe is that the key point is understanding where the tumor is growing, which is the tumor biology, because we will understand the feeding arteries of them, the surrounding structures, and then optimize our surgical approach as we have been discussing previously. Thank you so much.
Thank you, Professor Pablo, for an excellent lecture. I think your genius of your dissection was seen in live dissection with such a beautiful wide fiber dissection. And my one question is, most of these tumors are benign. They become too big before they are symptomatic, because they grow in the silent area of the ventricles and in proximity to very important ventricular wall, white fibers, and deep nuclei. In case of tumors which you have inadequately excised because of the firmness and infiltration of the ventricular walls, which are benign, how do you follow up these patients?
You mean how do I follow them up after surgery?
Follow up regime.
So, well, it depends of the histology of the lesion. And we have a fantastic neuro-oncology team. And for benign lesions, generally our protocol is we start checking them with 3 and 6 months in the first year. And then after that, if there is no growing, we check them for 1 year. In high-grade gliomas, obviously we check them first before the complementary treatment, then 1 week after that, and after that we check them every 3 months. This is the protocol we are following.
And in colloid cysts, which are very firm and could not be excised totally in that case?
Well, I don't know if I'm gonna give you a correct answer, but in those cases, I have just done, let's say, 4 or 5 cases in which we were lucky. At least macroscopically, we were able to take them. But probably in those cases, I would follow them up with the same protocol for low-grade lesions. 3 months the first year and 1 month and 1 year after that.
Thanks a lot, Dr. Vernon. Please take it.
Yeah, thank you. I think we have 2 more speakers left, and then for all those, please don't leave. Dr. Abida Shah is ready there with her mask and her surgeon's outfit. So she's going to also demonstrate a good cadaveric dissection of the brain. So we have to be all there. So Harish, please proceed. Thank you, Pablo.
Yes, yeah. So moving on to the next talk by Professor Ali Asgar. He will be moderated by Dr. Kishore Chowdhury. Dr. Kishore Chowdhury is working as a consultant neurosurgeon and neurovascular lead in the Institute of Royal Hallamshire and Northern General Hospitals, Sheffield Teaching Hospitals, NHS Foundation Trust. And he's he's working also as honorary senior lecturer in University of Sheffield, Glossop Road, Sheffield. And his organization roles include clinical lead in the neurovascular services of Sheffield Teaching Hospitals, infection lead in the Neurosciences Directorate, clinical lead in the Seamless Surgery Program, associate editor of British Journal of Neurosurgery. Over to Dr. Kishore Chowdhury.
Hello, good. Can you hear me?
Yeah. We can hear you.
Good afternoon or good evening, everyone in India. It's my pleasure to invite Dr. Aliasgar Moiadi on a topic that is very close to my own heart. Dr. Moiadi completed his MCH neurosurgery from NIMHANS, Bangalore, which is a prime neurosurgical institute, neurosciences institute in India. He has been instrumental in establishing the neurosurgical oncology services at Tata Memorial Centers. And I think it's one of the few neurosurgical departments in India catering to neuro-oncology exclusively. Professor Moyadi also has interest in developing novel strategies for improving visualization and resection of gliomas, particularly navigated ultrasound and optical imaging. He is also interested in intraoperative brain mapping, including awake surgeries, minimally invasive surgeries, skull-based surgeries, and biology of brain tumors. Professor Moyadi has over 100 peer-reviewed publications, and I think he sits on the tumor section of the editorial board for the World Neurosurgery Journal. He is also an active member of the World Federation of Neurological Societies. As far as I'm aware, he is involved in many clinical trials and translational research projects with collaborators within as well as outside the Tata Memorial Center. He is very humble, as far as I know, and is very passionate about teaching and training, especially in the field of neurosurgical oncology. So it's my privilege to welcome and introduce Professor Aliasgar Moyadi, and I invite him to talk on the topic that is close to my own heart, and that is en bloc resection of gliomas. Professor Moyadi.
Thank you, Dr. Chaudhary. And good evening, everybody. Good afternoon, wherever you are. I think I must first congratulate Dr. Vernon on this fantastic task, but he's left me with a formidable challenge of speaking after some very good lectures by Pablo, Juan, Dr. Santarius, and so many others. But I think I'll try and make a match of it. In fact, come to think of it, I think it couldn't have been better to follow their lectures because they have set the foundation for talking about glioma surgery. There's no other better surgery than intraaxial tumor surgery to build on the principles of the anatomy and white fiber matter dissection, which they have spoken about extensively. I think Dr. Goel made a point earlier in the day when he said that I think we should go beyond looking at gliomas just as a lump of tumor and start appreciating the science behind glioma surgery. And I can add maybe a little bit of art to that also. So I think, and I think Dr. Santarius showed a similar slide that when we talk of glioma surgery, we are talking of oncological surgery. And when we talk of oncological surgery, be it surgical management, be it chemotherapy, be it radiation, you're always balancing long-term quality of life, which is the oncological outcomes in terms of survival, vis-a-vis the short-term procedural safety or toxicity, whatever you can call it. And in terms of surgery, it's the perioperative outcomes. And that's why it's a balancing act. And the basic tenet of glioma surgery is safe maximal resection. Now, when we talk of glioma surgery, an optimal glioma surgery starts with proper case selection. Having selected the case, it entails good preoperative planning. We've seen use of preoperative functional imaging, DTI, and many other adjuncts in setting the stage for executing a glioma surgery. And then comes planning the surgical approach. And we've again seen fantastic talks on what craniometric points to use, how to plan the surgery, how to use the trajectory, what approach to take. And then comes the actual removal of the glioma, which is the technique of microsurgical excision. Of course, that can be complemented by the use of appropriate adjuncts, but cannot be substituted for by the adjuncts. And therefore, the technique of microsurgical excision remains the mainstay of removing a glioma. Now, conventional practice, and many would adhere to this concept, is intratumoral debulking, that is staying within the tumor. That is, you remove a little bit of it, and remove more of it, and more of it. And I think this is something which most neurosurgeons use in general, even for extraaxial surgery. But it is combined with the principle of circumferential dissection. What a conventional intratumoral debulking entails is piecemeal tumor removal. It can be a lot of blood loss, especially if the tumors are vascular. Does not look very elegant, though that's not a primary consideration, but it can take longer operating times and potentially can lead to suboptimal resections because you leave fragments of tumor behind. often covered by debris or blood. And oncologically, this is a counterintuitive strategy, because if you go back to textbooks of oncology and the basic principles of solid tumor surgery, it's essentially removing a mass with a margin. Of course, you cannot extrapolate all of that into intraaxial tumor surgeries, but you could apply that building on the understanding of neuroanatomy, neurophysiology, as well as understanding the patterns of spread of glial tumors and implementing techniques of subpial resection and white matter dissection that we have already seen. So I'm not going to talk much about this. We've had fantastic talks on this, but let me mention and let me re-emphasize that this is the basic building block for a glioma surgeon. So you need to have a good appreciation of the anatomy, of the gyral anatomy, the white fibrous anatomy, as well as the function of those structures. It's also imperative for a glioma surgeon to understand the pathogenesis and the pathophysiology of the origin of gliomas and their spread. It is long since known, and I think it's from the 19th century, building on the work of surgeons and pathologists, and then this very elegant chapter published in Professor Yasargil's book, which shows that these tumors, gliomas, originate in the white matter. They originate within gyri, and then through the early, intermediate, and late phases of spread, they follow the path of the white fibers, first under the U fibers, and then through the longer association fibers. However, at no point of time during their spread, except maybe in very rare late stages, do they breach the pia. And this is the cornerstone of the principle of subpial resection. So the pia is the innermost membrane of the dura, and it's intimately, probably adherent to the glial limitans, which is the covering of the brain. And this actually forms the kind of confines within which the gliomas remain and which is exploited in the technique of en bloc resection. So subpial resection actually is an old technique. It's known and a lot of people actually follow it. It is very popular in epilepsy surgery and probably not as much talked about in glioma surgery, though a lot of people would be using this. Talking about the technical nuances of subpial resection and en bloc resection of gliomas, and let me actually qualify this, that this is applicable for hemispheric gliomas and may not be applicable for deep-seated gliomas. So as we've seen, tumors would respect pile boundaries, exception rare cases, but they can grow around the pile margins, that is deep to the sulcal banks, and pass through the U fibers, and thereby may involve multiple gyri. The medial and the basal pia in the brain is usually most resilient and therefore can be handled a little more roughly than the convexity pia. While removing these tumors, like we would do in extraaxial tumors, a graduated suction aspiration technique can be used manually or with an aspirator, an ultrasonic aspirator, the settings of which are important to adjust. Avoid a diathermy as far as possible, except for the feeding vessels, but always be mindful of the en passage vessels or the vessels deep in the sulcal banks. And central debulking can of course be used and often is used combined with a circumferential dissection in order to reduce the volume and avoid manipulation of the surrounding gyri. So the basic stages in such an en bloc resection would include tumor localization, then gyral isolation, and finally white matter dissection. And when we talk of tumor localization, that's the first step. Sometimes the tumor is evident, but then often you would need some adjuncts, and a judicious use of adjuncts, be it navigation or intraoperative imaging, either ultrasound, MRI, or some kind of optical imaging becomes necessary. A note about navigation, that it's useful for localizing the tumor, but as you go progressively into resection control, brain shift sets in and then it loses its accuracy. Therefore, you would need some kind of real-time updates. And then you also have to localize not just the tumor, but you have to localize the function. And therefore you have functional mapping techniques. This could be awake and asleep, and we've talked about it. And each of them has its own technical nuances, but all of them could be applied complementarily and actually are important in ascertaining or rather maintaining the functional integrity of the brain. So breaking down The steps of glioma surgery for an en bloc resection: you need to have an adequate exposure of the involved gyrus. You have to have a proper selection of the craniotomy, and it should be adequate. I think I should emphasize this, that it should be adequate enough, especially if you're going to do cortical mapping in order to delineate the important eloquent cortices. Once you've done that, you have to identify the involved gyrus. We've seen that. Sometimes it's visible on the surface, as is over here, seen here. Often it may not be, and then you need some kind of intraoperative imaging. This is a navigated ultrasound in this instance. And once you've done that, you need to map the cortex by bipolar or monopolar, depending on what you have planned. Once that is done, you need to do a circumscribed incision on the pia of the involved gyrus. And generally, you would leave 2 to 3 millimeters of a pial rim all around. And this is important because you need to lift up that pia in order to dissect underneath it and separate the gyrus from the vertical depth of the sulcal bank. That is done with a manual suction traction dissection technique, or it could be done with an ultrasonic aspirator. And some of the aspirators have a setting, and this is an example of the CUSA, which has the setting of a tissue select, which allows you to temper the strength of the aspiration such that it doesn't breach the gyrus, the pia, and damage the vessels beyond it. And that's important because we'll see later what are the advantages of doing a technique like this. And then once you have isolated the gyrus, you reach the depths of the sulci, and there the pia ends, and then you have to move into the deep white fiber matter dissection. And here it's always important to combine with subcortical mapping because tumor boundaries are not as evident in the deep white matter. And also that function becomes very important, and that's often the cause of neurological morbidity. And then you carry on with your circumferential dissection and remove the tumor. And I always want to verify intraoperatively that I've achieved the aim that I set out to. So to break it up, an en bloc resection would have a gyral phase and a deep or subcortical phase, and it's applicable both in low-grade gliomas or high-grade gliomas. It involves, the gyral phase would involve lesion localization like we've seen and functional localization. You should keep in mind that in low-grade gliomas, function may be localized to within the tumor, and this has to be kept in mind, and surgery and resection tailored accordingly. Some adjuncts help better visualization for high-grade gliomas, for example, fluorescence. I always prefer to use ultrasound for most glioma surgeries as a resection control measure, but functional mapping and monitoring is an extremely important component of this. Just to give you a small glimpse of an en bloc resection. So this is a post-central gyrus tumor that we have. This is the central gyrus here, and that you can see that's mapped. This is done under anesthesia. So once you have made the pial incision, you use the ultrasonic aspirator to dissect it off. This is the suction traction technique by which we are dissecting off the circumscribed glial, the gyrus. As you can see, this is the bipolar stimulator, but I'm using it only as a dissector. I'm not actually stimulating there. And then at the depths, you carefully select and dissect off the white matter, combining it with subcortical mapping. And it's important to preserve all these deep vessels. The concept of en bloc resection can be extrapolated to multiple gyri also. But here I'd like to actually distinguish en bloc resection. A lot of people would say that removing the tumor en masse is an en bloc resection. There are certain subtle differences when you talk about en bloc gyral resection versus en bloc tumor resection. So if this is the tumor localized to this gyrus, we would all agree that lesionectomy is the minimum that is required, and in high-grade glioma, sometimes that's what most people aim for. You could go a little bit more around that and do an en bloc removal of the tumor, and that would also be a radical resection. But if you do that, you remember that you've left behind some gyral tissue there where most recurrences do occur. And in fact, we know in gliomas that most recurrences occur within 1 or 2 centimeters of the tumor margin. Also, you've disconnected some of the subcortical fibers already, and this gyrus is anyways non-functional. So therefore, the more logical and the more oncologically correct way of doing it would be to remove the whole gyrus. We also know that these tumors spread under the U fibers to adjacent gyri, and if they do so, then you could remove all the gyri, again in a subpile fashion, dissecting the outermost gyri subpilely to ensure a multi-gyral subpile resection or block resection. And then we have the concept of supra-radical, supramarginal functional resections, whereby even if there is no visible tumor in the adjacent gyri, you could go ahead and do subpile resection, removing till you reach functional areas. And this is a concept spoken a lot about by Professor Dufour. The advantages of doing an oblong resection are that it is anatomically and oncologically much more optimal. It ensures complete removal, less likely to leave behind fragments or leave behind tissue, and also eliminate the non-functional gyral tissue, which may appear to be uninvolved, but could be the seat of a future recurrence. Therefore, it improves radicality. And at the same time, you maintain the pile banks, which are actually quite resilient on either side. That prevents mechanical damage to the adjacent gyri when you're dissecting, or inadvertent breach of the gyrus. It also preserves the vessels which travel in the sulcal space and are protected by the two leaves of the pia, and therefore you would reduce the ischemic damage to the surrounding areas, which is again an important cause of morbidity postoperatively. And when you combine it appropriately with subcortical mapping, you would not interrupt subcortical connections and thereby again reduce morbidity overall. Of course, it's also a more elegant way of doing the surgery and actually a more simpler and efficient technique. It can be challenging. It may not be so easy to do that in certain redo cases and recurrent cases, but definitely an attempt can be made. In very vascular tumors, it may appear to be difficult, but actually it's easier because you would avoid a lot of bleeding if you were going intratumorally and debulking it piecemeal. And in very extensive tumors, it becomes moot because you're not going to be resecting it completely. Just to give you a couple of examples showing the application of the technique. Now, this is a dominant side peri-Rolandic glioma, actually post-central. And you can see the motor cortex is localized anteriorly. This was actually done awake. So this is the localization of the tumor here. And you can see that using navigation. Actually, we use navigated ultrasound. So the motor strip, and that's the tumor there. And then we did bipolar mapping to localize the function and confirm the anterior location of the motor strip. And having done that, this is the gyral phase, whereby we do a circumferential coagulation of the pia. This is the only time that I would use the coagulation. And then you incise that pia circumferentially and holding the gyrus, carefully dissecting. This is the suction here, dissecting the tumor tissue and the bits of the gyrus away from the sulcal bank over here. You do that circumferentially, and you have pia, which is in the depths of the sulcus all around. Once you reach the depths, you can see the white matter, and that's where you start doing subcortical stimulation, and you can resect the entire gyrus, which is involved with the tumor. And this is what it seems postoperatively. There's a small extradural collection there. I always like to confirm it intraoperatively. This is another example of a high-grade glioma, and this time it's in the non-dominant side, peri-Rolandic. It's pre-central in this case. And here we've done it with fluorescence as well as navigated ultrasound. So here, obviously, the tumor is localized. You can see it on the surface. You don't need anything else. But the role of fluorescence is in the depths to ascertain the actual extent of your resection. We also, since it was non-dominant and it was in the pre-central, we used MEPs and the Train of 5 technique of doing monopolar mapping. We did a biopsy of this tumor, and I always do that first as a frozen section, but I don't use frozen for the margins, and then go all around to do a subpile resection, even in a high-grade glioma. This is actually centrally the fluorescing tumor, which is isolated all around, and this is the dissected white matter in the depth. As you go deeper, you can remove it and then ascertain whether you have cleared all the strongly fluorescent tissue. At times, weakly fluorescent tissue may have to be left behind depending on the eloquent location, and sometimes ependymal periventricular faint fluorescing tissue need not be removed. Of course, you maintain the functional monitoring during surgery and ensure that it's removed completely. So summarizing it, an en bloc resection for gliomas applying scientific principles of anatomy as well as with the right technique, ensures better oncological resections and also maintains the neurological integrity better than would a piecemeal resection whenever possible. And this would actually do justice to the concept of safe maximal resection, which is eventually the aim of glioma surgery. Thank you very much.
Thank you very much, Professor Moiyyadi, for that excellent overview of gross total resection and talking about the anatomical boundaries and supramarginal resections. I have one comment and one question for you. The comment being that it is more for the trainees, that we all go for newest technologies and advances such as brain mapping and intraoperative MRI and awake craniotomies. But one thing we need to remember, that what matters is what is in your brain. If you do not start with the intention of removing the tumor completely, no matter what adjuncts do you have at your disposal, you may not be able to resect them completely. So your aim should be to, what I mean by safe maximal resection is a gross total resection as proven by a postoperative MRI scan. And I also agree with Varnan and Aliasagar, the point that made that I have also given up using brain tumor retractors for last 20 years or so, because I just don't find the need to do it, because you're bipolar and your suction cannula can use as a dynamic retraction. I have a question for you, Professor Moiyyadi, and I wonder if you could answer that. I have noticed in last 10 years, at least in our country where I'm working, that number of people are carrying out more and more awake craniotomies. My concern about that is that some degree of weakness or post-operative deficit is often acceptable after gross total resections, because invariably the patients will recover over a period of 6 weeks to 3 months. If we stop our resections when the patient starts experiences deficits, are awake craniotomies not likely to interfere with our aim of gross total resections? That's a question for you.
I think that's a very interesting question, and I think that's an eternal debate for the awake craniotomies versus the under GA. So I think just to elaborate a little on the point, I think the basic concept for glioma surgery is to be able to avert a deficit and to predict the reversibility of a deficit. I think the reliability of that prediction is the key over here. So if you're going to be talking about motor function mapping, I think you could safely do that under anesthesia. But the more complex functions, once you start mapping, it becomes very difficult to do that without keeping the patient awake. Yes, there is always the risk of having a deficit intraoperatively, but if you've done the mapping right and counseling right to the patient, you know which ones would be absolutely essential to preserve and which deficits may be reversible or may be redundant.
Thank you very much. Any questions from any of the faculties? Thomas, Atul, Varnan, Dr. Palanis?
Let me make a comment for my dear Ali. You see, I have been associated with Dr. Ali when he was a child, then he became a boy, then he became a man, and now he is a leader without any question in this subject. And he has promoted this field of glioma surgery, and he has been dedicated to this subject for a period of time. On taking cue from him, we have also, worked dedicatedly on this subject for glioma after he stimulated us to do this work. There is some Palandis. Can you mute him, Varnan?
Okay. नाही ते नाहीच आहे ते
Varnan.
Dinesh, can you mute Dr. Palande?
Yeah. So, Ali has been in.
माझ्या मते घरात आहेच already.
Deepak, can you mute? Deepak.
I already muted, sir.
Okay, so basically what I was saying is that this art we have got stimulated, and we have developed our own philosophy, our own technique, and our own technique of en bloc dissection, as you have seen Abida presenting. And we have developed our own concept after being stimulated by Ali. And I'm sure what Ali is showing and what we have now come to realize, that gliomas surgery is indeed quite a discrete branch of neurosurgery. And it is possible what we were doing earlier, just a biopsy or a little bit here, and we were thinking that it is the surgery for the least, senior and least talented. But we have now realized that it is the surgery for the most talented and the senior most. Glioma surgery, particularly in the region of insula, in the region of motor region, pre-motor, post-Rolandic fissure, are doable and eminently and elegantly doable. This is what we have realized in the last 4 and 5 years. And I have now, to give credit to Ali's work, that what he has been doing and showing to the young and old people alike. And I'm saying that glioma surgery is here to stay and here to thrive. And also we have to learn glioma surgery, and we have to learn the anatomy and white fibers. What advantage for me is that a very strong foundation of white fiber anatomy and very strong foundation of surgical principles has given us a good platform to really hit on the target of gliomas. So I must congratulate you, Ali, for your contributions to this field.
I think I agree every word that Atula says, and congratulations, actually, Ali, that your talk has been quite inspiring. And with this, I think with the time moving on, I would like to thank Ali and everyone all in the faculty, and would like to hand over to Harish and Varnan. Thank you very much.
Thank you.
Thank you very much.
Harish?
Yes, sir.
Yeah.
So moving on to the next last talk of the second session. So it will be by Dr. Shankar, and the talk will be moderated by Professor Dr. Batuk Diora. He is working as a professor additional at Department of Neurosurgery at Sion Hospital in Mumbai. And earlier he has completed his neurosurgical training from the same hospital, that is Sion Hospital. He's a faculty for microvascular neurosurgery at Ethicon Institute of Surgical Education. And his areas of interest and expertise includes cerebrovascular and skull-based neurosurgery, endovascular neurosurgery, spinal surgery, and he holds the following positions that he's a secretary of Bombay Neurological Association. He's an executive committee member of Cerebrovascular Society of India. He's an executive committee member of Neurospinal Surgeons Association of India. And he has 52 publications in various national and international journals till date. Over to Dr. Professor Batuk Diora to introduce our speaker for this last talk.
Thank you, Harish. Thank you, Harish, for the kind words. At the outset, I would like to thank Dr. Varnan for a part of the meeting. And I would like to congratulate Dr. Varnan and his entire team for an excellent academic feast they have arranged on web-based meeting. My responsibility is to invite Dr. Shankar and to introduce him. Dr. Shankar is a regional director, radiation oncology and the radiosurgery service at HCG Cancer Center, Mumbai. He received his master's degree in radiation oncology in 2001 from Osmania Medical College, Hyderabad, following which he did a neuro-oncology fellowship at Tata Memorial Hospital, Mumbai in year 2002-2003, and UICC ICRI RETT fellowship at UPMC and MD Anderson Center. He has over 72 publications to his credit in various peer-reviewed journals. His passion includes the high-precision radiation therapy, stereotactic radiosurgery for benign intracranial tumors, functional neurosurgery for neuralgia, movement disorders, and psychoradiosurgery, extracranial radiosurgery or SBRT for spine lesions, and is also having immense interest in the immunotherapy and the radiosurgery cross-interaction to induce abscopal effects. So may I invite Dr. Shankar Vangipuram for his talk on brainstem glioma. Dr. Shankar?
Thank you so very much, sir. Am I audible, sir?
Yeah, you can start.
Okay, so at the outset, let me thank Dr. Vernon for the invitation and Dr. Bhattu for the introduction. Honored and humbled with whatever you have said. So in the next 10 or 12 minutes, I will be focusing more on the overview on the brainstem gliomas. I'm really very cognizant that we are running late by almost 2 hours, so I'll keep my presentation a little short and crisp. So that will be over a period of 10 minutes or at the most 12 minutes. So I have nothing to disclose which is relevant for this presentation. Having said that, brainstem based on the location, we typically follow the Epstein-Farmer classification, where DIPG is something pretty common. The others being the focal tumors, typically the tectal tumors, the pontine midbrain tumors, the dorsal exophytic tumors, or the tumors of the cervicomedullary junctions. All this range anywhere between 5 to 10%. Now, Pons is the most common location. What we really need to understand is the majority of these tumors are high-grade astrocytomas with a dismal prognosis. Now, midbrain and medulla lesions typically are the low-grade lesions with the good to fair prognosis. So let's understand the age part of it, because the way how these tumors behave clinically as well as prognostically varies as per the age of presentation. Now, we need to understand that brainstem gliomas typically have a bimodal age distribution. In pediatric age group, if we look into DIPG, it's around 80%. The symptoms typically are rapid onset and they have a rapid progressive clinical course. And if we look into the pathology, there are more of epigenetic alterations, as you see right in there, and somatic mutations. And regardless, one of the most commonly used treatment approach is radiation therapy, and the median survival varies anywhere between 8 to 12 months. Now, adults typically, the DIPG, the range is typically 40 to 50%. What we really need to understand is the course is very insidious. The disease which you see here is less aggressive. You can find a combination of both high and low grade gliomas. The possible role of epigenetic alterations, again, treatment is radiation, but the median survival you see is typically ranging anywhere between 2 to 4 years across the published literature. Now, in the pediatric age group, for focal brainstem gliomas, the pathology is mostly low grade. Resection is possible whenever. These should be the first option. And of course, radiation should always be used as an adjunct. Median survival again ranges anywhere between 3 to 5 years, and in few patients, few of the series, it was more than 5 years. In adult brainstem gliomas, it's usually focal one is a high-grade glioma. Molecular characterization is just similar to supratentorial gliomas. The treatment is resection, and radiation also is something which can be used. So the next 8 minutes, what I'll be discussing is overview about the different kind of pathologies you can come across, and a little bit of the molecular characterization and how radiation is used, the kind of fractionation protocols. So I do not have a kind of videos which were presented by earlier presenters, but having said that, I don't want to concentrate more on the technical part of radiation. So the first thing which I would like to draw your attention is the focal brainstem glioma. As I alluded to earlier, 80% are low grade, only 20% are high grade. They are discrete, well circumscribed. And when you say low grade, it's usually the pilocytic astrocytomas or the diffuse astrocytomas, rarely gangliogliomas. And majority have a characteristic duplication which involves the BRAF genes in the pilocytic astrocytomas and a mutation BRAF V600E in fibrillary astrocytomas, gangliogliomas, and PXAs. Rarely they harbor the IDH mutations except in the adolescent and the young age group. And tectile tumors undoubtedly present with aqueductal obstruction with raised symptomatology of ICP and nothingel Parinod syndrome. The initial treatment is definitely, yes, ventricular peritoneal drainage and preferably third ventriculostomy. As the natural history is kind of very prolonged, the majority of these patients remain progression-free even without any further therapy. So the risk factors for progression of tectile gliomas typically are persistent, symptomatic, or progressively enlarging tumors greater than 1 centimeter cube, or if there is a contrast enhancement or cystic changes at presentation. These are the kind of clinical context when we advise for radiation therapy. Dorsal exophytic tumors are the tumors which originate from the subependymal glia in the floor of the fourth ventricle and they grow posteriorly into the fourth ventricle. This is essentially extension of the focal tumors. They are again histologically benign. And 60% of these are BRAF positive. And regardless, the first option would be surgery, and the surgical goals intends to establishing the diagnosis, get some tissue for the molecular sampling and characterization, and also enhance survival. Radiation is typically reserved for non-benign histologies and recurrences. The third one is the cervicomedullary tumors. Based on the location where they arise, the medulla, where the epicenter is, you have the histology. What I really need to draw your attention is these tumors typically do not have the peculiar infiltrative capacity because the growth is kind of restricted by the decussating corticospinal white fiber tracts and medial lemniscus, which actually impedes the spread. The last one is the DIPG, which when I say diffuse midline gliomas, the tumor are radiologically, they are poorly demarcated, and the non-enhancing lesion is more than 50% of the brain stem. And the clinical symptoms basically are, the cranial nerve palsies and all the stuff, what you see right in there. The children, the duration is typically shorter than what you see in adults. One interesting thing which we have seen in our patients is discrete facial myokemia and facial hemispasm, which occurs for a period at least 3 to 5 years before the the patient becomes actually symptomatic. I would definitely look forward to the opinions of the other speakers in this particular context, whether this was a common presentation they have encountered. And majority of these tumors are astrocytomas. If biopsy is performed, the adults, 80% is usually low grade. In children, 50 to 60% are grade 4. And nearly 80% are usually, they harbor the mutations, the K27 at the histone encoding genes. Other alterations you see are in the PDGFR genes and also ACVR1 genes. So the problem when with the IPG is they are very diffuse, they are intrinsic. If the diagnosis is typical, then obviously we do not advise for biopsy. But when there is a doubt about the diagnosis, definitely in a multidisciplinary approach, if the surgeon would intend to go and do a biopsy within the safe entry zones, yes, definitely we would advise for it because that will provide a tissue for genomic analysis and also for the testing the newer epigenetic therapies which are kind of evolving, not yet mature. Again, that is more in a clinical trial setting. Chemotherapy absolutely has no role for diffuse midline gliomas. And definitely TMZ can be considered for those where biopsy, you can see some IDH mutant brainstem tumors. So having said that, what I would be speaking in the next 5 minutes is about the radiation therapy. Now, radiation is all about providing effective palliative treatments, and honestly, it prolongs the survival in ranges anywhere between 4 to 7 months. Now, the dose typically we deliver is anywhere between 54 to 59 gray, spread over 5.5 to 6 weeks. Alternative radiation therapy techniques were used, wherein radiation sensitizers, the brachytherapy, radiosurgery. None of them have really added any meaningful difference with regards to the outcomes. Now, the other interesting approach, the earlier approach which I said was a conventional radiation therapy. When I say conventional, it is a single fraction per day. Now, there are alternative techniques which have been used, which were supposed to increase the survival. You know, one of that particular technique was hyperfractionated radiotherapy. When I say hyperfractionated radiotherapy, as I understand many of the audience are neurosurgeons, it is typically delivering 2 fractions per day. And the minimum gap between the 2 fractions is at least 6 to 8 hours. That's the kind of gap which we give between 2 fractions. So essentially, in a week, we will be administering 10 fractions instead of 5 fractions, which are delivered conventionally. Now, across literature, you can see several important clinical trials which have been published, specifically more for POG, CCG, Children Cancer Group. The 1-year median survival range is anywhere between 35 to 48%, which is really meaningful difference. And again, survival for 2 years ranges anywhere between 6 to 25%. Again, this also is varying across the literature, but essentially for hypofractionated protocol, that was the kind of difference. Now, hyperfractionated protocol is little taxing to any radiation department, specifically more in a country like India, wherein we work with loads of patients, wherein we treat a good number of patients outside brain as well. So therefore, it is not really a tangible solution in our country. So what is the alternative option? Hyperfractionated radiotherapy is something which has evolved. When I say hyperfractionated radiotherapy, it is delivering an abbreviated format of the radiation therapy. In conventional, we deliver treatment for 5.5 to 6 weeks. So the patient has to come for 6 weeks, 5 days a week. In hyperfractionated, it will be more number of fractions, but for a period of around 5 weeks. Yet the patient has to come twice to the department and 10 times for the radiation course spread over a week. Now, what we are speaking is an abbreviated format of the treatment, which is like instead of 5 weeks, we are speaking about abbreviating the treatment for 2.5 weeks and with a single fraction. Now, this is logistically more convenient, and how this translates into the kind of benefit is something which was tested in a randomized controlled trial, wherein 70 patients were kind of randomized between 6 weeks treatment and 2.6 weeks treatment. Now, essentially, there is not much difference between a hyperfractionated protocol or a fractionated protocol, spread out fractionated conventional radiation therapy protocol. So essentially, if a choice is given to us, we would be more happy treating these patients in a hyperfractionated protocol, because the technology which has evolved has given us the advantage of protecting the critical structures which are not involved from the high dose gradient. Now, the CyberKnife protocols are still more stringent. We can complete this treatment in just a couple of weeks, deliver 26 gray in either 2 or 6 fractions. And CyberKnife really gives a very good conformity and sharp dose follow, because we'll be using stereotactic cones here for the treatment. And essentially, non-enhancing lesions typically have a much better survival compared to what you see in enhancing lesions. Typically, there were some of the few clinical trials wherein a re-radiation was contemplated for a recurrent disease, as you see right in there, usually using utility histograms wherein the toxicity, severity, and efficacy was kind of factored in. These trials have concluded that in the event, if we contemplate a re-radiation, a 24 gray in 12 fractions is a safe dose for the patient, keeping the utility histograms to what is called as optimal. So to summarize the entire radiation picture, conventional fractionation radiotherapy, the median overall survival, I am speaking about the median overall survival, is anywhere between 12 months. For a hyperfractionated, it was 10.2, and hyperfractionated radiotherapy, 9.6. Honestly, this is all I'm speaking is for progression-free survival, and no difference is seen in the overall survival. So regardless of the fractionation protocols, the difference also was not statistically significant. Now, having said that, let me just draw your attention to how we assess the response when we do radiation therapy. We typically do nerve fiber tractography. Here, this is where all the learning we have done in the last 4 hours is something which is particularly relevant. As we understand the patterns of white matter fiber tract alterations due to neoplastic involvement, these tracts are kind of deviated. There can be edema of the preserved tract. So this will result in some loss of anisotropy, but retention of the enough directional organization so that we can actually localize them in the DTI maps. There can be some disruption of the directional organization of the fiber tracts due to infiltrating tumors, or there can be a complete destruction as well. So let me just draw your attention to 2 or 3 patients whom we have used this particular protocol. And as you see right in there, this was a 7-year kid who had a progressive blurred vision and also choking and coughing and choking when drinking liquids. You can see a pontine lesion right in there. So when we have done a pre-treatment nerve fiber tracking, you can see there is an attenuation of the corticospinal and the transverse pontine fibers. So post-treatment, there was a very good response you have seen for this patient. You can see improved visualization of the corticospinal tracts and the transverse pontine fibers. And 15 months down the line, when the patient had recurrences, you can see how it has happened. So what I would like to draw your attention is, whenever we give radiation therapy, the recovery of the fractional anisotropy across the different white fiber tracts is essentially correlating with the response to the therapy. This was yet another patient with 10-year-old kid who presented with guide ataxia with a lesion. The T2 flare, you can see how beautifully there was a lesion in the pons, which was extending posteriorly into the cerebellar peduncles. And again, you see right in there, nerve fiber tractography, you can see posterior displacement of the medial lemniscus, the transverse pontine fibers, infiltration of the CST and TPFs. Again, a response just correlated with improved visualization of all the tracts, and recurrences, again, decreased visualization and disruptions, as you see right in there. A third patient, yet the same scenario. So the bottom line is very clear. Whenever there is recovery of the fractional anisotropy, this usually happens anywhere between 2 to 3 months. You can see a good response in all these patients. Typically, we do nerve fiber tractography for all these patients. And also, the ADC values typically dropped immediately post-treatment. And again, they increased during the time of recurrences. MRS is also one of the important tool which we use for the response assessment and the prognostication as well. Typically for those recurrences which are greater than 4.5, the prognosis is just dismal. So to conclude, friends, it's very important. Once we establish a clinical radiological impression, if there is an opportunity to do a safe biopsy, go ahead and do that. If the patient is having a pilocytic tectal plate gliomas, you need not do any intervention, close clinical radiological observation. Whenever there is evidence of progression, go ahead and give radiation. If there is a low-grade brainstem glioma, definitely radical radiotherapy conventional or hypofractionated, we can use any of the protocols because the evidence has now evolved about the hypofractionated protocols in using in a randomized controlled fashion. For those lesions which are not amenable for radiation biopsy, obviously the radical radiotherapy is something which can be used. And again, the intent is absolutely palliative, as it will have no dent on the overall survival, and whatever we are speaking is on the progression-free survival. But in future, friends, it's very important, the biopsy which we take, wherever it is possible, there are several molecular characterization pictures which are possible, and the newer drugs are being tested. Thank you so very much for the time allocated.
Thank you, Dr. Shankar, for an excellent presentation. Before I invite questions from the faculty, I would like to ask one question to you.
Yes.
Besides the, see, you have clearly mentioned about most of the time diffuse spontaneous glioma, we directly send for the patient for the radiation therapy. And you have mentioned some cases where the diagnosis is not sure, one can have a invasive biopsy sort of.
Yeah,
is there any,
is
there any non-invasive or fluid biopsy sort of a thing, so one can diagnose on the basis of
there is recently, yes sir, there are few publications which have actually come up very recently, which have used liquid biopsy. But again, in India, we are not using it at the moment because of the cost constraint, number one. And I am not really sure, even Dr. Ali Asgar can highlight on this, if they are using liquid biopsy in Tata Memorial, because I have not come across any centers who are using liquid biopsy in India.
The second thing, you have shown 3 different cases in which there was a response to the radiation therapy. And that you have shown on MRI images. Does that means like patients' clinical symptoms improves over a period of 4 months?
Definitely they improve, sir. They improve very good. But again, as I said, the improvement is only for a transient period. Recurrences are bound to happen in all these patients. What we have noticed is whenever there is a drop in the ADC values, that can be actually picked up prior to the clinical improvement. Usually we time our MR imaging in the 2nd and 3rd month. That's ideally when we are seeing the drop over the initial ADC values and the fractional anisotropy values. Once we capture that, then we are pretty confident that the tumor is going to respond to the clinically as well as radiologically. There will be a clinical radiological response.
Thank you.
Yeah,
Professor Goel is there?
I would like to just ask a question to all the faculty. We have an experienced faculty. My problem is with children, especially in the DIPG. It's very difficult to tell the mother that your child is not going to survive. So whatever you do, whether you do surgery, whether you give radiotherapy, so how do y'all tackle that in your experience? So I would start with Thomas Santarius, because for me till today, I find it very painful and very difficult to explain to a mother saying that your child is not going to make it. So I would like to hear from the experienced faculty. How do you handle it?
Thank you, Vernon. I don't have an answer to it. It is probably the hardest thing we will do, because really there isn't anything we can do. Similarly to Shankar's talk, we don't routinely biopsy something that looks like diffuse brainstem glioma. Yeah, you know, there isn't a perfect way of doing it. However, it where appropriate, if radiotherapy is indicated, and this can be given, you know, as a hope, even if we know that there's going to be the treatment is only palliative. So I think it's very individual how we approach that. Yeah. I usually generally try to focus on positives, and none of us is going to live forever, so we can always find something positive. It depends on the work for the person, and certainly having some treatment, even if palliative, is good.
Any other comments from the...
Yeah, Varnan.
Yeah.
If your question was specifically to talk about the child's health and future to the mother, then in the Indian context, I think it is better to talk to the male member, to the father, rather than the mother. If that's your question, the specific answer. Means I would never talk to the mother. I would talk to the father, and I would ask the father to discuss it with the rest of the family.
I have a comment as well on this, Varnan. One message I would like to give is, no matter how you break the bad news to the parents, never take away their hope completely, because sometimes we tend to act like gods, which we are not. And in fact, I published in British Journal of Neuroscience, in British Medical Journal, one episode from my JJ days in 1991, with Professor Turrell being the consultant at the time. And it's called Shattered Hope. So it's only one paragraph, but if you just search with my name and British Medical Journal and Shattered Hope, this exactly problem, the question I've tried to answer. But whenever I'm breaking the bad news, as Thomas rightly pointed out, there are no easy ways. You have to be very truthful, but at the same time, try to focus on positives and never let the patients, the family lose the hope, I think.
I have a comment, Varnan.
Yeah, please, go ahead.
My experience is the same. I don't think we should be playing God. In a way that scientific things are different. I had a case in Royal Preston Hospital. There was a glioblastoma, clearly a temporal lobe glioblastoma, diagnosed in a 35-year-old male. And they said they will come after a month and a half for surgery. And then they wanted to try some alternative therapy. We said, yes, you please do whatever, because we know many times it's hopeless as far as we are concerned. They came to us after a month and a half, and when we operated, this glioma was completely walled off with a calcified wall and could be completely excised. We followed up for about 7 years without a recurrence. So I think we need to be skeptical of this, and we need to give the hope. At least 98% we can say, 1 or 2% not in our hand. Miracles can happen, do happen. And there is another case of Dr. Jindal. When they came to Goa Medical College with a highly malignant glioma, they said, we want to go to Vailankani for some time. They said, please go, come back for surgery. And in 3 months' time, they came back and he did a scan and the tumor had disappeared totally. This is a living example. The former dean of Goa Medical College can vouch for this. So I think we need to be a little bit easy on this.
Thank you. Thank you very much. Thank you, Batuk. And thank you. Shankar, you want to say something?
Yeah. So just a quick comment, sir. 3 months back, I've consulted a kid who was just 7 months old. And breaking the bad news was a kind of a shock for me as well, because the kid was absolutely cute, and it's too hard to digest the fact that the kid was having DIPG. And surgeon was pretty reluctant. I can't do anything. Radiation is obviously that's not the age in which we go ahead and radiate, or chemotherapy, we know it's just ineffective. Honestly, when I consult the patient, the patient's parent, I made them understand the reality. There was a great amount of reluctance seeking for any hope they have in the life. But honestly, all the hopes we have is closed, and obviously the kid has expired after a month or so. So honestly, yes, the question like this, when you've come into a situation where the prognosis is absolutely bleak, it's very important that every stakeholder is probably addressed to.
Thank you. Thank you, Shankar.
I think
Varun, as Shankar said, empathetic approach, being a person, being a physician, actually goes a long way.
Thank you.
Varun,
Yeah.
Palandia.
Please.
I think it depends on which situation, in which environment you are working. In our environment where we work, where the people come without, means as far as the monetary condition of the patient is not good. Now we have to explain to them everything. That's what I used to do, if you remember, and explain to them the whole thing properly, as Dr. Nadkarni said rightly, to the father and to some responsible people, not to one single person. You should have at least 2-3 people of the family together and tell them the real factual position. And this is what we feel, and this is the present data. Now, you don't know what it is till you take a biopsy initially. And you put to them that even if anything 99%, if there are chances that the patient is not going to survive, there is 1% chance that we may prolong his death, maybe. That should be the way, if we are very sure that he is not going to be surviving after any kind of treatment. And many times, if they are not affording, they say, then we are going to take the patient away. But if they have got some kind of monetary backup, they say, okay, you take the biopsy and do the needful, and then we'll see what to do. So you should not keep them in the dark. That is what I feel.
Yes, true. Yeah. Thank you. Thank you, sir. And I think we shall end this session. And Dr. Abida would be doing a dissection. We still have 498 delegates still logged in. Have not left. So, Abida, are you there?
So there were few questions. There are few questions. So can we have the question and answer?
Till,
yeah.
Can you tell Abida to be ready? Dr. Abida? Yeah, she's ready. Abida is ready. Abida, are you ready?
Hello, sir, can you hear me?
Yeah. Yes,
can you hear me? Okay, okay. Hey, I'm ready. I'm ready.
So please go ahead.
Okay. Okay, so...
start. Abida, you can start.
Okay, sir, just tell me if I'm audible. Am I audible?
Yes, yes.
Okay.
Yeah, we can hear you.
Okay. So this is a cerebral hemisphere where all the gray matter on the surface I have already removed because it takes quite a lot of time. And all these connections that you're seeing now are the connections of the short arcuate fibers on the cerebral hemisphere. So this is your region of your pre-central gyrus. This is your region of your post-central gyrus. So this is just to give you an overview of how the cerebral hemisphere looks after removal of the gray matter. This is the anterior. This is the Sylvian fissure. This is the region of the insula. This is the temporal lobe. And this is the occipital lobe. Now, since Pablo has shown most of the lateral dissection, I will start from the medial side. So this is the medial view of the hemisphere. This is anterior. This is posterior. This is superior. And here, of course, you can see the brainstem, that is inferior. So I've already started dissecting here in this region. This is the region of the cingulate gyrus has been removed here partially. And now I will remove some more to expose the cingulum completely. As you can see that it is coming here. So this is the cingulum that is going all the way behind the splenium of the corpus callosum. And you can see how these fibers are turning here. And this is the connection of the cingulum as it goes up into the parietal region. Now we'll continue the dissection in the temporal region here.
Can you tell us where you are now? Abida, can you tell us where you are now?
So you can't hear me?
I can hear you. Yeah.
Yeah.
Just tell us where, at what area you are.
Temporal horn, sir.
Okay. Fine.
This is the medial aspect of the brain. So
okay,
this is
fine.
Now this is the corpus callosum, this is the frontal, this is the occipital, this is the temporal region. So I have traced the cingulum into the medial aspect of the temporal lobe. So here the parahippocampal gyrus was there, which has been removed here.
Okay, good.
So this is radiation of the cingulum ending here in the last portion of the parahippocampal gyrus. See, there is some residual parahippocampal gyrus here, gray matter, which I am now removing.
Good. Yeah, we can see it now clearly.
Yeah.
Yeah.
So now I will show you this, how this radiation of the cingulum, I am depressing that and I have entered the temporal horn.
Okay. So can you zoom in a bit? Can you zoom in, zoom inside? Yeah, that's good. Yeah. And focus, please.
Yeah. Okay. Can you see it now, sir?
Yes.
Okay. So now these projections that you can see here like teeth, you can see these, sir? That's
yes.
the dentate gyrus. That's the dentate gyrus.
It's nicely seen.
Yes. And this is the region of the head of the hippocampus here. The brainstem is in the way here, but if I lift this brainstem, you can start seeing the head of the hippocampus here.
Yeah.
Can you see it, sir?
Yes. Yeah.
Yeah, I'm depressing it now. This is the head of the hippocampus.
Yeah.
Now from the head of the hippocampus, this white tract is starting, this white fibers here.
Mm-hmm.
So this is the alveus and this is the fimbria of the fornix, this white tract here.
Okay, good.
Can you see that, sir?
Yes, yes, we are seeing it clearly.
Okay, now the fimbria of the fornix is going up. I'm tracing it around the thalamus. So this is my choroidal fissure and I'm tracing the fornix around the thalamus here. I'm lifting it here and you can see the body of the fornix here.
Mm-hmm.
Just beneath the corpus callosum.
Okay.
Wait, I'll focus it. So here, this is the body of the fornix and going all the way into the columns of the fornix.
Yeah, that's nice.
Okay, sir. Here, if I depress the fornix here, you can see this layer here. This is the region of the hippocampal commissure, where both the fornices will connect to each other. This region here.
Mm-hmm.
Now I'm tracing it into this region, that is the mammillary body here. So the fornix is ending here in the mammillary body. Can you see that, sir?
Yes.
Okay, now if I start removing the gray matter of the thalamus in this region, I will start seeing the mammillothalamic tract.
Yeah, so do that. Do that.
Yes, sir. Here it is. Can you see it, sir?
Yes, we are seeing it nicely.
So the mammillothalamic tract is going all the way to the anterior nucleus of the thalamus here.
Yeah, you can see it.
You can see the whole tract here. I'm removing some more gray matter of the thalamus. So now it will end here. The mammillothalamic tract will end here in the anterior nucleus of thalamus here. And now to trace it further, I'm going near the caudate head. Okay, sir? This is the fornix. This is the caudate head in the ventricle frontal horn. Now what happens is from the anterior nucleus of the thalamus, there will be fibers that will come here. So when I lift the caudate, these fibers that you can see now are your anterior thalamic radiations.
Okay.
See, sir, these fibers that you can see here now.
Yeah, we can see them nicely.
So this will go all the way and connect to the cingulum above to complete the loop of the Papez circuit.
Okay.
So if I cut this part of the corpus callosum, then I will get this connection here. Blade.
Yeah, show it, show it.
These are some corpus callosal fibers as they're turning. See, sir, these fibers here, the corpus callosum goes beyond, beneath the cingulum, and it will connect to the, go lateral here in the cortex. So that these are those connections of the corpus callosum.
Got the caudate nucleus out now.
Yeah, caudate nucleus is here. It is lifted up here. Okay. I'll remove it only. This is, I've removed the head of the caudate.
Okay, that's nice. Yeah.
So now I'll cut these fibers also. So there you are, the anterior the thalamic radiations now more clearly seen.
Yeah.
Here. So this is your medial aspect of your projection fiber, sir. If you come from medially, this is your end. After this, on the lateral side, there will be the internal capsule. Micro scissor there. Micro scissor. It's really there. It's there in that.
Abhida, you can use that laser light to show what you have dissected.
Okay, sir.
That is nice. You can see, use the laser light and focus on what you have dissected.
Yes, sir. So here, so this is the cingulum now here, this portion, and there are some fibers of the corpus callosum here, and these are the anterior thalamic radiation as they are entering the cingulum from inferiorly here.
Okay.
You can see them here.
Yeah, you can put that
Focus
laser
it.
light there. Yeah.
Okay, sir. These are the anterior thalamic radiation as they're going all the way up to the cingulum here. So here you can see the cingulum connection. I've removed this part of the corpus callosum.
Nice.
Okay,
nice.
sir.
Yeah, nice.
So now what I will show you is, I will show you some fibers of the corpus callosum from posteriorly. Focus it.
Zoom out a bit slightly.
Yeah.
Yeah. Yeah, that's good. That's good.
Okay, so now this is the posterior end of the corpus callosum. This is the splenium. This you can see is the cingulum. So now if I dissect here more in this region, I've dissected and kept. So you start seeing the forceps major in this region. Okay. Wait. So from the corpus callosum, these are the fibers that are going posteriorly. So you can see this. These are the fibers of the forceps major.
Okay. Just focus that light, please, on the forceps major. Yeah. That's nice. That's nice. Yeah.
Okay, sir.
Yeah.
And then this is as it is going up to the cortex. Now the same way on the medial aspect of the hemisphere, once you cut the cingulum, or when you lift the cingulum from here, so these are still fibers of the cingulum.
Yeah, Abhida, go slightly on a high magnification and focus in. You can see them nicely. Yeah. That's good. That's good.
So these are the some cingulum fibers that I've now removed. Okay, because I want to show you the corpus callosum fibers. These are fibers of the cingulum that I'm removing. And you can see here now, sir, beautifully.
Yeah.
Show me the first 1 minute, sir. Specimen pakad, 1 second. Pakada.
Now go on a higher magnification.
Yes, sir. Yes, sir. 1 minute. So there, leave it. So these are the fibers of the corpus callosum as they go up and join this portion of the corona radiata. Here you can see this connection. These are the dorsal corpusal radiation, callosal radiations as they go up. Can you see them, sir?
Yes, we are seeing them.
Here you can see the fibers here now, sir. All these are the corpus callosum fibers as they go up towards the corona radiata. This is the corona radiata.
Nicely seen.
So this is the portion of the medial aspect of the hemisphere. Now I'll show you some little bit of the inferior aspect of another hemisphere.
Go ahead.
So sir, this is to orient you. This is the inferior aspect of the hemisphere. So the preliminary fiber dissection I have done. So if you see from anteriorly, this is the corpus callosum. Okay. I'm turning it. This is inferior. So you have here the optic chiasm and the tract. Okay. So now here, this will be the region of the lateral and medial olfactory striae. This is the most inferior part of your frontal lobe.
Mm-hmm.
Now in this side, I've removed that gray matter to start showing you the anterior commissure. Now you can see it here.
Okay, yeah. Nicely seen.
This is how it goes on both the sides. So what happens in this region, sir? All this gray matter that you're seeing here, this anterior commissure has been cut a little bit here. All this gray matter that you're seeing here is the basal nucleus of Maynard, the substantia innominata and the basal nucleus of Maynard.
Yeah, can you show it again, please?
This gray matter here.
Put the
Where
red.
the red light. Yeah.
That's nice.
So this gray matter in this region, in the region of this is the anterior commissure. If you imagine, this will be the anterior perforated substance in this region. When you remove it, the gray matter in this region is your basal nucleus of Maynard or the substantia innominata.
Okay.
Okay. Now, from lateral, we have seen the uncinate and the IFOF. Now, I will show you the frontal connections of the infinite and the uncinate and the IFOF. So now, this is also some little dissection that I have done. So this is your lateral aspect of the hemisphere. The insular gray matter has been removed here. You can see the arcuate fasciculus here.
Okay.
That is turning like this down in this region and ending here. This area where the IFOF begins, so in the inferior aspect here. Can you see this? These fibers.
Yes, yes.
These are your frontal fibers of your IFOF, which begin in this region, and they go, and this is your region of your Lyman insulae, this portion, where you have the uncinate here. So the red dot is now on the uncinate fasciculus here, and the superior one is your IFOF, which is running just beneath the arcuate fasciculus here.
Okay. Nicely seen. Nicely seen. Good demonstration.
So this is, I'm dissecting more, and you can see the IFOF going posteriorly now here in the temporal region. I'm following the IFOF into the sagittal stratum. Now you can nicely see it, the IFOF that is coming from here and going all the way posteriorly. I will see if I can.
Can you show the whole extent of that?
Yeah, sir. Here it is begin in the frontal lobe here. So this is your hemisphere.
Yeah. So trace
the inferior. Inferior aspect of your frontal lobe, which is beginning here, in frontal aspect, going in the region of the Lyman insula here. Here the uncinate is down, and this is your IFOF going all the way posteriorly into the temporal region here. You can see these fibers, sir?
Yes, clearly. Nice.
And going all the way posteriorly where they will form the sagittal stratum, a part of the sagittal stratum, and they will cover the here. I'll have to lift the arcuate for this. I'm lifting it now here, and you start seeing the fibers of the IFOF if you trace them nicely.
Nicely seen, nicely seen. Yeah, Abhida, tell us what you're doing.
Okay, sir. I was just dissecting a bit of the IFOF to go beyond to the optic radiation.
Because this dissection is for the sake of exam going residents also. So we still have 490, I think we have crossed 500, 501 delegates still have are logged in and are watching you.
Okay, sir.
So for the sake of exam going residents, second year residents, explain what you're showing to them.
So these are the fibers of the optic radiation as they're going into the occipital lobe. You can just see the beginning of that now here.
Beautifully seen, beautifully seen.
So this whole thing here, sir, the IFOF and all these layers, basically there are a series of layers. That's why it is called stratum. This is your sagittal stratum. Once I peel off one, then we'll have, they're not very easy to peel off also sometimes because they form a very deep layer. So you can see some fibers that are coming here. These are the fibers of the optic radiation, sir.
Yeah. Nicely seen.
So there you have the whole sagittal stratum and the fibers that are seen here. Now let's go to the insula a little bit. So this is the first extreme capsule of the insula. So we'll just peel that off. So you start seeing the dorsal portion of the external capsule in this region, sir. So this portion is called ventral external capsule and this portion is called dorsal external capsule.
Please
Can you see that, sir?
No, show it with a laser light for the sake of the residents.
Yes, sir. Here it is.
Yeah.
So this portion is the dorsal external capsule.
Because many times these sections are asked to be explained at exams.
Yes, sir. And now this, what I'm removing here is the putamen.
Okay. Please show the putamen with your laser.
This one, sir.
Yes. Okay. No, this is for the sake of the residents
yes, sir.
in PG.
Yes, sir. So, sir, this should be dissected very nicely. So, this will take time. So, I'm just going to show you how it looks. I have already a dissected specimen ready.
Yeah.
Show me that. So, again, this is a dissected specimen, sir. So, these are fibers of the corona radiata. Okay.
Okay.
These here. This thing that you're seeing on top here.
Okay.
Is the superior longitudinal fasciculus, the lateral part of the superior longitudinal fasciculus, SLF2 and SLF3, this whole thing.
Nicely.
You can see here, the red dot. Okay.
Okay.
Just beneath that, you start having the arcuate fasciculus. As you can see it going all the way around the insula. So this whole thing is the arcuate fasciculus, which I'm just lifting now. Okay, when you lift the arcuate fasciculus, you start seeing the IFOF, which I showed in that specimen. So this is the frontal portion of the IFOF, and this is the Lyman portion of the IFOF, and this is the posterior portion of the IFOF here.
Nicely
okay, sir?
seen.
Yeah, and this is the ventral external capsule, and these are fibers of the dorsal external capsule.
Yeah.
Now, what happens to these fibers? Once we remove them,
okay.
This is what happens. Once you remove the putamen completely, you'll start seeing the internal capsule. I'll show you in another specimen, but this is just to show the dorsal external capsule. You can see these fibers that are going up here.
Yes.
So what happens is the dorsal external capsule merges with the internal capsule, which is just beneath the putamen, and they come ahead and form the corona radiata.
Okay.
They come together and form the corona radiata on top here.
Beautiful, beautiful.
Right, sir? And
yes.
These are just another view, sir. All the fibers of the corpus callosum that you can see here.
Yes.
As they are turning up and joining on the medial aspect of the corona radiata.
Yeah, it's such beautiful anatomy, and I think all of us should appreciate this anatomy And of course, the dissections where there's such layering of the fibers. It's an amazing.
And sir, when you remove the whole putamen, this is your whole internal capsule.
Yes.
Okay, so this is your anterior limb here. Can you see it, sir?
Correct. Yeah, nicely seen.
This is the genu. This is your posterior limb.
Okay.
This is your retrolenticular portion, and this is your sublenticular portion. So these are your proper optic radiation as they're ending in the occipital lobe. Here you can see them clearly. And this most part will be the Mayer's loop.
Can you show that, the Mayer's loop? Because many times an exam question is asked to the students.
So Mayer's loop now, basically, see, this is your optic tract.
Correct.
It will end here. It will end here in the lateral geniculate body.
That's true.
Here. So Mayer's loop basically begins from here.
Okay.
Goes all the way around the temporal horn here, and then curves and goes in the roof and lateral wall of the temporal horn here.
To see that arrangement, it's a beautiful arrangement. One can appreciate. See, beautiful.
Yes, sir. Yes, sir. So this is from the lateral aspect. When you go, this will be your end. Your internal capsule is the end from the lateral aspect of your hemisphere. When you come from the medial aspect, as I showed you earlier, the anterior thalamic radiation will be the end. And both of them end and meet as the projection fibers. So from medial, you have the anterior thalamic radiation. From laterally, you have the internal capsule. And they meet here and form the projection fibers, which are projected up as the corona radiata.
Okay. Nice.
So this is another specimen, sir. I've just dissected here also. You can see the whole mammillary thalamic tract that is lifted here, anterior nucleus of thalamus. And these are the anterior, if you lift the head of the caudate, this is the anterior thalamic radiation. And this is another specimen.
Nice, nice.
So from medially, anterior thalamic radiation, from laterally, the internal capsule, and that's the projection fibers. So what basically, when I was classifying them, what we are saying is that this projection fiber is in between. You have some fibers that are medial, lateral to it, and some fibers that are medial to it. And the medial part will be your cingulum, your medial part of the SLF. So this fiber bundle that is on top of the cingulum, this fibers here, that is your medial part of the SLF. So this is your cingulum, and this is your medial part of the SLF. So these will be the fibers on the medial side of your projection system. And on the lateral side, you will have your arcuate. You will, like you have seen in this specimen, you will have your arcuate, you will have your SLF, and those fibers.
Nice.
So that is the middle layer of the fibers. And this is my vertical group. And earlier I showed you the short arcuate, short association fibers or the short arcuate fibers.
Beautiful.
So that's, yes, sir. So that's it, unless you want me to show something else.
No, but this is good enough. And I think you have done a great job. I admire your passion for this dissection. You have to have passion and
patience.
Appreciate you being there so late in the night doing this for all of us and for all the students. Thank you, Abida. I appreciate it a lot. And thanks to the dissection which you have shown. So
Thank you, sir.
Any comments from the faculty?
You said passion. I would say passion with patience.
Yes, true. Yeah, and I think if you do not love the brain, you will never respect the brain. That is what I feel. You have to develop a love for the brain and appreciate the beautiful anatomy which nature has made. And I think Abida is doing a good job. And congratulations to you, Abida.
Thank you, sir.
Thomas, you want to say something? Thomas.
Well, really beautiful dissection. I appreciate it's quite late in Mumbai, but it was worth staying for. And as Pablo said, you need to do it many times.
True.
Before you get sleek in it on the cadaver, and clearly Abida is very sleek and doing it on the cadaver, and I suppose then. This way you understand the concepts, and when you then operate on a patient with pathology on top of it, there's another level or two to be able to understand what we're looking at, where we are. But without understanding normal anatomy, there's no chance of doing a good job, as it was said many times by other speakers today. What's going on intraoperatively. So yeah, that's an absolute fundamental thing for us to do. And thank you for doing this for us, Abida.
Thank you. Thank you. Thank you very much.
Thank you all. And I would like for Rishikesh to take over, because we are towards the end of the session now. We had this special session of cadaveric dissection by Abida also. And Rishikesh to give us the word of thanks.
Thank you, sir. So that brings us to the culmination of a wonderful academic fest, a wonderful webinar with a live dissection of white fibers. So it's a privilege to propose a vote of thanks. I, on behalf of Department of Neurosurgery at Grand Medical College and Sir JJ Group of Hospital, extend sincere thanks to all the speakers for sharing your knowledge, work, and opinions with us today. I thank our chief guest, Dr. Mankeshwar sir, our dean, for his support and encouragement in organizing this international webinar as a part of celebration of 175 years of JJ Hospital. I thank Dr. Kishore Shetty sir, the MMC observer, for sparing time for us and being live with us. A big thank you to all the speakers for their wonderful presentation. Special mention to Dr. Abida Shah madam and Pablo for a wonderful white fiber dissection. I'm sure the dissection and the presentations will be very inspiring for all the delegates who have been there with us throughout this webinar. I would like to thank all the moderators who are all esteemed teachers for sparing time for us and making this webinar academic fest for all the delegates. And finally, I would like to take this opportunity to place our hearty thanks to Sun Pharma for their logistic support to us. I would like to thank BNA, NSI, and Goa Neurosurgical Society for their enormous cooperation in organizing this event. So once again, I would state that we are most grateful to all the speakers, moderators, and delegates for being part of this international webinar. Thank you. Thank you very much.
Thank you. Thank you.
Thank you. Can I just say a special thank you to Professor Velo, who spearheaded the meeting and created the opportunity for many of us to learn many things. As I said, we couldn't be physically in Mumbai, but it was fantastic to be there, at least via the internet. And I'm sure Professor Palander is retiring with a good feeling of leaving the department in such capable, inspiring hands of Professor Velo.
Yeah, sure. Because Velo has done a very good job of teaching and especially allowing the younger people to speak on the topics. That's a very good thing which he started doing it. And I think the residents and the junior staff should take advantage of this kind of seminars which Dr. Vernon is regularly organizing. This was a very well organized and almost perfect webinar today. Thank you, Dr. Vernon, for involving me and giving such a good feast to all of us. Thank you.
Thank you very much, Vernon, and all the team. You've got a superb team working with you. And I maintain JJ Neurosurgery is one of the best places to work in the world.
Sir, you are mute.
Kishore, this is your cupboard, which you have donated to the office. So we have done it up and we have kept it as a reminder and a remembrance. You see the showcase behind?
Yes, indeed. Yes.
That's yours. Okay.
Oh, it's a pleasure. Thank you.
Pablo, can we have you? Pablo.
Here I am. I'm here.
Unmute. Carry on.
Can you hear me?
Yes, please.
Well, I'm sorry, I'm in the car and I want to thank you again for your invitation. It has been a long day, but it looks like a repetition, but today we have learned a lot from each other, and I thank you for putting this amazing program together with this fantastic team. Thank you very much.
It was a pleasure to have you all also with us. Yeah. Dr. Batuk? Is Batuk around? Dr. Batuk? So I think if they are not around, I would like to say thanks from the bottom of my heart to everyone who has taken part in this workshop and live webinar. And everything went on as we wanted it to go. And thank you for that. And thanks to the delegates. And we had more than 1,000 registrations. Until the end, we had 521 people logged in continuously, which is a good morale boosting thing for us. And I'd like to thank my department, the team of my department, my residents, my nurses, my lecturers, and my associate professors, because this cannot be a one person who can do this. And thank you. See you all. Have a good weekend. And good night from here. Thank you.
See you soon somewhere.
Yeah. Harish, if you want, you can close. Is Harish there? Rishikesh?
Yeah, he's there. Harish?
Yes,
Harish?
sir.
Yeah, please
Yeah.
close.
Yeah. So that was quite a wonderful sessions, all put together. So hope all the neurosurgical residents benefited from it. So with that, and we'll say bye.
Good night. Good night.
Please,
Good night.
Yeah.
Bye.
Good night. Good night.
Stay safe.
Good night. Bye-bye. Bye-bye, Tom.
Bye.